We could start with the, okay.
How long do you want to talk for introduction? 2 minutes.
3 minutes. Those are the things that I wanted to hit.
So we can probably just as you like. You can start now to sit. Sit down. Sure, take your time.
Oh, yeah, I can sit down there.
No, I think that this would be fun. Yeah. It's okay.
Because then,
We were just going to introduce the meeting to get it started, and then we'll turn it over.
So we're going to ask questions.
hello.
Good morning,
Hello.
Halle.
Hello.
David
Good to
Clemens,
see you.
a pleasure.
Would you like to lead off a little first and alternate, or how do you want to do this? How do you want this?
Probably alternate would be nice. That way we can have some variation. But if anybody has a specific question, you know, we can kind of go in as well.
Okay.
Yeah. Just, you know, maybe you can begin with the first one and
Yeah.
then, yeah.
Will do.
Show me what I have to do.
But you don't know.
It's nice to see you.
Great to see you. We only get to see each other in this meeting.
Yes.
Okay,
We
I
both live in
understand.
the same city.
Ah, yeah, I understand. Yeah.
But it's never, you know, you only see each other at meetings, which is crazy.
Good morning. I'm Michael Sorrell. I'm assisting also with IT staff. I just wanted to say to you for the first session, you have all presentations, expect the one from Professor Afifi. So in case he doesn't show up on time, we're going to switch him with Professor Clemens. Okay?
Okay.
So I'll make a sign to you, or I'll just come here and let you know.
Do you have a program?
Yeah, everything is done. And you have it there.
Okay, perfect. Okay.
I just, giving
Yeah,
you.
yeah.
And then Professor Nahabedian is joining on Zoom. Nahabedian
Yeah.
is supposed to join on Zoom. We have a pre-recorded presentation of him, and it's also written on
So
your
it's
instructions.
pre-recorded, but then he'll answer
He will
questions.
join to answer questions. He hasn't joined yet, but I will also let you know that.
How much time do we have for questions?
So you're gonna see the timer there. There's gonna be 11 minutes of presentation and 4 minutes of discussion. So we're gonna give you the time in there, so you
Maybe
know
he
when
needs
to
a
stop
wake-up
the
call.
discussion in case it goes too much.
Just being polite and going on
We
to the
have to
next
be
talk.
exactly. We have to be very.
Very nice.
We have to be very.
Cut me off if I start drowning.
Well, I heard that there's a button and then the floor drops out.
Yes.
Exactly.
But drop into the still would you like to?
And you can see that live on YouTube.
We have about 2,000 people watching.
Oh, wonderful.
Then when we go start.
Reassuring.
So, ladies and gentlemen, take your seat.
At 15.
Thank you very much for coming. We will open this Congress, which is the 8th International Breast Surgery Workshop and Forward Work Consensus Conference on BIA-ALCL. And we are here in Houston, so thanks Houston for the hospitality. Why in Houston? Houston was founded in 1836, and it's a well-known city called as the Space City. But we are here not because of the Johnson Space Center, which is based here. We are not here because of the well-known oil-based economy of this city, very rich city, but we are here because of the Texas Medical Center, which is the world's largest medical center and research facilities and assistance also facilities. And I have the honor to open this meeting together with Mark. I want to give you a little bit of background for those who doesn't know about the International Breast Surgery Workshop. That was based 14 years ago. So it's an appointment that we go on after 14 years. And it's mainly based at collecting a faculty of a very high standard level. Mark and myself, we go around many times for traveling for meetings, and we try to collect the best speaker. We try to collect the most interesting news and presentation around the world, and we bring it together in this meeting. That creates a unique opportunity of having a very fantastic faculty, with a total age index of 1,515. So it's a very high standard of quality of science. This is what we sell to our customer, this is what we sell to our sponsors, and we offer for free on streaming. So I'm sure you will enjoy, and since recently, of course, since 4 years, we implemented the program with the Fourth World Consensus Conference on BIA-ALCL, keeping in the program the best science about this difficult disease. Hope to find a solution as soon as possible. So I give the microphone to my co-chairman, Mark, to give you some further information. And thank you very much for coming from all over the world and from very far away here. Thank you.
Thank you so much, Fabio. I first want to start by thanking my co-president, Fabio Santanelli, as well as Dr. Michael Sorotos, who's part of our program committee. It's been absolutely instrumental to all aspects of this. Also, our organizers, which is Diana Marshak, Carlotta, Erica, Jenny. We couldn't do this absolutely without you. I'm so excited to welcome you finally to Texas. From the very first inception of this meeting, we wanted to bring this to MD Anderson. COVID kind of stood in the way, but we were finally able to get it done. And as people have come up to me and said, this is my first time in Texas, this is my first time in the United States, I'm struck by when I first came to this city 12 years ago as a microsurgery fellow. And I remember saying, to some of my co-faculty, this is my first time in the South in the United States. And the response was, no, actually, if you want to go to the South, you need to go north of here. You're in the Republic of Texas now. And it's kind of our mindset that I think you'll see brought to some of our panels, which is that kind of rebellious spirit, that independent mindset that you see in the Republic of Texas. I also wanted to note that there's some things that you're not going to see as part of this presentation. You're not going to see panelists talking about things that they've never seen, diseases that they've never encountered. I see at some meetings where you see an entire panel of presenters talking about things like ALCL, and not a single one of them have ever seen a case. When we came up with this meeting, there's a lot of breast meetings around the world. What was going to make us different? We wanted to focus on who was writing the manuscripts that was driving our field forward. We started with an idea of really looking at impact factor and H-index, and really saying who was writing all of the papers so that we could lend a voice to them. The other thing that you're not going to see is panels by men talking about women's health. We need to stop that. Every single panel, every single panel that you see today will have women's voices as part of it, as well as underrepresented voices that traditionally we haven't heard from. We have done it intentionally, and we are stronger for it. What you will see at this meeting is a couple of our themes. The first one is accurate data dispersed globally. We did something kind of crazy with this meeting in that we delivered it for free to anybody who wanted to register for this worldwide. What was the effect of that in past years? Last year, we had 2,500 attendees in real time, and by the end of the month, we had 8,000 unique eyeballs on the conference. This meeting, with pre-registration alone, we have about 140 people in person and over 800 registrations, and I'm sure that we'll see that number increase as the meeting progresses. It's really important that we're not just coming up with algorithms and outcomes, but that we disperse that information, because an algorithm in a paper means nothing if nobody reads it. And so key to that was giving that information away. To that, we could not do that without our sponsors. And so I want to also acknowledge our key sponsors at the highest level, our diamond sponsors, which was Allergan, Mentor, our platinum sponsors, which was Motiva Establishment Labs, our gold sponsors, MTF Biologics and Sientra, our silver sponsors, Stryker, our bronze sponsors, Bridget, Decomed, and SIA. And really important is a lot of times you'll see some small meetings where it'll be specific to a single manufacturer, almost as if that manufacturer's really kind of created the agenda for that meeting. It's not going to happen here. All of these people, these companies contributed to this meeting, and none of them had editorial content on any aspect of the panelists. In fact, you'll see at times where people were presenting and kind of contradicting maybe some of the things from those companies. We welcome that. We welcome open discussions. We welcome dissenting opinions because we want to have those conversations here. And so the other thing that you'll see is that this meeting is about setting tomorrow's standard of care. So we all know what we're doing today, but we want to see what we're going to do in the future. You're going to see a lot of our panelists committed to presenting unpublished research. I'm doing it in my presentations, and we've seen it in past years where a lot of the presentations that you're seeing have not made it in publication yet. We want to have a dedication to showing you unpublished data of what's to come in 6 months and in 6 years. Our faculty was chosen for their excellence, not their excellence meaning their ability to be perfect. We're all going to show our complications. Our excellence meaning those that exemplify a desire to always strive to be better. And with that, we open the 8th International Breast Surgery Workshop and the 4th World Consensus Conference on BIA-ALCL. Thank you. I guess I'll go ahead with the first panel. Our first panel is going to be implant-based breast reconstruction. And our first speaker will be Dr. Cordeiro, speaking on the impact of radiation on 2-stage implant-based breast reconstruction. Thank you, Dr. Cordeiro.
Good morning. I just wanted to add to just some instructions for the audience and the speakers that we're keeping a bit of a tight timeline. We're looking at presentations to be 11 minutes with 4 minutes of discussion because everything is getting recorded and it's an online presentation as well. So I just wanted to remind everyone about timing.
Thanks. I guess I'll speed through this. Thank you, Fabio and Mark, for the invitation. It's always a pleasure to be at this incredible meeting. This morning I'm going to talk to you about the impact of radiation therapy on 2-stage implant breast reconstruction, a topic that I've been extremely interested in for at least 2 decades, and I'd like to share some of my experience. These are my disclosures. So PMRT, or post-mastectomy radiation therapy, has become increasingly common for patients with advanced breast cancer. And over the past 2 decades, my approach to implant-based reconstruction in patients who receive PMRT has certainly evolved. About 20 years ago, back around 2000, we were faced with a dilemma. What happens if you have a tissue expander in place and you need radiation? Do you remove the expander? Do you convert to a delayed reconstruction? And what if you know pre-op that the patient will receive post-op RT? Do we delay the implant reconstruction? Do you reconstruct with autologous tissue and then radiate the flap? And then what if the patient is not a flap candidate? So we sat down with the oncologist, the radiation oncologist, the breast surgeons, the entire team, and I think this is always a multidisciplinary approach to come up with some kind of a solution. And the solution we came up with, and this algorithm we've followed now for at least 2 decades, was to go ahead with placing the tissue expander, start expanding early post-op, expand during chemo because most patients got adjuvant chemo, and then do the exchange about 4 weeks after chemo, and then radiate 4 weeks after the exchange. So that's been well established in my institution for many, many years, and we've followed it. Now, more recently, in the past decade, we've had more and more patients getting neoadjuvant chemotherapy, and if they've already had their chemo, then when they had the mastectomy and we placed the tissue expander, we rapidly expand them, and there's not enough time to expand, wait a period, do the exchange, wait again. So we decided to radiate the tissue expanders about 8 weeks after placement of the expander and full expansion. We then do the exchange 6 months after completion of radiotherapy. And we've also followed this, this algorithm now for at least a decade. So there are 2 algorithms that get applied depending on what the patient is receiving in terms of their oncologic treatment. Now the question becomes, how does PMRT impact outcomes in patients with implant-based reconstruction? And when you look at the literature, there are many problems because surgeons report variable outcomes. They focus principally on surgical outcomes and just loss of the reconstruction. There's relatively little information on aesthetic results and on patient-reported outcomes. And the question, if you're doing 2-stage reconstruction, is what's the optimal timing, radiation to the expander or radiation to the permanent implant? This is a systematic review that basically came up with the same conclusions. These are most of these studies in literature are retrospective, small numbers, lack of a control group. So in order to answer this question, we turn to our database, and I see patients yearly for 10 years and then every 2 years, record outcomes, aesthetic outcomes. Since the advent of the breast queue about a decade ago, all patients fill out the breast queue, and I'd like to share with you that experience. So over about a 2.5 decade experience, 6,000 implant reconstructions, over 4,000 patients. In yellow, you can see the groups that get radiation, and about 12% get radiation to the implant and about 7% radiation to the tissue expander. So a total of at least 20% of my patients over the years have received radiation to either the expander or the implant. Now, we decided to look at these 2 algorithms and compare outcomes. So these are the 2 principal algorithms. We looked at all implant reconstructions over a 10-year period, which is a time period during which we were doing both, using both algorithms. And as I said, we have prospectively collected outcomes. Just so that you know, all these patients receive tissue expanders and implants with total musculofacial coverage. So it's muscle above, sort of fascia below. But I think this certainly helps with the outcomes in these patients that are receiving radiotherapy. The radiation technique is quite standardized at our center. As I said, I evaluate patients for capsular contracture, aesthetic results once a year. We also have the data on implant loss, implant complications, failures. And then there's also data now from patients utilizing the breast queue. Capsular contracture is the modified Baker classification system, and I'll show you some examples of these. The breast queue, we principally looked at 2 modules, satisfaction with breast and satisfaction with outcome, and I'll show you some of that data. So over that 10-year period, there were about 1,700 reconstructions, of which 94 patients got radiation to the expander and about 200 to the implant. If you look at just reconstructive failure unadjusted, you can see that non-radiated patients, about 4% lose their implant, radiation to the expander 18%, and radiation to the implant 12%. And although this is a reasonable way to look at this, and there were statistically significant differences, I think a much better way to look when you're looking at outcomes is to do a Kaplan-Meier analysis to look at survival of the implant. So the top curve in green, about 95% of patients at 6 years still had their implant non-radiated. If you radiate the implant, 83.6%, and radiating the expander, 68%. So certainly your odds of losing the reconstruction if you radiate the expander is higher than with the implant, and any kind of radiation increases your chances of losing the implant at the end of the day. And this just shows you the odds ratio with either radiating implant or tissue expander is certainly higher than non-radiated implants. When looking at capsular contractures, the columns on the left are non-radiated patients, middle radiation to the expander, On the right, radiation to the implant. You can see that the darker blue bars, certainly radiating the implant, your odds of getting a grade 3 or 4 capsular contracture is higher than radiating the expander. In looking at aesthetic results are a little worse radiating the implant versus radiating the expander. And in both cases, radiation does impact the aesthetic outcomes. What about patient satisfaction? You can see that there's really no difference in the breast Q scores in any of the categories, whether you radiate the expander or the implant. So in other words, patients actually don't really know because they haven't seen all the different varieties of options. It's still important, but there's no difference. So just to show you some examples of what these reconstructions and radiation look like. Here are patients, this is a patient who, with acute radiation change, you can see the discoloration, many of them blister, they look terrible. But about 6 months later, on the right, you can see that most of that has totally resolved. Here's a patient pre-radiation, during radiation, and here she is after. And certainly she's got a bit of a contracture on the right side and some mild discoloration, but I think many of these patients actually do quite well, and given that they have advanced disease, we still think it is very worthwhile reconstructing them, because otherwise they'd go without a reconstruction. What about complications? Certainly, whether you radiate implants or expanders, you can end up with something like this, and this is where you end up losing the implant. Exposure, another reason to just remove the implant. These patients usually later come back for a flap. Grade 4 capsular contractures, these are some of the worst I've seen. And remarkably, every one of the patients I show you here insisted on keeping their reconstruction. And I think it's a different mindset, and it points to why it's important to still reconstruct these patients, because they're still very grateful. Grade 3 capsular contracture, moderately distorted. You can certainly see the difference between the two sides. Grade 2s, very mild distortion, and this is a majority of the contractures that we see with radiation, so I still certainly think it's worthwhile. I'm not sure which side, the right side's radiated on this one. And then grade 1s, it's often very hard to tell, and this actually does constitute about 20% of the patients. So many of these patients do quite well. So to conclude, the odds of reconstructive failure are higher with radiation to either the tissue expander or the implant compared to non-radiated patients. Radiation to the expander has increased failure rates compared to the permanent implant, 32% versus 16%, and I do share this with patients if they have a choice. Aesthetic results in capsular contracture rates are slightly better for radiating the expander versus the implant. Patient-reported outcomes do not differ. What's the take-home message? I think the management of PMRT and breast reconstruction is multidisciplinary, and it always has to take into account the oncologic treatment, and then as plastic surgeons, we work around what the patient wants and what the oncologic issues dictate. Oncologic approaches continuously evolve, and we need to adapt to these changes. What should we recommend? I sit down and talk to these patients about all the issues, and then they make the final decision. Thank you.
Thank you, Peter. That was perfectly timed. I'd like
Pure
to
luck.
introduce the moderators for this session, Dr. Phillips and Dr. Lumenta, and they will lead off with some questions, and then we'll leave some questions for the audience. We have about 4 minutes for that.
How do you choose how much fill that you do at the time of the surgical procedure for a tissue expander?
Basically, depends on what the tissues look like. So as little as just 50 cc's or as much as half the volume of the expander. And it varies from breast surgeon to breast surgeon. And it's just a clinical decision.
And then for modulating the scar afterward, if the patient desires additional intervention for the radiation changes, what kinds of things are you offering and timing for that?
Well, I generally would not operate on anyone for at least 6 months after radiation and the final result. I'm very conservative, and I'll tell patients, look, you're going to have this reconstruction for the next 30, 40 years, hopefully. And the more surgery you do, the more likely you're going to create a complication. So if it's a mild contracture, mild aesthetic problem, I'll tell them to leave it alone. If it's something more severe, I'll offer them, going in, revising the capsulectomy if necessary. But generally speaking, I'm more conservative than most.
Thank you.
Okay. The tissue expanders had a higher failure rate, but the implants had a higher capsular contracture rate. What is your hypothesis on that? Why is that?
Well, I think with if you radiate the expander, you have an opportunity to come back when you're doing the exchange. And when I do the exchange, I always do an aggressive capsulotomy, et cetera. So at the end of the day, they're less likely to have a contracture. But you have to look at the loss rate. And I actually don't advise patients one way or the other if they have a choice. Many of them don't have a choice. The ones that get neoadjuvant, they have to get radiation to the expander. But if they have a choice, I'll give them the numbers, and the ones that are more concerned about total loss will go with radiation to the implant and vice versa.
Thank you.
Yes.
Thank you, Dr. Cordeiro, for a great talk. So you mentioned that all your implants were under the muscle. So how does this data relate to prepectoral reconstruction? And actually, more importantly, if you know that the patient is going to get radiated, what is your preference, submuscular or prepectoral?
So definitely if they're going to get radiation or it's a high probability, under the muscle. I personally don't like taking the risk with prepecs. We don't have that much data, that not just me, but me and my colleagues at this point. We don't have that much data on radiating patients in the prepec position. I personally think in the very thin women with thin flaps, et cetera, they're going to be much more likely to have a problem. And that's true even submuscular, but my preference is under the muscle if there's any inclination for radiation.
Okay, thank you for a fantastic talk, Martin Karolinska, Stockholm. I think the timing is essential, and you said if you have radiated tissue expander, change to permanent would be 6 months. I know there was a paper by Peled who compared the ones 3 months and 6 months. I think this is so important to find the window of opportunity between the acute response and then when the late progressive disease starts. What's the idea of your timing?
Sorry, we don't have much time to answer that question.
Okay, we'll take it in coffee break.
Yeah.
All
Thanks.
right. Thank you so much. We're moving to our next esteemed speaker. Dr. Santanelli is going to talk to us about the anatomization of implants.
Thank you. Let me invite to the next meeting. We are planning on October 13 to 14, 2023 in Rome. We will have the 9th International Breast Surgery Workshop and the 5th World Consensus Conference on BIA-ALCL. So you're welcome. I'm going to talk about a novel concept which is spreading quickly in Europe, and it's based on a device produced in Italy, is the anatomization of round implants. That's my disclosure from Roman time. So it's a direct-to-implant subpectoral reconstruction. It can be a good result, can give good outcomes. You can see here is the use of Surgimet combined with Natrel. It's a quite a long time ago patient, and it looks quite nice, but when you look at it on the oblique or on the side view, then you find out that there are some rotation of the implant still, which impair the quality of the results. So I was not that happy. It happens quite often when you detach the pectoralis muscle and it may draw up the nipple. And the same by using the polyurethane, subcutaneous polyurethane, it does not seem to be the solution to this problem because of the severe wrinkling by gripping the skin to the implant itself. And further, since the volume, please, as usual, Can you please? Okay, so since it was stated by the share committee about
there's sufficient evidence to demonstrate a causal relationship
between texturization and BIA-ALCL, so it's a further issue that convinced us to change the approach and go for a complete full wraparound dermal patch, anatomic shape around a round smooth implant. So basically we have draw a study, and the aim was a prospective analysis of pre-pectoral direct to implant immediate breast reconstruction with this Braxton device and smooth route implant only. The primary endpoint was to analyze complications stratified per mastectomy or per reconstructive related, and secondary endpoint was to identify which risk factor were influencing the complication rate. So we included all the patients refusing or were contraindicated to autologous reconstruction, and they had indication for direct-to-implant prepectoral reconstruction from April 2019 to April 2021, in 2 years. So we analyzed all this data on a prospective database and demographic tabulations, mastectomy, implant weight, surgeons for reconstructing and for mastectomy side, drain, number of drains, volume of drainage, day of drain removal, and complication. So we analyzed 58 patients, which is 102 breast, 12 monolateral, 45 were bilateral. The mean age was 48 years. The mean body mass index, 23.6. And the smoking patients were 15, 25%, 26% of smoking patients. As you can see, 62% underwent nipple-sparing mastectomy, 28% to skin-sparing mastectomy type 6, and 10% to skin-sparing mastectomy type 4. 6 general surgeons approached the mastectomy phase, and 7 plastic surgeons did the reconstruction of those 102 breasts. That's a kind of results that you can achieve by using this combined technique with round implants, which looks very much anatomical and naturally shaped, with nice dropping without capsular contraction at all, using Braxton and Motiva silk. That's the full projection Motiva. That's the oblique view of the same patient, as you can see. Similar results with another patient. 300 grams the breast and 335 the round Motiva and Braxton. And that's the result on oblique view. Similar, again, with the mid projection, not full projection, the mid projection, it's 380 cc, the implant. And that's the result. Again, it's the same by using Motiva, 425, a larger implant, and that's the results on the oblique view. And that's the results, very natural. It's the same if you use the Mentor implant with this smooth round and with around the full wraparound Braxton, 490. So we decided to put a larger implant in order to expand more the skin envelope, in order not to reduce and not to have scar, and do a nipple-sparing mastectomy. And that was the results on side view. And the same if you do a unilateral. Even with unilateral, you can keep the symmetry with the contralateral side. And that's a Mentor smooth patient. That's the results. So the analysis of the results, the mastectomy weight was about 400, and the implant weight 427, slightly more, larger. The number of drains per patient were two drains per breast. The total volume of drain was about 500. The day of drain removal was about 16 days, so quite long. And mastectomy complications were 33 against only 8 reconstructive complications. If you go into the details, we see that in the mastectomy-related complications, 22 were skin flap necrosis and 11 bleeding, so they were closely related to the demolitive side phase. And the reconstruction-related were very limited, with red breast syndrome 3 times, 3 seroma, and only 2 implant infection. So we analyzed all the variables with the binary logistic regression analysis. We couldn't find any connection between complication and those factors we have analyzed in the mastectomy phase. Similar during reconstruction phase, we couldn't find any connection with any of those variables we have analyzed. So in conclusion, the use of this Braxton patch in immediate direct-to-implant prepectoral breast reconstruction allow for an anatomization of the round implant, immediately to implant prepectoral breast reconstruction show an overall low complication rate, which are independent from the breast or plastic surgeon or the device itself. Compared to other direct-to-implant reconstruction techniques, we experience the same hospital stay for the patient, similar volume of drainage, longer drainage permanence compared to them. Thank you for your attention.
Well, excellent timing. Thank you. So the question is, what's the indication at your institution for placing in, what's the difference? When do you say prepectoral and when do you say submuscular?
Yeah, I think that since we start to use this implant, this device, we are not indicating anymore the submuscular. Okay. We have very few cases. We have very good collaboration with breast surgeon. So it's very rare that we have post-mastectomy radiotherapy. Our practice, I would say, is 60% based on autologous reconstruction, 40% based on implant. And so it's very rare that we have to go for radiotherapy. So I would say that 99% of those patients we approach directly with prepectoral because the result is extremely soft and loose and with good doses and no problem.
Do you use any drains?
Drain?
Yeah.
Oh yes, as I said, we use 2 drains per breast, an average of 2 drains per breast, and we keep it quite long because the amount of serum, although is the same compared to the others, it keeps draining for a long time. So it's quite important to keep it in place for 16 days. Okay. The average is 16 days.
And secondary revisions such as filling in the superior pole, when or do you choose to use those?
What do you mean revision of this people?
Say with fat grafting.
Well, not really. Not really. We approach it like that. These are the typical results you can have. So it's, I mean, especially if you have to have a symmetry with the contralateral side, we can have the same mid-age breast. So we don't really need to fill up the upper pole. And they enjoy to have a more natural breast without filling with the fillers. Some patients, if they prefer to have it, we go for lipofilling, but there is no contraindication at all to give lipofilling on this dermal patch.
Thank you. Questions from the audience? We can go on.
Do we have any questions from the audience? Okay, great. Thank you so much.
Thank you.
Appreciate it. All right, our next presenter is Dr. Afifi, and he'll speak about muscular to prepectoral implant conversion.
Thank you, Mark and Fabio, for the invitation. Excited to be learning from all of you. I'll be talking about switching submuscular implants to the prepectoral plane. I have 2 books. I received royalties from them. No disclosures unrelated to this talk. So this was my first prepectoral reconstruction. This was 2016. My first patient had a previous lumpectomy and then having a bilateral mastectomy. I used a deepithelialized lower flap. You can see her result at 4 months and then at 4 years. Encouraged by this result, I continued doing prepectoral since 2016. So another patient getting a bilateral mastectomy, bilateral direct to implant reconstruction, and then another patient bilateral mastectomy, bilateral direct to implant reconstruction. Then I started doing harder patients, like patients with high BMI, also getting a bilateral reconstruction, and unilateral patient who's getting a radiation on the left side, and you can see her result with the right reduction and left prepectoral reconstruction. So this quickly became my preferred approach for primary reconstruction. Now, there's a patient of mine, I did her around 2013. I did the submuscular complete coverage, no radiation, complete submuscular coverage with a textured shaped implant. For 2 years, she continued to have continuous pain. I tried everything possible and nothing was helping. She fired me, went to another surgeon. He did a revision procedure, radiofrequency ablations, pain specialists, and nothing was helping her. So seeing my results with the prepectoral reconstruction and how little pain they have, how quick the recovery is, I called her and told her, just come back. I think let's try and switch it to a prepectoral reconstruction. So there's her with the submuscular implants, took them out and placed prepectoral expanders. Expanders were switched to implants, and within a week after putting the prepectoral implants, she said, I think we're onto something. This feels very different. And 3 years out from pre-pec reconstruction, extremely happy with the result. So here's another patient of mine with a unilateral reconstruction. This was a direct-to-implant submuscular reconstruction on the left. She wasn't in pain. She just continued to complain of vague symptoms of discomfort and tightness, not feeling right. So I switched the left submuscular implant again to a prepectoral plane, and you see the big improvement in the cosmetic, and she's feeling much better. So I continued doing these. This patient came for cosmetic reasons, wanted more projection, more definition, and I switched her to a prepectoral plane. And when you look at the breast cues for all of these patients, there's satisfaction with the breast. You see that post-operatively, all the circles are shifting to the right. And for the pain, all the circles are shifting to the left. And this was very consistent, one patient to another. Pre and post satisfaction with the breast, pre and post pain, everything is getting better. So we started studying these breast cues. So the first goal was how much improvement do these patients get in the different domains of the breast cue. And when you look at all of them, many of them, they almost doubled their scores after going from a submuscular to a prepectoral reconstruction. But my main goal from the study was to see which patients do well and in what aspects. So I divided the patients depending on the indication for the switch. Why were they switching the implants from submuscular to prepec? We divided them into 3 categories: chronic pain, animation deformity, and cosmetic concerns. So I was hoping to give you data that would tell you which patients are going to do well and which patients should be converting. The data was very impressive, but sort of boring, because regardless of their indication, all their breast Q scores were improving significantly, meaning that if they were doing the surgery because of chronic pain, their pain scores improved a lot, and their satisfaction with the cosmetic concerns also improved a lot, and vice versa. Patients who were doing the switch for cosmetic reasons, who did not complain of any pain, even those patients had a big improvement in their pain scores. So regardless of the indication for surgery, patients were getting significant improvement in all the categories of the breast Q. We've published our work before showing patients' concerns with the submuscular implants, and we also published our survey of ASPS members with their impression about prepectoral reconstruction. In this work, we showed that this was 2019, that prepectoral was becoming the more popular method, but still, most surgeons had significant concerns about the wound healing issues and the rippling. Until today, I myself have a lot of concerns about these 2 things. So technical tips how I do the switch, the submuscular to prepectoral. The first thing is an inframammary incision, or using what usually is a transverse mastectomy incision. My impression, I think most people will feel this, that inframammary incisions have a better healing. They have a lower complication rate, but becomes a much more technical surgery because you have much less access. So there's a patient of mine. She had prepectoral reconstruction and radiation, and she did very well for 2 years. And the 2 years after the reconstruction, she showed up in my clinic with the skin open this way. And I'm looking at the skin flap, and this skin is around 4 millimeters thick. I'm like, there's no way that this will last long term. So I switched my approach whenever I'm doing these reconstruction, to not doing an incision, but rather deepithelializing 1 centimeter on either edge of the scar. So I deepithelialize this segment, and then I incise in the middle of this segment. So this way, at the end of the procedure, I have 1 centimeter of dermis kissing the 1 centimeter of dermis on the other side. And this has improved my results and has prevented what you usually see of an indented scar right at the site of the scar. So there's a patient, my patient, again, submuscular implants. I use an inframammary incision. This blue line you see in the middle is the site of the myotomy in the muscle, but I'm using an inframammary incision, dual port expander with ADM, and there's her result afterwards. In most of my patients, I'll try to show you the rippling view with the patients leaning forward to show the rippling, which not a lot of rippling here, and the push-up bra view at the very end, which I think many patients care about. Prepectoral dissection. The way I do the prepectoral dissection is before we even prep the patient, I inject roughly 100 cc's of saline with epinephrine and TXA and lidocaine along the whole prepectoral plane. So after we do that, the whole dissection is done sharply. I'm using almost no bovie whatsoever. Everything is with a scissor or a knife. It's fun, it's less burning, and it's much faster than using the bovie. So the muscle repositioning. So the red is the muscle and the yellow is the capsule. I do not know how much capsule to remove. My preference is to usually remove the posterior capsule, this segment here only, while leaving the anterior capsule to avoid bleeding from the muscle and to not cause a lot of adhesions. The second thing is the muscle. Usually the lower part of the muscle is very thin and it's just scar tissue, so I actually leave it in place and I just divide the muscle in the middle, move it backwards, but I leave all the lower muscle, scar, ADM with the lower flap to leave a thicker flap. And I try to do this in a stair-step fashion, so you can see that the myotomy is higher than the skin incision. So at the end, I tuck this lower flap under the upper mastectomy skin. I suture it to the undersurface of the upper mastectomy skin, so it's a stair-step approach. ADM, synthetic mesh or no mesh, there's conflicting data. I do not have the answer to this. I think it's a big issue. Two ways you can use the ADM. I'm now favoring the picture on the left, where I'm just putting the ADM just over the upper pole because I preserved all the scar and muscle in the lower pole of the breast. This, I think it improves the healing and lowers the cost. If you haven't tried this, we've published this, I would recommend this strongly. There's the secure strap. It's a hernia stapler, and I use it to suture the ADM in the upper pole of the breast. It saves a lot of time, and it saves my C-spine. Again, I've been using this for many years now, and I highly recommend it, and I have no disclosures. So a direct-to-implant or a two-stage. The main reason that I like using an expander is that I do not have to fuss with the insurance company about doing a revision. Putting the expander almost guarantees you a chance to go back, do some more fat grafting, fine-tune the reconstruction. Usually the decision for me depends on the shape of the submuscular reconstruction. A patient like this who is doing this for pain, she already has a really good outcome. Not my patient, done elsewhere. She had a submuscular reconstruction. She really has a good shape, good symmetry, good inframammary fold. I do not see any value to putting an expander here. So in someone like her, I do a direct-to-implant reconstruction on both sides. And if you can play the video, please. And I removed all the videos from my talk just to save time. And you can see these patients, I always take videos of them showing the animation. There is absolutely no animation. And then when she pushes up her breast, just to show the natural movement in the breast after the surgery. Again, another patient is a right implant, also done elsewhere. I'm switching her. It really looks good, so I go immediately to an implant without using an expander. But other patients who have not the best outcome, this was an implant done many years ago, not by me. So in these patients, I go to an expander, and then I do an implant, and as you can see, she was done with a phasix mesh. Another patient with a ruptured implant, you can see this herniation under the right inframammary fold. Again, it's hard to do a good result with a direct-to-implant, so I put the expanders and then switch them later to the implants. Direct-to-implant technique, it's very interesting to see what you were doing, Fabio. I do something similar, except I shape the ADM on a shaped sizer. I use a round, smooth implant, but I shape the ADM over a shaped sizer, similar concept to what you were just describing. And in conclusions, I think the conversion procedure brings improvement in all aspects of the reconstruction. I rarely today do revision of submuscular implants, keeping them in their same plane. It's either we accept the results or we switch them to a pre-pectoral reconstruction. Thank you, and I have 8 seconds left.
Would you speculate on the cause of the significant difference in pain between subpectoral and prepectoral?
I think when I talk to the physical therapists, they all are discussing the fascial attachments, that all our fascia is connected. Because many of these patients, they come back and they're telling me my shoulder movement has improved, my neck has improved, my back pain has improved. So I think all the attachments and all the stress, I think lifting the serratus in particular causes a lot of pain in these patients. Many of these patients who are doing this for cosmetic reasons, they would come back and say, I actually did not realize that I was in this much pain before the surgery.
And then are you converting some patients for purely aesthetic reasons, without the pain component?
Yes, absolutely. Many of these patients were switched for purely cosmetic reasons.
Ever tried to remove the entire capsule and think there was a different result, so capsulectomy entirely?
I never tried doing it. It's technically hard. It will bleed a lot. And I want the muscle to move. Just anecdotally, I have no evidence for this. I want the muscle to move. My impression is that if I remove the posterior capsule and the anterior capsule, there's going to be a lot of scar tissue in there, which I do not want.
Thank you. I'm Santanelli. And two questions. One is, are we talking about texture or smooth implant in terms of removing the capsule? And then I agree that the pain is related to the muscle disinsertion, and only the weight of the implant hanging on the muscle itself, it gives pain. And so according to that experience, how did it change your indication between pre- and retropectoral positioning of the implant in your practice nowadays?
So to answer the first question, I do the same capsulectomy with both, unless I have concerns about ALCL, but I do the same capsulectomy in both. Regarding, and again, I'm happy to learn from all of you. I do not know what the right thing to do is. The second thing is about the indications. If the patient has it, I believe in every single patient, prepectoral is a superior cosmetic and a superior functional outcome. However, it comes at an increased risk of complications. So I have this discussion with patients. I have strong indications for prepectoral, like patients who are getting radiated, unilateral, patients on crutches, patients with multiple sclerosis, patients with any pain condition like migraines. I would strongly favor prepectoral, but it comes at a higher risk for complications.
Cordeiro from New York. Are most of, when you're switching out these implants, are you going from a textured to a smooth? I think Fabio mentioned, commented.
So I haven't used any textured implants in the last 8 or 9 years.
No, but you're swapping from textured submuscular to smooth prepec?
I think maybe 5% of this patient series were textured. The rest were round implants.
Okay, yes. Because I have very similar data. I've swapped out about 500 patients from textured to smooth for other reasons, usually fear of ALCL, et cetera. And I leave them in the same position. They're all, most of them submuscular. And it is remarkable how many patients, I have data now, 75% of them say the smooth implant is way more comfortable, it feels natural, their pain is gone. So the question becomes, is it because of the switch of pocket or switch of implant? At least in my practice, it is remarkable how much more comfortable the smooth implants are.
So I totally agree with you.
Unpublished data.
Yeah, no, I totally agree with you. The worst patients are those who've had textured implants. When I see a patient with a textured submuscular implant, I know that we're going to have a great time because she's going to be so much better. But in this series, the vast majority of them were smooth, round implants. In my area in Wisconsin, there are very, very few textured implants that are being done.
Wonderful. Thank you so much. Our next speaker is Dr. Demiri, and she will speak about patient measurements and implant selection in two-stage implant-based reconstruction.
Good morning, everybody, dear chair. First of all, I would like to thank the organizers, Fabio Santanelli and Mark Clemens, for the honorary invitation to be a part of this fantastic faculty team of the symposium. So my talk this morning will be how we measure patients and how we select implants in two-stage implant-based breast reconstructions, given that in my country, in Greece, most mastectomies are performed by breast surgeons, of course, and they are skin-sparing mastectomies. We very rarely asked to reconstruct nipple-sparing mastectomies because even prophylactic mastectomies still are the majority skin-sparing ones. So we have even a bigger challenging to reconstruct those patients. Oops. I have no disclosures. So as we all know, implant-based breast reconstructions account for more than 70% of all primary reconstructions worldwide. And two-stage procedures done as immediate or late surgeries, they do have advantages. Less tension on the mastectomy skin flaps, flexibility on choosing the breast volume, which may be altered and controlled, and patients may have a significant input into decisions, and of course revisions can be made in the second surgery. While of course there are drawbacks, higher cost, longer procedures, multiple visits, and minimum 2 surgeries that are required. So when, in the first stage, of course, we have to select the right expander, considering the dimensions of the footprint, of the breast footprint, and of course considering any symmetrization which might be required on the opposite breast, which is preferably performed in our practice in the first stage. We avoid large round expanders producing extra large pockets because they need to be revised in multiple ways. Instead, we are using expanders in shaped expanders, medium height with integrated port in order to selectively expand the lower pole and get more desirable final breast shape. So in our practice, after skin-sparing mastectomies, of course, we are inserting the expanders retromuscularly, and we try to cover them with autologous tissues, either the myofascial flap of the serratus or the inferior deepithelialized skin flap, after a wise pattern skin reducing mastectomy. So, when we need to plan our second stage at earliest 6 weeks after completion of the expansion, and as Peter Cordeiro mentioned, at least 3 weeks after chemotherapy or 6 months after radiation, then we need to measure and plan our second stage in order to get a symmetrical and aesthetically highly scored result. So there are questions that need to be answered. Have we get symmetry with the expander? Do we need to adjust, and how the other breast? Do we need to revise the pocket, and how? What about capsular contracture, especially in irradiated cases, and what are the patient's wishes, of course? So the decision to select the implant is multifactorial, based on the characteristics of the breast, the mastectomy, previous treatments, namely radiotherapy, of course, laterality of reconstruction, and of course, adjustment of the opposite breast. We always mark the meridian, the median line, the inframammary folds comparative to the other side in order to define our new pocket. Of course, capsulotomies are always performed, especially when we put our expanders submuscularly. We need to do capsulotomies and we need to redefine the intramammary fold. And of course, we need to consider lipofilling, especially in the upper pole, to cover our irregularities, like in this case. So it's important to measure the dimensions of the breast cone that we need to reproduce, the base, which means the width, the volume, and the projection. For when we have an expander with the base and the volume that we need to get with our implant, we need to remember that almost always expanders are highly projected. So implants are usually, we need implants with a lower projection, but even if this is the same patient, before and after exchanging of the expander to an implant, in supine position, the implant needs to be a little bit more projected than the natural non-implanted breast, just to have a better projection when the patient is in a sitting and upright position. If good symmetry has been achieved with the expander, it's important to remember that the implant's volume should be a little bit more bigger than the volume of the injected saline, because of course the expander itself the device has its own volume, and it's good to be familiar with the characteristics of our implants in different brands, using charge or even some application. This is the application by Perheden, which is quite helpful for many surgeons. Of course, using sizers is mandatory intraoperatively in order to assess immediately the result in an upright sitting position. All brands may provide us sizers, especially when the other breast has not been already adjusted. Then we need to correct this asymmetry. And it's very important to use sizers in this case. If we use a mirror of the contralateral augmented breast, we can see that both breasts are very similar. The only thing that it is missing is at the top of the cone, of course, the nipple. So anatomical or round implants. Of course, anatomical implants are more natural. They have a natural shape, full lower pole, like the natural breast, less projected upper pole, and they are more stable, but of course they are not so soft. We have the risk of rotation and of course the obvious risk of ALCL. On the other hand, round implants, we know they are softer, of course, no rotation concerns, minimal risk of ALCL, but yet the problem of SCC has appeared. But of course, we have still risk of capsular contracture, displacement, which we should remember, so pockets need to be much tighter, and of course, the full upper pole is not always desirable. So in our hands, indications for round implants, because in Europe we still are using anatomical implants, it's only for large breasts with thick skin, contralateral augmentation with round implants, bilateral mastectomy sometimes, and of course if the patient wishes not to have an anatomical implant. Let's see some of our patients. This is an anatomical expander, 350, which was replaced by an anatomical implant, a little bit larger, 440 cc's, with a quite good result. Another similar case, we didn't touch the other breast. In this case, again, 350 expander, 390 implant with a modest mastopexy on the other side. Large emptotic breasts, skin-reducing mastectomy on the right side with an expander of 450 and an augmentation to the other side, which was replaced by an anatomical implant 495 with a long and stable result for the next 3 years. And another case with a small implant that was finally used with a contralateral augmentation on the other side. This anatomical expander was replaced with a round implant plus lipofilling on the top. Bilateral reconstructions are easier to achieve good symmetry with higher overall aesthetic scores as soon, of course, as the breasts are quite similar. Like in this case, therapeutic mastectomy, skin-reducing mastectomy on the right side, prophylactic on the left side, symmetrical result using a little bit bigger implants comparing to the expanders plus lipofilling on the top. When both the two breasts are not similar, like in this case, she had a lumpectomy on the left side plus irradiation, and now she's a BRCA patient. She's going for a prophylactic mastectomy bilaterally. Then we have used 275 expanders. When exchanging the expanders, we grafted with fat the left side, but still there is an asymmetry. In those cases, perhaps different sized implants might be considered. So to conclude, is there a real algorithm? Is there a ready recipe to be used for selecting implants in two-stage breast reconstruction? The answer is not really. In our practice, we always follow the principles, analyzing each case individually, discuss with the patient, of course. In the first stage, we need to select the right implant and the right expander and insert it properly. If preferably, we adjust the contralateral breast in this stage, and then in the second stage, we very carefully determine and select the dimensions of the new breast cone, width, projection, and shape, And either if we use anatomical or round implants, we need to think about lipofilling in order to have better results. And of course, the use of scissors is in our hands imperative. Is there a third stage? Yes, additional fat grafting should be always considered. So thank you very much for your attention.
So just a couple of, so it's very personal in the end how you decide, so personalized medicine. The question is, do you remove the capsule? So always going back to the capsule today, I suppose.
No.
No.
We don't remove, we do capsulotomies, or we adjust the pocket depending on the implant that has been selected, or on the breast shape that we want to produce, but we don't remove it.
And the lipofilling during the second stage, where do you put the fat to?
Yes, in most cases we are doing we fat graft in the second stage, but sometimes.
Where to? Where do you place it?
Where? Usually in the upper pole or in the medial in the medial area.
So in between the capsule and the skin.
Where? In which level? In subcutaneously, yes. Between usually subcutaneously, yes.
Have you had problems with anatomic implants rotating or flipping?
We had problems with expanders rotating. In most, not in many cases, our expanders have rotated, which are shaped again. Anatomical implants do rotate sometimes, but the problem is when rotation is, we can see it. Usually with fat grafting is, if needed, we can cover it. But yes, there might be a rotation, of course, of anatomical implants. We did experience some rotations.
A question from the audience.
Yes, thank you very much for your presentation. Dietmar Ulrich from Nijmegen from the Netherlands. We use the same concept in our department as you show. It's a typical European concept with textured implants, also with textured tissue expanders, and we use the same concept. And as you've shown here, with the lipofilling, with your second stage, you've got a lot of pretty good results here. And just one other remark, the tissue expanders, you can also fix the tissue expanders with the new generation of the tissue expanders. We fix it in the EMF, and then you've got a stable result without any rotation of the tissue expanders also. But nice results you present.
Yes, thank you. I haven't used fixed expanders so far. Yeah. Yes, yes. Yes, yes. Thank you. Thank you for your comment.
Thank you so much. Appreciate it.
Thank you.
Thank you. Next speaker is Dr. Hall. He'll talk about radiation-induced capsular contracture from genomics to salvage procedures.
Thank you very much. First of all, I'd like to thank Mark and Fabio and all the organizers for putting together a nice program. I'm truly honored to be here. I have no disclosures. So this is what I'm going to talk about. This lady came in quite recently to my office seeking for revisional surgery after having immediate breast implant, reconstruction by the breast surgeons, and then post-mastectomy radiotherapy. So what did actually go wrong, and why did this happen? When did things go wrong? Who will have this type of radiation reaction, and what now? Well, I'll try to answer some of those questions, but first, a few words about the setting where I work. This is where I see the patient, the Karolinska University Hospital, and it's right next to the Karolinska Institute, probably most famous for handing out the Nobel Prize, and I cannot come to Texas Medical Center without mentioning this guy who actually revolutionized the melanoma treatments, the paradigm shift with the immune therapy. We all know that. And next to that, the Stockholm University actually built a hub of a SciLife lab. So there's a great community where we can work around the patient with a lot of great labs and basic science. I'm also the clinical lead of the Swedish Breast Implant Registry. Up till now, we have more than 50,000 implants. And this gives us a great opportunity for translational research and zoom in and zoom out from big data to actually lab work translationally. Well, not surprising, but just some from the annual report that I wrote together, just published from the 2021 annual report. Not surprisingly, we see that patients that have been radiated after immediate implant-based reconstruction, reconstructive cases only, and not the ones having radiation before the implant, well, they still have a greater risk of capsular revisional surgery. But these are the patients. Those are the ones we work with. And all of these women came in to me quite recently seeking for revisional surgery, autologous reconstruction after implant-based and radiotherapy. And why? Well, as we've seen, we see a selected amount of the cases. If we work with breast surgeons doing the implant-based reconstructions, we get the worst cases to do the revisional. And of course, many of them get capsular contracture, migration, pain, etc. But again, we have to say most of the patients do well after post-mastectomy radiotherapy. And equally important is to say that some get this severe type of radiation reaction, some get none, and we have a big bulk of patients in between. So this has caught some of my interest, and I, for the last 15 years, been doing research on normal tissue radiation damage. So I started off collecting the recipient vessels that were radiated compared to the flap vessels that were not. By comparing the patient's tissue with its own, you're looking at the factor of radiation only. So this is actually a very powerful tool. And I've banked this and worked in different compartments of the body with the arteries, the veins, the skin, the fat, and now the radiation-induced capsules. We also work with basic scientists in the lab, giving us opportunity to do the interventional studies in animals, and then go back to the patients, looking at breast Q and other patient outcome-related data, sample tissue material from the patients, and also draw blood samples from them. So at the bottom, we look actually at biomarkers and gene types, and this is a recent publication we did together with the SciLife lab. And we pooled the very radiosensitive head, neck, and breast cancer patient, compared them to the TNM, age, everything matched 1-to-1 with the nuns that did not have a radiation reaction. And we could see gene variants and biomarkers popping up. This is, of course, not the truth of what happens. It's multifactorial, but it indicates that we do have radiosensitive patients. We'll also be looking at intervention to ameliorate the radiation response post-radiotherapy. And that has actually, cleaning up, cooling down after the radiotherapy with taking care of the inflammation, we've been able to reduce the fibrosis. And what about fat transfer? Well, there are a lot of anecdotal reports, so we wanted to bring in some objective data. So we looked at, again, patients radiated compared to non-radiated breast, fat transfer, and then go back 1 year after, checking differential gene expression, histology. And what we could see was that we could actually see a differential gene expression pattern between the radiated and non-radiated breast that was almost normalized after fat transfer. So we do have objective data that this actually helps. But what about the capsular contracture? What can we do there? Well, we know from aesthetic surgery, and this is a meta-analysis quite recently in PRS, but this has been published for the last 5 or 10 years, that leukotriene antagonists may have a suppressive effect on capsular contracture. However, this has been studied in aesthetic surgery. So when the early papers came out, we started studying the leukotriene response in the radiated tissue. We could find that it's highly upregulated in radiated tissues, connective tissues in the microvasculature. So putting this together, well, nobody did this before, but this must be the silver bullet, right? Montelukast, upregulated in radiated tissue, help in capsular contracture in aesthetic surgery. So we started looking at that in a similar manner, in an unbiased approach, collecting radiated and non-radiated capsules, comparing with microarray and histology. And the results, we saw more than 200 differentially expressed genes. We put them into software, but unfortunately no significant leukotriene upregulation there. What we saw was a bit surprising, though. We could see a lot of B cell infiltration. And looking at the processes, biological processes, on the top list of differentially expressed genes, B cells and B cell activation is there. So we started verifying by immunohistochemistry. This is bilateral case. You see B cells in the radiated capsule, but not in the non-radiated. Collected some more and did quantification, and it was significantly upregulated in the radiated versus the non-radiated. We checked at other inflammatory cells, T cells and macrophages, and there were no difference. However, a lot of inflammatory cell infiltration regardless radiotherapy in both cases. So looking a bit closer, we have a tool. We can use the array data and pull out the cells that were active in gene expression data, and we could see that the most significant upregulated cell types were the macrophages and T cells, regardless of radiotherapy. But we need to bear in mind all of those implants were textured and none were smooth. So of course there's a lot of research to be done in the future. Back to the patient. This is a typical patient coming in. Well, she's actually very happy with her left breast. May look good like that, but she suffered from pain and uncomfort, and she wants seeking for autologous reconstruction. So what we do is, there's no way we can use this pocket because it won't expand. It's contracted, not only in the skin, but in the musculature. So we discard all the skin in the lower pole and replace it with, well, first choice, of course, DIA, and in a prepectoral pocket. Another patient, typical, and this so constricted lower pole need to be cut out, and there's no way you can use the skin. And we all know that the lower pole is so important for the aesthetic appearance of the breast. So this is how we do it. Another patient, she had bilateral reconstruction, but here we run into problem. We had an arterial thrombosis, and you know, we very rarely see this, but when we're doing the conversion from radiated implants, we've seen a lot of problems of this, and we get more and more of these revision cases. So it has been shown that radiation causes harm to the vessels. It's not really associated with flap failure. You know, we have very low failure rates, so it's difficult to find that outcome, but we see in some studies that you have problems during surgery that you need to prepare. But also this little older study from UCLA has shown that previous implant or an expander makes certain inflammatory, you know, problems to the vessels. So we consider this not being 1 + 1, 2, but 3. They have a synergistic effect. So now we're more looking at the arteries and the capsule together and see what they're doing. So clinically, this is a case, and here is the elastic layer dividing the intima from the media, and this is from this patient. It just got lost, it get ripped. And for those of us have done enough on those radiated patients, we recognize the problem. So we try to suture, like we learned in vascular surgery. The sick intima should be nailed to the media. And what we do clinically now, in the revision with radiated implants, we suture the loose intima from inside and out, and we discard the third rib like we used to do in the old days. Otherwise, we go between the second and the third. And we also do an open book anastomosis, because we found that twisting with a double clamp, we sometimes, in severe cases, get an occlusion even before we did anastomosis. And we use this BIA-ALCL single clamp. It's just very gentle to the radiated vulnerable vessels. So future directions, well, I think we'll find biomarkers that can help us, tailor the treatment. And at Karolinska, we have a precision medicine center of Karolinska, which is the idea of giving every patient a unique treatment in a cancer setting. We also have, the timing of surgery that we talked about before. When's the ideal window between the acute and the late progressive phase? Shells, targets to reduce inflammatory cell infiltration, and probably there will be magic bullets. Maybe Montelukast can be studied in another way to ameliorate fibrosis in those cases that need to be radiated. Last but not least, I'd like to welcome you all to the upcoming Europe's meeting in Stockholm in May. And personally, I'm going to be host of the Europe's Research Council, and it's going to be in the Nobel Forum, where the Nobel Prize winners present their talks for the first time in a Nobel Assembly, get to meet. It's going to be very unique to access to that. So we hope to see you all at both of those meetings in May. Thank you very much.
There's already a question. Do you want?
Mark, would you like to go ahead?
Sure.
Lead off?
Thank you, Dr. Halle, for an outstanding presentation, as well as making the long trip here to Houston. I had hoped that one of our radiation oncologists, Ben Smith from MD Anderson, would be here this morning. He couldn't, but I wanted to bring to your attention, he recently identified the C509T variant of TGF-beta as an independent biomarker predictor for aesthetic outcome after radiation therapy, as well as capsular contracture, as well as device loss. That C509T variant, now we've developed into a CLIA-certified lab test, and we're really working with early identification of what populations it best predicts for. We see, if present, it is actually really quite a deleterious effect on the patient. It's higher in African American populations as well as Hispanic populations. It's lower in Caucasian populations. So with all of that said, you talk about using these as targets to correct the problem, but what is the role for predicting the problem before it's ever occurred?
Thank you for that important question. Well, of course, there's much to be done. If you look at the biomarkers and the gene variants that has been described, we have a couple of other papers on that. You necessarily don't get a hit on one of them, but it's been described in different cohorts. I think we need to collaborate, and we collaborate also with Royal Marsden in London, Adil Khan and his group, and we try to, we need to collect data in order to have big cohorts, but the phenotype of the radiosensitive patient or the ALCL patient, it's going to be difficult either to define or find. In head and neck, it's easier. We take the osteonecrosis, but that's a clear cut when they get a fracture of the mandible. When do you say a Baker 4, 3? How are you sure you can, differentiate? So to find the phenotype, who is the radiation responsive patient, that's going to be difficult. We're going to the acute reaction from photos after radiotherapy to select that cohort in the breast, but acute and late response are also different entities. So yeah, there's so much to be done, but very interesting to hear about your findings.
Hi, my name's Alex Marichli, and I'm a plastic surgeon at MD Anderson here in Houston. About 10 years ago, when I was in residency, I worked in a lab, and we looked at the impact of radiation on soft tissues, and we identified reduced capillary density in the soft tissues and causing a relative hypoxia. And we hypothesized that a lot of the changes that we see in irradiated breast soft tissue might be attributed to this relative hypoxia. I was wondering, in your extensive studies, have you seen this at all? And if so, do you think that some of the soft tissue changes that we see could be related to just the reduced vascularity?
Yeah, thank you for that question. Well, that's actually why I started with the vessels, because it all needs vascularity. And capillary density has been shown a lot in radiated tissues. And the interesting thing that it increases a lot. So what happens is you get a recruitment of the myofibroblast, collagen deposition, and it kind of, what comes first? Either, the vessel that is thrombosed in the microvasculature and gives, collagen deposition or the collagen that kind of shrinks the vessel. That's the hen or the egg discussion. But it's for clear that's true.
Interesting. Thank you very much.
Thank you very much. Next, we have Dr. Mo Nahabedian.
Good morning,
coming to
everybody.
us
My name is
virtually.
Maurice Nahabedian, and I'm going to spend the next 11
Virtually, with a title of his talk on managing breast cancer in patients with prior breast augmentation. So,
Good morning, everybody. My name is Maurice Nahabedian, and I'm going to spend the next 11 or 12 minutes talking about managing breast cancer in patients who have had prior breast augmentation. Before I get started, I'd like to thank the organizers of this prestigious conference, Mark Clemens and Fabio Santanelli. These are my disclosures: speak and consult for Allergan and Stryker. These are some breast cancer statistics that many of us are familiar with. We all know that breast cancer will affect 1 in 8 women. What we may not have known is about 35,000 women who have had prior augmentation may be diagnosed with breast cancer in any given year. Fortunately, there's no link between breast implants and primary breast cancer, and of course, I'm talking about non-ALCL. What is important is early detection, diagnosis, and management. So in order to take a deeper dive into this, we did a case control study looking at trends in the augmentation cohort at a single institution. And the 2 cohorts that we looked at were 48 patients who had had prior cosmetic breast augmentation before cancer treatment. There were 48. And we compared this to 302 retrospective patients who developed breast cancer but without implants, and these were matched. The endpoints for the study were breast cancer detection, staging, implant location, fill, diagnosis, and management, as well as other factors. So when we look at implant characteristics in the cohort that developed breast cancer with implants, 69% of those devices were in the subpectoral position, 61% were silicone implants, and the mean age of the implant at time of diagnosis was 14 years. And of course, the non-augmented group didn't have any implants, so there was nothing to compare. When we look at tumor characteristics, looking at the cohort of patients who had breast cancer with augmentation, 8.7% were either BRCA1 or 2 positive compared to 5.9% in the control group. And the most common diagnosis was infiltrating ductal, which was 88.4% in the non-augmented group compared to 76% in the augmented group. When we look at TNM classification, the majority of patients in both cohorts were T1, N0, M0. And you can see that stage 0, 1, or 2 cancers were diagnosed in 97.1% of cancers in patients without implants compared to 97.8% of patients with implants. If you look at the detection methods, the tumor size was slightly smaller at time of diagnosis in the patients who had had prior augmentation, 1.4 compared to 1.9%. Over 50% were palpable in both cohorts. Both cohorts had mammography. Interestingly, the detection of these tumors on mammography was in 77.8% of patients with implants compared to 90% of patients without implants. Now, keep in mind that traditional imaging with mammography can obscure parenchymal visualization in 39% of patients with subglandular implants and 28% of patients with subpectoral implants. So various techniques have to be utilized in patients who have implants. Diagnosis and trends. Excisional biopsy was performed more often in patients who had prior augmentation. Mastectomies were more common in patients with implants, whereas breast conservation was up to 43% in patients without implants, whereas it was only 27%. So a little bit more breast conservation in the group without implants. So some of the summary findings of this study. So breast cancer detection was usually completed at a smaller tumor size in the prior augmentation group. Diagnosis is facilitated by palpation or MRI rather than screening mammography for the reasons discussed. less likely to have nodal involvement and have a lower incidence of stage 3 disease in patients with prior implants. And patients with prior implants are more likely to undergo mastectomy versus breast conservation. Looking at whether these devices were under the muscle or on top of the muscle, there was really no difference on cancer detection, stage, or treatment. There were no differences in tumor size, lymph node spread, or metastases. Palpable mass was slightly more common in the subglandular setting, 57% versus 55%, and a positive mammogram was noted in 78% of patients with subglandular and 71% of subpectoral. So then the question becomes, is breast conservation feasible following breast augmentation? This was another retrospective study done by another group of investigators looking at 52 patients who had had breast conservation in the setting of prior augmentation, and compared that to 51 patients who had breast conservation without augmentation. And they found that the non-augmented group was more likely to have larger tumors, T2 and above, compared to the augmented group. More patients in the augmented group had positive margins, 6 compared to 3, however, that was not statistically significant. And more patients in the augmented group had recurrence. Again, that was not statistically significant. So I just want to go through 4 cases here that I think exemplify our practice. So this is a patient who's 36 years old, who I initially saw in 2006. She had her saline implants placed in the subpectoral position in 2001, and then developed a left breast stage 1 invasive ductal carcinoma. So the plan on her was to do a left skin-sparing mastectomy and 2-stage reconstruction in the dual plane or subpectoral position. She was not going to receive chemo or radiation. So here she is with her mastectomy completed and tissue expander placed, and we're filled to a reasonable amount here. So at the next stage, we take out this expander and we go ahead and put in a permanent implant. We also adjusted the right side. So here she is 2 years after that operation, and she has reasonably good volume and contour symmetry. She comes back to see me 13 years later. This is now 2019. And she has ruptured silicone gel implants. Fortunately, she never had any recurrence. So the plan was to basically adjust this by taking out the old implants, putting in new implants, and making some soft tissue modifications to improve her overall symmetry. Here you can see our preoperative markings and then the ruptured implants with the capsulectomies. I try to do capsulectomies on these patients. And then here she is 6 months after that procedure with new implants, and I think we've got improved volume and contour symmetry. Keep in mind that a breast that is augmented with a mastopexy is always going to look a little bit more natural than a mastectomy, especially with the rounder implants, because the new breast will assume the shape of the implant. Another patient, similar to the other one, except that her prior augmentation was only 2 years prior to her development of breast cancer. She had had 345 cc smooth implants placed through an axillary approach and then developed a right breast cancer. It was 1.6 centimeters, infiltrating ductal, and she wanted mastectomies, nipple sparing, and she wanted to be a little bit bigger than what she was now. So here's our markings. We're going to do a nipple sparing mastectomy through an inframammary approach, and we're going to place tissue expanders because she wants to be larger in the prepectoral space, and I used a 400 cc expander just based on measurements. So here she is 3 days after this procedure, and it looks a little bit frightening, but nipple sparing mastectomy is sometimes a little traumatic and you can get some bruising. So we took out the 345 cc devices. Her right breast was 218 grams, left was 228 grams. We filled the tissue expander to 200 cc's, and this is very early follow-up. So she went on to heal, and we went ahead and resumed our expansion. So here she is now at 450 cc. She's got a little bit of rippling, as you can see there. So the plan is to take these tissue expanders out, put in new silicone gel implants, and we're going to do some fat grafting at the same time. So here she is 2 weeks post-op, and she has the 520 cc devices, and she's not quite happy. She wants to be a little bit bigger. We didn't quite meet her expectations. So fortunately, doing an exchange is relatively straightforward. So we set her up for taking these devices out, putting in a slightly larger implant, and here she is with a 600 cc device. And you can make an argument that she actually looks better preoperatively, or she looks better postoperatively than she did preoperatively. Another patient, actually a little bit different than the other two, she had had her prior augmentation 2 years prior to developing a left breast mass. So this is a little bit different. It's actually not a breast mass, but it's like a chest wall mass. And she's got a 300 cc device. This is in the dual plane position. So we did some imaging on her, and she ended up having a desmoid tumor. And you can see the tumor under the left implant involving or invading the chest wall. It originally emanated from the intercostal muscles. So just some desmoid facts, locally aggressive, benign tumor. They do tend to occur at sites of previous surgery. You have to be aggressive because these have a tendency to recur. So the plan on her was to essentially take these devices out and do a chest wall resection. So you can see our approach was inframammary. There's the tumor that you can see coming out from the chest wall. So with the assistance of the thoracic surgeons, we excised the ribs 3 and 5. We then went ahead and did a chest wall reconstruction using methyl methacrylate and a mesh on top. I decided that I wanted to compartmentalize this reconstruction from the breast because we did not do a mastectomy. So I basically did a latissimus dorsi flap that we deepithelialized, and I laid it on top of the reconstruction in order to basically provide some insulation between the mesh and the breast tissue, and we had some padding there as well. So here she is 2 weeks after that procedure. Implants are out, not real happy with the results. She does desire reaugmentation, but obviously for good reason, we decided to wait a good year or two before proceeding. So eventually we did go back and re-augment her, and this is her 2 years after reaugmentation with a 240 cc smooth round silicone gel implant. And we've really attained very good volume and contour symmetry, and you can see the well-healed scar from her latissimus dorsi flap. Final patient is 66-year-old who has left DCIS. Interesting about her, she had her breast implants placed 35 years ago, never been replaced. 360 cc silicone gel implant. So the plan on her is partial mastectomy, not total. She's going to have bilateral explantation. She is not interested in placing new implants, and we're going to do a left oncoplasty and a right reduction. And you can see on her lateral views just how displaced these implants are. She's really got what's called a waterfall deformity, where the breast tissue is now gliding over the implants and starting to give a Snoopy type deformity. So here's our markings. I can tell you that the left partial mastectomy was 46 grams, the left excision was 18 grams, the right reduction was 51 grams, and we took out these 360 cc smooth round implants that were both ruptured. And then we went ahead and did our oncoplasty on the left and reduction on the right, and this is her 1 month out. So you can even do this type of oncoplastic type procedure in the setting of prior augmentation. So in conclusion, I think that breast cancer following augmentation should be discussed with all patients preoperatively before augmentation. I think proper surveillance via self-exam and mammography is recommended. Actually, MRIs are probably better than mammograms. Oncologic management, breast conservation versus mastectomy. Reconstructive management can be prosthetic, autologous, or oncoplastic. I'd like to thank you all for your attention and look forward to the question and answer period.
This is Linda Phillips. Would you please comment on the differences in body image or aesthetic sense between those patients who have and have not had previous augmentation prior to their breast cancer diagnosis?
I think I'll take this one. We're having technical difficulties, and Dr. Nahabedian is actually not on the line, unfortunately. But I want to thank him as well as wish him a happy birthday today. So I think we're going to go ahead to the next talk, which will be mine. First, I want to acknowledge, we'd be remiss without saying how much we're indebted to the patients that have agreed to allow their photographs to be utilized in these educational presentations. We would ask the people that are watching this at home to please not repurpose these photos or slides without the direct agreement of the presenters. I also want to acknowledge my colleagues at MD Anderson Cancer Center who are serving as the hosts for the meeting this year. Half of them are participating in some aspect as part of the presentations and the moderators. And I rely heavily on them with regards to the data that I'll show in this next talk, which is on achieving a natural prepectoral reconstruction. Disclosures is MD Anderson does participate in FDA trials for Allergan mentor and establishment labs. I'm going to talk about my technique evolution with prepectoral, as well as what I coined the escape method, and practice changes and outcomes. Those who have studied change management will quickly recognize the dreaded S-curve. The S-curve starts with the red dot, which is where we are now. Our ideal state would be the blue line. And to get there, we frequently have to go worse before we go better. And that's actually the course of my own path with prepectoral reconstruction. And I've broken it down. It's easy to say pre-pec reconstruction, but there's so many different facets to this technique that have really changed in my own practice over the years, which I take back to 2004 under the training of Scott Spear, where we did total muscle coverage, going all the way to pre-pec, introduction of ADMs, even my irrigation has radically changed, to utilizing smooth tab surface tissue expanders, to utilizing completely smooth, round, cohesive implants. I think a large component of making prepectoral work is using air expansion of the tissue expanders. And I would say most importantly, that worse before better has been my revision rate and my fat grafting, which was relatively low in the beginning, incredibly high when I first started prepectoral. Every single patient required fat grafting to fix the transitions around it, and now has plummeted with the use of the escape method. So my prepec is all cases since 2016. All of them require ADM. These are my preferred techniques, which I've already said. And about 80% are two-stage, 20% are direct to implant. This just demonstrates an ADM wrap that I utilize for these patients, again, using human ADM for all of these. And I think the ability to have tabs on tissue expanders and fixate it to the chest wall is critically important for prepectoral success. Mesh is nearly essential in all of my prepectoral reconstructions, and so therefore I use it for both primary and secondary reconstruction, as well as revisionary surgery. I think that it's important part of my learning curve was to actually hold off on using it in radiation therapy, and that was some of my last reconstructions to go pre-pec, because I thought that the muscle would actually protect that implant in radiation. But what we found is that there's higher complications and actually higher capsular contracture, mostly from that muscle. So much fibrosis in that muscle makes it much more of a foe rather than a friend. And I would see that in patients where one side is radiated, one side is not, the ADM acting as a block, preventing contraction and not having the muscle there really kept these pockets pliable even when it was radiated. When I looked at outcome studies of radiation, I found that while complications were higher in the immediate postoperative setting, the first 6 weeks, they significantly dropped off in the long term. And even with prepectoral reconstruction, ADM actually was an independent predictor for protecting that reconstruction from explantation. And so that's why ADM is an essential part of my practice for prepectoral reconstruction. I would be remiss to not note that the ADM indication is specific for xenografts as a transitory scaffold for soft tissue support. For allografts, it's supposed to be used for homologous use, and therefore this entire presentation is unfortunately off-label because ADM does not have an indication within breast reconstruction. This just demonstrates our informed consent that we give to all patients that are receiving ADM with tissue expanders, warning that the FDA has not cleared it for this approval. Now, going on to the technique portion of this talk, the main reason why I changed my technique was this patient, which arguably was one of my worst outcomes with prepectoral reconstruction. But you see some of the stigmata of prepectoral, which is device step-offs, particularly prominent in the superior aspect of the breast, sharp edges that can actually break down the skin. You can actually see this patient who was radiated and the tissue expander started eroding through the skin. But it was these step-offs that I saw less so, but in all patients that had prepectoral reconstruction. And I noticed that all of these patients I was requiring fat grafting at very high rates and very high revision rates. I liked prepec, but I also had to revise it quite often. And this just demonstrates that fat grafting of the sulcus between the clavicle and the breast implant that frequently needed to be fat grafted to get a more natural transition in the décolletage area. In fact, if you looked, I originally required about 67.3% of prepectoral reconstructions needing fat grafting to only a quarter of my traditional submuscular reconstructions. And I kept asking, why was this, and was there a way that I could decrease this? Well, the idea is, if you look at this, the main anatomical breakdown here is a disruption of Scarpa's fascia. So you've got the pectoralis muscle, you've got the expander implant, and Scarpa's fascia has released and retracted upward in the breast. And we didn't worry about this so much when a muscle was on top, but it's much more obvious now when you don't have that muscle in place. And we can actually avoid and decrease our revision rate by reattaching that superficial fascia. And so that brings us to the escape method, which is that the expander has a 2-point fixation to both Scarpa's fascia and to the pectoralis major muscle. And that's decreasing fat grafting in my practice down to 1 in 3 patients, so significantly plummeted to near levels that I used to do with partial muscle coverage. And this just demonstrates where I actually recruit that Scarpa's fascia and I bring it down and I make sure it's in continuity with the expander and the ADM complex. The underlying anatomy for this is that Scarpa's fascia is in continuity with the superficial fascia of the breast. It's important for that breast to move naturally, to have natural transitions all around the breast. And this just demonstrates that the escape method. It starts with fixation to the chest wall, both tabs as well as the ADM. And you can see I've brought a lip of the muscle over the top crest of the tissue expander to actually hide it, to give a more natural transition. Then I find Scarpa's fascia and I actually recruit it, draw it forward, and actually sew it to the ADM. 2-point fixation to both the chest wall, the pec, and also Scarpa's fascia. When Scarpa's fascia is recruited circumferentially, you replace that gap all the way around. And it's most important in the axilla, where you want to draw all that tissue that's fallen by the latissimus dorsi muscle and bring it back up to your construct. You obliterate this, and you get a really nice axillary transition, and you also get rid of all of the stigmata that we see with prepectoral reconstruction. And this gives much more natural transitions in the lateral aspect of the breast. In the superior aspect of the breast, we can't see that there's a device there anymore. What I also like is that we're still getting the benefits of pre-pec. Notice the cleavage line. We still get much more rounded that we would never see with a sub-pec reconstruction, but also we have natural transitions. It's the best of both worlds. It's not just for primary reconstruction as well. We also use it for secondary pectoral reconstruction, which is a site change. And you already saw the presentation by Dr. Afifi this morning demonstrating site change, but I would say it's also very common in my practice to get rid of muscular distortion. In this situation, I dissect the pectoralis major out of the skin flap, very similar to the technique shown this morning. I will usually use ADM reconstruction in these just for pocket control if I need it. I place the device underneath there, and by releasing the capsule all the way around, I'm able to re-identify Scarpa's fascia, and I'm still able to make sure that I recruit it. You can just see the gap there where Scarpa's fascia has been released, and here where I've actually done capsulotomies all the way around so that I can actually see Scarpa's fascia in suture the ADM directly to scarpus fascia, keeping it in continuity. I think that's the real trick to making these as natural as absolutely possible. It's tough to see through such a limited window, but absolutely key, hooking that up and actually sewing it to the device. This just demonstrates all patients. None of them were fat grafted. All of them are pre-pec and demonstrating much more natural cleavage lines, superior poles, as well as natural lateral axillary lines. I also want to bring up our institutional experience. This study was led by Dr. Jesse Selber, a 2-year experience looking at ADMs and prepectoral reconstruction. And interestingly enough, we found something different when we looked at patient-reported outcomes. We did not see a difference or an improvement when we compared prepectoral to subpectoral reconstructions. I think that it's interesting in the surgeons that have presented already, they demonstrated in site conversion, they do see improvements. But when these situations, when they don't have that precedence to compare it to, we still don't see an improvement in pros with prepectoral reconstruction, but we do see improvements in time to tissue expansion as well as time to exchange. And so we definitely think that there's much more benefits, and we've seen this in a shift in our own practice from 1 surgeon doing prepec in 2015 to 23 surgeons in 2022. I want to end there. So in conclusion, prepectoral reconstruction demonstrates enhanced medial pole fullness, more rounded reconstructions, better projection. I would encourage you to try the escape technique. And key to this is recruiting the breast superficial fascia for continuity to the ATM. Thank you.
Thank you, Mark. Great results, and I really like the technique. So, do you do any subpectoral? Is there any place for subpectoral anymore?
I don't anymore, and there's a few things that I say I never do. I guess the exception to that is that I think it's important when you're doing pre-pec to have conversations with your radiation oncologist and make sure that they're on board for the patients that you need to radiate. And so my exceptions are tumors invading into the pectoralis major muscle or within 1 centimeter of the pectoralis major, which may change the targets that our radiation oncologists have to utilize. So that would be my exception. And I encourage plastic surgeons to have those conversations before taking patients to the operating room.
Thank you.
Mark, it's really innovative, that technique. I just had a question for you. Do you find that you change your tissue expander height depending on where that scarpa's layer is, or do you try to bring that scarpa layer down to a standard height of a tissue expander?
So I use a full height tissue expander on all patients, and I used to tailor it based on body habitus, and I thought maybe a medium height for a shorter torso. And yet, after a while, I just felt like almost everybody needed that full height, because the tissue expander wasn't so much about creating the breast so much as it was setting the footprint and getting the construction all the way up to that cut scarpus fascia. So you're right, I want as much height as I can to get that continuity. And then I'll use the implant maybe to get a different shape.
Thank you. I'm Fabio. So thank you very much for your presentation. You know, we are, of course, using 2 different devices, and we have different approach between Italy and USA. I must confess and disclose that my last tissue expander, I used it probably 7 years ago, 10 years ago, so I don't even remember when. And we use, as I showed before, the full wraparound patch, which we can call it simply ravioli style, Italian ravioli style. And actually, I'm doing exactly what you are doing, but I didn't understand I was doing. And that comes probably from the autologous reconstruction as well. But when we go for autologous, we grab the scarpa fascia on both sides in order to improve this. And so I just naturally did it, but I didn't understand the reason why I was having good result. But thank you to point this, because it's very important. Of course, by using the full wraparound, I liked also to grab to the muscle, because differently from the autologous, that I don't take any bite into the muscle in order to have immediate and quick positioning of the autologous reconstruction. Otherwise, it takes much longer if you grab the muscle. But with this one, I find it's necessary to fix it on the muscle all around and keep the fascia. Thank you very much for pointing this.
Yeah, I say that to our fellows. When you're putting in a deep flap, it's not about suspension of the D flap, those superior sutures. It's about reestablishing the continuity to an anatomic plane. You want to purposely grab that scarpus fascia. It's not just about suspension.
Mark, if I could make one comment. I see a problem with presentations, and this is generally speaking, about techniques that get certain technique improves the results, et cetera. My own feeling about this in general in the evolution of techniques is that the mastectomy has gotten a lot better over time. I mean, significantly better.
Yeah.
When we went to nipple-sparing mastectomies, suddenly the breast surgeons paid more attention to the mastectomy, and even their non-nipple-sparing mastectomies are better. So if you're comparing old techniques to new techniques, they should be within the same time period, not looking at historical controls, so to speak. Mm-hmm. And yes, I think a lot of these things certainly make a difference, but I think what we're dealing with now is a very different animal in terms of the mastectomy itself.
Yeah, I completely agree. So many compare historical cohorts for the submuscular, comparing it to how we do pre-pec today. That paper that I just showed actually was one time period, 2018 to 2020, so that you didn't compare to a historical cohort, but did represent as the institution was changing in technique. But great point. We're going to stop now for the break. I think we have 30 minutes. Is that right?
Yes.
Yes, 30 minutes.
So what time does it say we're coming back at?
11.
Okay, so we'll return at 11 o'clock. Thank you.
Thank you. That was great.
Really good papers.
Great talk. I really like those results.
Those are excellent, yeah.
Let's get started. All right, so now begins the autologous breast reconstruction session, and I'm a little biased around this. So although autologous may not be the most common form of reconstruction, we all know, especially as microsurgeons, that is the best form of reconstruction. And so Dr. Selber is going to start off and talk about the robotic DIP flap. Thank you.
Thanks for teeing that up for me, Dr. Garvey. Thank you for the invitation, Mark and Fabio, and to the moderators for their attention, and welcome to Houston for all of you who are out-of-towners, and for the familiar faces, hello. So I'll be talking about the robotic DEEP. I'm Jesse Selber, Professor and Vice Chair at MD Anderson Cancer Center, where I've been doing most of this work. And go. There we go. These are my disclosures. So I've struggled with a conflict about autologous breast reconstruction for a long time because I have offered it in the traditional fashion, but it's not an operation that I would personally get. And the reason I wouldn't get it is just because of the potential for long-term morbidity of the abdominal wall, which I find to be relatively common. And I think the goal of breast reconstruction is to restore a sense of wholeness and well-being after breast cancer. And anything that detracts from that is really detracting from the purpose of restoring wholeness and well-being. So that's the perspective from which I'm coming here. And abdominal bulges are relatively frequent. They mostly occur below the arcuate line. They don't always, bulges I don't think are the biggest problem even. I think discomfort, long-term discomfort is a real problem though. Getting out of bed, they usually feel it just above the incision, in between the arcuate line and the incision. And the magnitude of this problem is not tiny. This is a recent pretty good study by Nick and Samit in UT Southwestern, just looking at their series, and they're doing this all the time. So this is in very good hands, and their findings were that there's a 10.5% abdominal wall morbidity rate. They admit that this is probably low because this is a retrospective analysis. My experience is that this is also low. And so the question in my mind is not, are we doing the right thing? Obviously, autologous breast reconstruction is critical, as Patrick said, and in some cases it's absolutely necessary. I'm just not sure we're doing it right. And the history of abdominal-based autologous breast reconstruction recognizes this tension. So we started with a pedicle tram. Free tram improved reliability, but not morbidity. Muscle-sparing free tram, I think, incrementally improved morbidity. The SIA is a bit of an anomaly. It's vascularly not super reliable in my hands with the artery small. Most of us don't use it at Anderson at this point. And then the DIP, which has been the enduring state-of-the-art for about 25 years, hasn't really changed much, honestly, since it started getting done. This is what I learned to do in residency, muscle-sparing free tram. I think to sell this as an abdominoplasty in somebody's practice is very disingenuous. It's not abdominoplasty. This is much more serious than iatrogenic hernia on some level, and in certain ways it's worse because it involves the muscle, not the midline, and it should be expected to follow that natural history. Standard deep incision's not that much better. I went around and clicked a bunch of pictures in the OR. I have very good partners, but it's just, it doesn't look that much different than the muscle-sparing free tram to my eye, if you just look at the donor site. So Joe Cerletti and I started thinking about this way back when I was in residency, thinking that it wasn't what you left on the flap, it was really what you left in the abdomen, and then looked at this prospectively, and that turned out to be pretty true. So for unilaterals, we blinded all our physical therapists and lots of PROs, and they weren't that different. Bilaterals, you could tell the difference, but the physical therapists could tell, but the patients couldn't really tell. So I don't think they're too different in the end. And I think you can see why, or I think it's pretty obvious why. Let's see if this laser pointer works. Yeah, so what we want is the perforator, but it has to be connected to the pedicle, which is behind the muscle. Perforator is in front of the muscle, pedicle's behind the muscle. So, doing that, you have to open the muscle to approximately where you want to get the perforator out. I shot these in 2005 in Ghent with Phil Blondeel. So it starts all right around the perforator, but then you do this, and then you do this, And this is, basically a textbook deep. We're still doing them like this. This is the major nerve. You split only till you have to and then come in from the side. But, the colon's still pushing up at you. And I think even though this is the right way to do it, we'd be fooling ourselves to think that this is going to go back to completely normal. I think that's unrealistic. When all we really want is the vessel and the skin and the fat. People have tried to shorten the pedicle up. The paper by Mike Sincere, I think, was pretty good. But when you shorten the pedicle up, you decrease the caliber. And so, for those of us who don't like to make micro more complicated than it needs to be, long pedicles and large calibers, they keep you out of a lot of trouble. So for me, that's not a good trade-off, personally. And so I've been thinking, is there a better way to do it? And this is my solution to that problem. So the robotic deep gives you all the pedicle length that you want and minimizes abdominal wall morbidity, I think, more than any other way to do this. And I'll go on to this video, which is kind of a short summary of the way this works. CT scans are really important. I'll go back to that in a minute. The incisions are the same, and the dissection, what's different is the dissection around the perforator just goes down to the posterior sheath and stops. And then you go intra-abdominal. This particular part makes me cringe because I don't use a 12 port anymore. Oops, that's not what I wanted to do at all. Sorry, guys. Hang on, I'm gonna get it done here. And go. Okay. So, yeah, this delay. So the CT scan's important, as I said. I'll get back to it, why it's important. There's no getting around making the skin incisions, right? So it's just about the muscle and the fascia, just down to the posterior sheath, that's it. And then port placement. Like I said, I don't use this 12 port anymore. I use a 5 there. If that looks big, it looks big to me. And then this is an intra-abdominal operation, so that's the thing. Not everybody does it that way, but I think that's the best way to do it, or at least in my hands, works the best. This is the meat and potatoes of the operation, which is the exposure and dissection of the deep vessel. So, I think what you want to notice is that, so down here we're below the arcuate line, and that bulge that you get with that strength layer of the confluence of the anterior and posterior sheath doesn't happen below the muscle, happens above the muscle. So all you're doing is unzipping the posterior sheath, or the peritoneal lining here, and you're dissecting the vessels off the abdominal wall and then ultimately off the rectus muscle. And you don't have any retraction in here, you're not dissecting muscle down here, you're not dissecting anterior fascia at all. And for patients with the right anatomy, and you're missing all those motor nerves, with the patient with the right anatomy, you're really avoiding any of the structures that cause people problems with abdominal wall discomfort. Now, you can't do this on everybody, and I'll tell you who you can do it on and who you can't, or where the juice is worth the squeeze, in my opinion. So then you divide using a clip, or you can use, you can do that thermally, and then just pull it right out the hole, and that's how you get to here. And for periumbilical perforators, or where most perforators are around the umbilicus, you get about a 13 to 15 centimeter pedicle pretty reliably. And if you select right, you can get pretty short fascial incision. Then whip stitch this closed with the barbed suture. The entire robotic part of this case takes about 45 minutes. It's taken as little as 30 minutes. It took more than an hour once, and that's it. And that part comes out of the open time. So it's for me, it's pretty time neutral. But of course, there's a learning curve there. This is sped up naturally. It's not. It's quick. This takes 10 minutes, but that's the whole talk. So anyway, so then you tie those off. This robot fingers are strong, so you can pop those off, and then you're moving on. You can also do the micro with the robot. I don't routinely do this, but it's definitely doable. There's a whole kind of universe of robotic microsurgery that could be talked about. It's a different discussion, but I think it's it's a pull-through application that's worth at least mentioning here. For these vessels, these size, it probably doesn't matter too much, but as we incorporate lymphatic work in our routine breast reconstructions, robotic anastomoses are going to become important, and we're doing that more and more. So there's some new microsurgical robots afoot. This is one out of Maastricht, Holland on the left, and out of Calci, Italy, MMI on the right. These are both really good devices. The one from MMI is probably going to make landfall in the US. Actually, we've got 2 units already there. This is a sort of a shameless plug for my dilator. This is not really a dilator, it's a coupler sizer. So you get these little rings are 0.5 millimeter each, and then you just stick it in the vein. It tells you what coupler to use. What it mostly helps you do is waste couplers or also be too conservative about the size coupler, because you always want to maximize your coupler size. So I think this keeps you out of a lot of trouble. I get no royalties from this. I have no equity in this. Literally just use it because it's a good device, or don't. So just a series of pedicles and the holes they came from. You can see, this pedicle came out of that hole. That's basically like a port site, right? 1.5 centimeters. Here's another one, a little bigger. Another one, probably 3 centimeters, somewhere in the 3 centimeter neighborhood. So why are they different? So patient selection is really important. I know I'm running out of time. I'll get there quick. You have to, what I try to do is 1 or 2 closely grouped perforators with a short intramuscular course. If you've got that anatomy, you're going to have a really good robotic deep. I think the bottom line here is A, that A number. So if C is the whole length of the pedicle, B is the submuscular course, and A is the intramuscular course. So why this is valuable to me is I can measure this, and then I can, in the consult, say, this is what your fascial incision is going to be like. It's basically equivalent to that number A. I'll take a picture of it in the operating room with the ruler. I can show it to the patient afterwards, and that provides a lot more control in your consult than just saying I'm going to wander around in there and do whatever I need to do to get the vessel out. That's what I would want, somebody who could tell me I'm going to have to make a 10 centimeter fascial incision, or it's upsetting.
Yeah, it's your apps rules.
Okay, so this is the sagittal view. I'll pop through these real quick. We're sort of at the end. Bilateral can be open. The anatomy is not necessarily symmetrical. Open, there's a robotic one next to an open one. The good things, I think it maximizes pedicle length, minimizes fascial incision, very little muscle splitting, no motor nerves cut. And I think at the end of the day, which incision would you prefer? Would you like the one that looks like a port site, or it looks like a beaver gnawed at you for a while? I think, it's better to have this. I think everybody would like the smaller incision. I don't know if this is the next step in the evolution of this for the young people and the patients to decide, really. It's certainly revolutionized my operation completely, and I wouldn't go back. I think it's also important just to mention on the last slide, it's important not to judge the end state of innovation by its current state. This is the first, basically, generation of these devices, and computers, used to be able to add a column of numbers and fill up an entire room, and now you've got 20,000 times that computing speed in the palm of your hand. So I think we can expect robotic technology to follow a similar trajectory and expect pretty exciting things for the future of that. So if there are any questions, happy to take them. Thanks for your attention.
Thank you. So we're going to do it a little differently this time. We're going to start with questions from the room first. So any questions? Is this a question? Here we go. Yes.
Jesse, I love what you're doing. How many of these have you done, and what percentage of your deep flaps are robotic?
I've probably done mid-50s, and percentage about 70. Yeah, so it depends. So there's a slide rule, which is like how long does your fascial incision need to be before it's not worth it anymore to dock a robot? And so my cutoff personally is 4 centimeters. Some of my partners have argued that anything north of the arcuate line is good enough, to do it. And so you can expand these indications, because I think that's where all the problems are. So I think if you can stay above that, you're justified in doing it.
Thank you, Jesse. Venturi, Washington, D.C. Peter actually stole my question, so I'll think of another one quickly. You mentioned CTA, which I think is very important when picking perforators and looking at connections to the superficial venous system. But when you were showing the 2 pictures of the muscle sparing and the robotic, if you picked that same perforator with a regular deep, you could probably keep the incision pretty small, couldn't you?
Yeah, it depends. I mean, in my hands, I can't do like a 4 centimeter incision and get 13 centimeters of pedicle length. I can maybe get, 7 centimeters or something like that. So yeah, I mean, you can definitely push that, but I'm not getting the pedicle length that I want. I'm not getting the visualization that I want. So I always end up splitting more than I want to. And people eyeball it and say, yeah, well, that's about 5 centimeters, and maybe it's 8, you know, but it's never quite that small. You know, you don't get 1.5 centimeters, you don't get 2 centimeters, you rarely get 3 centimeters. I think minimum 5, I would say, open.
Hi, this is Santanelli. Jesse, thank you for your presentation. It's excellent. It's very difficult to find something, you know, to tell you, but I found a little. In the history of autologous reconstruction, come first the free dip flap, the free tram flap, and then the pedicle. It was described 1 year after the pedicle by Holmström, the year before in Sweden. And that's the only thing I could find. But I want to ask you something. Is it, I feel like, you know, the Jethro Tull, I say, too old to rock and roll, too young to die. And so I'm really fascinated by this procedure and the possibility to do it. But every time I find, well, maybe this is not the right case, then I have to get trained, I have to call the general surgeon. My question is, having 0.5 laparoscopic complication among 700 cases and more than 700 cases, and 1% bulging, is still worthwhile?
Probably not. I mean, honestly, with those numbers, if you have a 0.5 rate, you know, 1% rate of if you have an overall abdominal wall morbidity rate of less than, you know, some small single-digit number, maybe less than 5, you have to think seriously about whether it's worth it. I don't think that's what most people's numbers look like.
I was hoping you were pushing me a little bit more. You know, now I will never go for it.
Well, I've got something.
I'm too lazy to go now.
I've got something special
I
for
would
you
say
in particular.
Jesse said probably is not worthwhile.
Yeah, but
thank you, excellent presentation.
Here's something to think about, Fabio. I know that you go to the thoracodorsals, right?
Yes, exactly.
Yeah. So, I mean, we're now doing robotic nipple-sparing mastectomies from the axilla, and so, you know, being able to do a robotic nipple-sparing mastectomy plus a robotic autologous reconstruction with potentially one of these robots with a robotic anastomosis in the axilla is definitely a full-service model that you could consider pursuing, because you're already doing that.
Yeah, that makes sense. Thank you very much.
Okay, we're going to move on to the next talk. We'll hold that question. Sorry, we're out of time. Okay. Yep.
Thank you.
Okay.
All right, our second talk is going to be, let's see, autologous fat grafting for total breast reconstruction, Dr. Sorotos.
Hello, good morning, everybody. Thank you. I would like to thank Professor Santanelli and Professor Clemens for the invitation. And I'm not going to be using any robots during my presentation. So, I would like to invite you to the next conference, 13th, 14th of October, 2023 in Rome. I'm going to speak about autologous fat transfer for total breast reconstruction. And in our experience, we use fat transfer for various indications. So we use it to augment the flap when we have patients with insufficient donor site volume, and we get pretty good results with that. We described the latissimus dorsi, fat-augmented latissimus dorsi flap for total autologous breast reconstruction back in 2014, and we were able to increase the volume of the latissimus dorsi without any implant. And we have recently published our long-term results with the same technique, also getting very good results. But today I'm going to focus my talk on fat transfer and total breast reconstruction. So we first described our experience in 2014. We had few patients. They were a group of patients that were irradiated after nipple-sparing mastectomy, and some of them non-irradiated. There were 34 breasts, 13 unilateral cases, 8 bilateral cases. We use a very standardized technique for throughout our experience. And we found out that, you know, this is a reproducible technique with very good aesthetic results. It is effective both in irradiated and control patients. It can offer an autologous reconstruction in after nipple-sparing mastectomy. We offer aesthetic improvement in donor areas and breast tissue quality improvement. Of course, it was a small population. This technique, it cannot be offered to people to patients with inadequate donor site volume. We can only reconstruct small and medium-sized breasts, and we need to operate patients for multiple times. So the aim of the current study that I'm going to present to you is to define a systematic approach for total breast reconstruction with autologous fat transfer after nipple-sparing mastectomy. we increased our numbers, and we wanted to validate our protocol for irradiated patients and extend the indication for patients with smoking history. So we collected data. Prospectively, we included patients we had indication for nipple-sparing mastectomy, small to medium-sized breasts. Exclusion criteria were comorbidities such as diabetes and local or distant metastasis during the procedures or ischemic complications of the mastectomy flaps. These are the data we collected. We have in total 117 breasts, 3 groups, radiotherapy group, smokers, and control group. Also, in this case, we use the same standardized procedure. We do most of our procedures in local anesthesia and sedation. We do liposuction. We centrifuge in a classic technique with 3,000 rounds per minute for 3 minutes. We use our autologous fat transfer system with a Luolock syringe and a small cannula. And we use a standardized fat transfer protocol. So we usually inject the first session of fat transfer is 1/3 of the mastectomy volume. And then from the second session on, we add 30% more volume compared to the previous session. Of course, this is not always the case because in irradiated patients, it's not easy to give this volume in the first session. And we start with fat transfer a little bit later. So we wait for them to finish the radiotherapy, and we start with the fat transfer 2 months afterwards. This is our timing. We did an aesthetic analysis and subscale analysis of our results. What we found is that our groups were homogeneous for age, BMI, and the mastectomy weight. So we didn't find any differences in that. When it comes to the number of sessions needed, what we have to notice is that patients with radiotherapy need more sessions. So you have more fat resorption probably, so you need to inject them more. But this is not the case for patients with smoking history. The same goes for volume, so we need more volume for patients with radiotherapy compared to groups with smokers and control groups. And then our follow-up was not statistically significant. Regarding the aesthetic results, we had good results with all groups. What was not very good, let's say, was the skin texture due to the radiotherapy effect in the group A. And of course, this impaired the total score. We recently published our results in PRS, and we think that this technique can be easily reproducible. So I'm going to show you some cases. This is an irradiated patient. After the first and the second session and the third session, we can get some very good results and very good volume. The same patient, oblique views. Another irradiated patient. And then this technique can be applied also in cases where they had previous quadratectomy and radiotherapy, and with some scar release, we can actually move the nipple a bit inferiorly to get a better result. So we do the rigotomies together with the fat transfer. And then this is a patient with a smoking history. And these are control patients. Let's say these are the easier patients to treat. And we can get good results also in this case. As you can see, all patients have inferolateral mastectomy access for the nipple-sparing mastectomy. Okay, some more cases. We are able to increase the volume after every session and achieving the final result. We usually decide our patients how much volume they want to reach. So as a conclusion, this is an effective, reliable, and reproducible technique. It is an alternative for total autologous reconstruction. We confirmed our indication for irradiated breasts and extended our indication to smokers. We offer aesthetic improvement on the donor areas and breast tissue quality improvement. One more conclusion I would like to add, and it's a question that we usually get when we have presentations about fat transfer, is oncological safety. So we recently presented our 1,000 cancer cases in a masked case control study, and we found out that there is that fat transfer was not associated with a higher probability of local regional recurrence in patients undergoing breast reconstruction. So we believe that it can be safely used for those patients. Thank you very much.
All right. Thank you. Excellent presentation. We'll start with Dr. Clemens.
They're really extraordinary, and I've tried these in my hands and I can never get them to look as good, but just seeing your presentation makes me want to keep going back and just try this in the properly selected patient. My question goes to the oncologic question, which you kind of ended on. Not that it would lead to higher breast cancer recurrence, but specifically that it would lead to more biopsies or calcifications or questions of cancer. It doesn't have to be cancer to still be problematic for a patient. We don't see that at MD Anderson, but can you speak to that element? Because I think that that's another area that might cause people to hesitate in trying this technique.
I totally agree with you. I think from that point of, we are very lucky because our patients are followed in our hospital, which is not a huge hospital, and we have the same radiologists that follow the patients post-op. So they are patients that they know, they know the kind of techniques we use in reconstruction, so they are able to follow those patients, and we don't get so many biopsies for lesions that they know that might be something connected to the fat transfer. We don't have so many complications regarding cysts or any other problems with the fat transfer. We try to keep our volumes low, so without exceeding and putting too much fat in every session. Sure.
I have a couple quick questions. How do you counsel patients that this is basically going to be a delayed reconstruction and they're going to be flat after their mastectomy? I find for some of my patients that's the most challenging part of the conversation.
You're right, and this is challenging also for us. We are a center with a very high percentage of immediate breast reconstruction. We do a lot of DF flaps and latissimus dorsi flap with fat. So I think the way to propose that is patients with small breasts, so that they can accept to be, with almost nothing for a couple of months, and then they can slowly have a decent reconstruction.
And then,
was there a question from the floor?
I'm Santanelli from Rome.
Okay.
I want to add one point to what Mark asked. I see in many presentations that people are doing fat grafting, but they abandon the use of 1 millimeter cannula to deliver the fat. I think that the key of the result in such a case is that we keep it. So we are very obsessed by that. And so we prefer to do it several passages with very small amount delivering, and that really reduces the number of calcification that can raise the question of the biopsy. So we never use this kind of 2 millimeter cannula, absolutely not. We go with the technique that we show, and that probably can be the key point.
So along those lines, where are you, at least for the first operation, where are you injecting the fat? Is it in that space where the breast tissue used to be, into the pectoralis fascia or muscle, into the subcutaneous flap itself?
So we try to find as much space as possible. We usually inject in the space of the mastectomy. We go also below the pectoralis major muscle in the space, and also in the fascia. But it's not easy to say when you go blindly where to inject, but we try to keep it in those places. We never inject the muscle.
Time for one more question.
Yes. What's the amount of fat necrosis in your patient group? You really saw excellent results. I'm very impressed, and I have the same opinion. In my hands, I have some of these good results also, but most of the patients I'm treating then, they present fat necrosis.
So we had one patient that had an infection post-op, not fat necrosis, an infection, and that was a setback. We had to let her freeze for some period and then inject her. Fat necrosis, like we never had something that pushed us back on the reconstruction or impaired the reconstruction. No.
Okay, great. Thank you very much.
Thank you very much.
So the next speaker is Dr. Cheng. And she's talking about no implants, no flaps, no problem, Goldilocks reconstruction post-mastectomy.
Thank you. Thank you, Mark, for this wonderful title. Where's the clicker? Oh. So today, thank you for the invitation to speak. I'm going to talk about a procedure that kind of came from my institution, so I'm not going to claim credit for all the photos. Some of these also belong to my partner, Bert, who's here. But Goldilocks reconstruction is what we're talking about if you're not familiar with it. So it's not, oh, sorry. I have to learn how to use this clicker. Okay, sorry. So I have no disclosures other than, like Patrick, I am a microsurgeon, so I do enjoy doing flaps. Also, I have no BMI limit, to the dismay of my residents.
Also like me.
And finally, like I said, some of these photos belong to my partners that I'm going to be sharing today. So Goldilocks and the Three Bears, we all know this childhood story, right? She goes around and eats their porridge. It's too hot, it's too cold, something's just right. And this really is how this is analogous and how this technique was named is because sometimes you're free flap, your donor site's not big enough, sometimes your implant's too small, and this is where you want to be, which is home in bed, happy and not worrying about your flap. So this is the problem. This is what rolls into my office. And these are patients who are not good candidates for implants. They're not good candidates for flaps. The patient in the middle has had component separation for hernia repair. Other patients, you can see they're wheelchair bound or they're just completely uncontrolled medical comorbidities. And this is just a smattering of what rolls into our office. So here's an example. What would you do for this patient? So she's getting bilateral mastectomies, very large breasts, inadequate abdominal donor site. Some people might offer her implants, some people might offer her stacked flaps, but all these are very complicated options, and she has some comorbidities that don't make her a great candidate for a long operation. So you can stew over what you would do for this, but I'm going to show you at the end what we did. We all have our standard toolbox, and I'm not arguing that flaps are good, implants are better, or whatever. The right tool for the right patient is what you need. And this is like a little extra widget you can add to that toolbox, which is the Goldilocks mastectomy. So we're going to deviate from the standard. So some patients, stack flaps are great. It's a long operation. You typically are going to need a partner to do that, and that's not always feasible in private practice. So this might be a good alternative. I've done plenty of flaps where I go back and add an implant for volume, but again, now you're like doubling the complications potentially for this patient. We've also had patients, you go back and add fat for extra volume, and that's a great option, but again, you're kind of limited in how much you can add, and a lot of them just don't want the extra surgery. We're also starting to get some pushback on fat transfer being reimbursed here in the US. And then as our previous speaker just showed, you can do fat only. I just don't have BMI patients. I'm very jealous of your BMI 22, by the way. So what is Goldilocks mastectomy? So this is an in-between option that offers a patient some sort of reconstruction with their own tissue, but isn't involving implants or flaps. So the original paper was published by one of our graduates about 10 years ago. And so it's utilizing your WISE pattern skin marking, which is something every PGY 1 and 2 learns to do. And it's deepithelializing all the remaining intervening tissue and folding it onto itself to create a breast mound. So this is not very difficult to do. I can step out of the room, do another case, and leave a junior resident to just de-epi for hours. But this is a great in-between option for somebody who's not a good candidate for immediate complex reconstruction. This is not a good operation if somebody has small breasts because they are going to be significantly smaller. So here's her clinical example in her paper, and here are some more examples of patients. And you can see on 5, the right side is just a straightforward reduction, but the left breast is created simply out of the mastectomy skin flaps. And it's a pretty good match. There's no implant, there's no flap. She's gone home the same day, and you don't have to worry about her T-junction breaking down. Same thing on 5F, it's a contralateral reduction and then a mastectomy reconstruction. Oops. So who's a great patient for this? And this does require good selection. So you want somebody with relatively large breasts who's happy to be smaller, and most of these patients are thrilled with the idea of being smaller. This is usually a patient who doesn't want an implant or doesn't want a flap. And for some reason, we're seeing patients who don't want the long surgery, they can't afford the recovery because of work or social situations. Or in my patients, we have a lot of African-American patients who are very averse to additional scars. And sometimes there's just inadequate donor sites. So this does give them a one and done potentially.
The cases that were shown before, the nipple wasn't preserved, but you can sometimes preserve that on the pedicle. And so again, they're just one stage operation. And then most often, I'm using this for a suboptimal patient. So I've had all of these. I've had the morbidly obese BMI 70 plus who are smoking with uncontrolled diabetes, or the anticoagulated Jehovah's Witness that you just don't want to do anything. And so this is a nice in-between option that you're not just turning the patient down. You're saying, well, I want to help you, but I don't think implants are great, and I don't think realistically they're going to get their BMI down from 60 plus, so this is something I can do for them. So surgical markings are critical here, and this is where I made a mistake early on when I first started to do this. You want to mark your wise pattern, but you don't want your breast surgeon to actually cut on that. You're going to separately mark this small elliptical incision. In the original paper, she did this to a periareolar incision, but a lot of the breast surgeons will struggle to do a mastectomy on these larger breasted patients with a small incision. So just give them an incision they're familiar with, which is this nice transverse incision. They can do their whole mastectomy through that, and then that preserves all that other tissue you see in between your Ys and that little ellipse. And that's what you can use for volume. So, oops, sorry. So here's just another patient. She's had neoadjuvant chemotherapy. She's a 44G. She's had component separation, like I said. So deeps are off the table. So here you walk in the table, it's a little scary at first. The skin flaps look really terrible. The mastectomy's been done. If you do have SPY, this is a great opportunity to use that so you can discard what doesn't look good. You're gonna deepithelialize, like I said, for a little bit of time. And then it's not just stuffing it underneath your skin pattern. You can actually make back cuts along your IMF, and then you can cone that tissue using Vicryls, PDS, whatever you prefer, to create a small breast mount, then re-drape that skin flap superiorly with your wise pattern to create a cone. So here she is on table. They're not large breasts, but you're done, and she's off the table and going home the same day. So, word of caution, results can be variable. This does depend on the quality of your skin flaps. And so I'm going to show you some examples of very bad to very good. So here's one of mine. This is a poor result. And why was this a poor result? Like I said, when I started out and made this mistake, I didn't mark the separate incision for the mastectomy. So the breast fellow came and cut on the wise pattern, elevated mastectomy skin flaps, and I ended up with a lot of dead skin. And so you can even see that kind of discoloration on that right side. That ended up all being kind of fat necrosis and just melted away. And and I was lucky that I had to actually use the skin from the inferior aspect just to get her closed, because I had to trim away so much skin. So here's an acceptable result, and it's not great, but I think most of us would not want to touch that abdominal donor site. She's going to have a high rate of complications and wound dehiscence. She's so obese. Here's what I would say is a satisfactory result. It's a right reduction with a left Goldilocks procedure. Her body habitus is just prohibitive for a good flap reconstruction. Here we're going to get a little bit better result. This is one of Dr. Loskin's. Here she is early post-op, and then after a few weeks, when she settles, she just needs a nipple tattoo or reconstruction, and she'll be done. And here's what I would consider, a much better result. We're getting better here. Again, she's nice symmetric breast mounts, and she's one and done. Her shoulders are lighter. She's happy. Here's one of mine. This is a 14-year-old with a juvenile gigantic fibroadenoma. Here she is on table. It's almost a 2-kilo specimen. And so you can just take what's left, harvest your wise pattern, deepithelialize all that. I was able to keep the nipple for her. Here's her early result. I only ever saw her one time, 10 days post-op. She disappeared. I presume she's happy living her life. So careful patient selection is important. This is not something patients are going to see on the internet and find on Instagram, and so they don't know what you're talking about when you propose this. So you really have to spend some time counseling them on what you're planning to do. Like I said, the results are going to be highly variable depending on the amount of tissue you have left, and you need to warn them that because they might need a secondary procedure. But you have time now that they can come back when their diabetes is controlled, when they stop smoking, to add an implant or add fat. So here's just some examples. This was that patient earlier, Dr. Loskin's. Here she is on table in her immediate post-op, and some people would be perfectly happy with this. This particular patient wanted a little bit more fullness. This can sometimes still be kind of a flat reconstruction. So he went and added, oh, that didn't show up. I don't know what happened to that photo, sorry. She added 400 cc implants and just had a fuller result. Here's one of mine I did about a year and a half ago. She has multicentric disease, totally uncontrolled diabetes, uncontrolled hypertension. So just not a great candidate for immediate autologous or implant reconstruction. This is her immediate result 2 weeks out, a very nice result. But again, I warned her some of this might die with fat necrosis, and here she is a month later. You can see the right side's lost significant volume. I offered her fat grafting just to correct that, and that would have taken care of this, but she missed her large breasts, so ultimately she asked me to put implants back in her. But I can do this now that she's stopped smoking and her diabetes is better controlled. So here she is as a final before and after, very, very simple result. Here's that earlier patient we started off with. I asked you to think what you would do. So here she is. Dr. Loskin did a Goldilocks on her. It's a very good result. No microsurgery. He's home by 3 o'clock. And no implants initially. And most people would be happy with that. She actually, again, also, they make them big in Georgia, wanted bigger. So, of course, she got 800 cc implants. Thank you very much.
Mark?
Really great results. So much of that just makes sense, and I don't think that we do it that much. If we look in the US, 50% of mastectomies are not reconstructed by most recent estimates. And we see that there's a growing narrative online that if you have like dog ears or fullness in the axilla, it's actually because your surgeon disagreed with your decision not to get reconstructed. In essence, that the surgeon was trying to make you look bad because they wanted to give you a better result. As we try to improve the aesthetics of going flat, is there a role for almost all high BMI patients to have a T-junction, to try and narrow that, to pull that in, to try and reshape that mound? Rather than just going flat, because going flat in a high obese patient are the ones that have the worst sequela when they go flat.
Yeah, I think we've all seen it. It's very frustrating when they're told, oh, my breast surgeon said I left that for your reconstruction, and they have a giant standing cone deformity in the lateral chest. I do think this technique gives you the opportunity to offer a subset of patients you would otherwise flat out reject potentially and just say, I'm not going to do anything for you. Because we do see those patients who've gone flat, but their flat closure is not even flat, it's concave, and they have this big round abdomen, which almost makes it look even worse. So giving them a little bit of something, maybe it doesn't even stick out very far, but just to even actually make it truly flat so that they can have a better fitting prosthetic is a nice option, and I think this is just something we need to, as plastic surgeons, think about more often rather than just say you need to lose 100 pounds before I'll reconstruct you.
Yeah, just a technical question. I didn't get it. Did you use like ICG, anything to predict the quality of the tissue, since you're talking about the quality, or did you just take whatever you had and fingers crossed?
So I think this is going to be dependent on your breast surgeon, right? Like we all work with different breast surgeons. Some we know are good and some we know are not good. So if you walk in and they don't look good, yes, I will in a heartbeat spy it to discard what is terrible, because I have dealt with the sequelae. Much harder to add an implant in later or add fat in later if you have something rock hard in there, fibrotic. So I'd rather throw it away and then come back and add something than to leave something I know is not good quality. Yes, Jesse.
Great presentation. I think this is a great operation. I do this all the time and love it. One thing that you can add to it, just for the general group of people, is the lateral thoracic roll is something people get really worked up about when you take their breast off because they think you put a breast in their armpit, which you didn't. You just didn't get rid of that. So, I mean, a la body contouring, Peter Rubin, et cetera, you can either cap that in or de-ep that and roll that in, and that actually will help do quite a bit of auto-augmentation as well.
Yes,
I'm
we
sure
do that.
you do that.
We do that
stuff,
regularly.
yeah.
Sorry, that was in my notes, but I don't have notes.
We're going to go in the back first.
Oh, hi, Bert.
Hey, great talk. You're asking about the SPY camera, and what I find useful if you don't have SPY technology is when you go back and you eventually cut your vertical component, you don't cut it out, you deepithelize it, and if that skin's bleeding nicely, then that gives you your answer. So if that skin's not bleeding well, then you might want to SPY it, or you can cut it out, and then you just save some of that inferior skin. It's a nice little trick too. Great talk.
Okay. One more.
Angela, how often do you go back secondarily and do fat grafting or add an implant?
I was so obviously I don't have like 100 of these. Nobody should have 100 of these, I think, but it's really patient driven. I find that some of these patients who had these G, K, M size breasts, even though they look, I think, fine, really their identity is associated with having large breasts, and so they'll push to have something done. So I would say in my patients, about 25% of them still want some extra volume.
Great.
Thank you.
All right, thank you very much. So our next talk is by Dr. Rubin, and it's Authority, Regulations, and Safety of Fat Grafting, and I believe it's a remote talk.
Thank you for the opportunity to talk about regulations and safety surrounding fat grafting to the breast. I'm sorry that I was not able to join you in person and hope to join you at the same meeting in the future. My disclosures will not impact the content of my talk today. The FDA perspective on fat grafting, and indeed any cells derived from fat tissue, is very similar to the perspective of the EMA. I'm going to talk specifically about FDA rules, but there are a lot of similarities and crossover, and the FDA and the EMA are very much working in coordination and seem to have very similar perspectives on the regulation. There are three general regulatory tiers for human cell and tissue use in the United States. The first tier is the lowest regulatory burden, and this involves procedures without requirement for FDA registration or direct oversight. These are things we do in the operating room, like skin grafts and bone grafts and fat grafts, and these are regulated locally, and the FDA has really no direct oversight, although as you'll see, they do have jurisdiction. The second category is called human cell and tissue rules, and this is a higher risk category than the first, but still low risk overall. And this category is really designed for tissues that are going to be manufactured for transplantation, acellular dermal matrix, demineralized bone grafts, and similar products. And then the third category is the highest risk. In this category, the FDA considers that the tissue or cells that you're going to be using will actually be regulated as a biologic drug. And this is a very high level of regulation. And the reason that there's a red box around this first category is because this is really where we want to be. We want to be grafting tissue in the OR, doing surgical procedures without direct regulation from the FDA. And this is really, our version of heaven. This is surgical heaven. We get to do our procedures as we want with little regulation and a high amount of safety. Now, I'll get a little more in detail into these rules, and you'll see that these are best taken with a little bit of caffeine, some coffee, some espresso, because these are not intuitive to surgeons. So first and foremost, we have to understand that the FDA does not actually regulate surgical procedures. However, the FDA does regulate the use of all tissues that are removed from the body and intended for transplantation or implantation. And the FDA uses a term called HCTP, which refers to human cells, tissues, or cellular or tissue-based products. And basically, any tissue that comes out of the human body intended to be implanted into the same patient or a different patient all falls under FDA jurisdiction. So notice the use of the word product. And look, here's a syringe full of fat for fat grafting. Is that really a product in the same way that acellular dermal matrix is a product. Because if you have a tissue product, even though it's not the highest category of regulation, there's still a lot that has to be done to meet the regulatory requirements. So this creates a little bit of a practical problem, because we're taking tissue out and reimplanting it all the time in the OR, doing skin grafts, doing all kinds of grafts. So the FDA makes an allowance for this, and they call this the same surgical procedure exception. And the FDA says that if you take tissue out of a patient and put it back in the same procedure, and you do very little in terms of manipulating the tissue, then that's okay. And this carve-out is so invisible that most surgeons in the United States don't even know that it exists or that it is needed. However, this is the carve-out that allows us to take tissue out and graft it in the OR. Now, I mentioned in the 3 regulatory tiers that we want to be in this lowest category of regulation when we're grafting tissue. How do we know that we are there? Well, we look at the actual regulations for human cell and tissue rules, and it will tell us that if you take tissue out with minimal manipulation and you use it for the right purpose, then you're in this category. And accordingly, you're in heaven. However, that same rule book will tell you that if the tissue is more than minimally manipulated or being used in a non-homologous fashion, it's in the high risk category, and it takes a lot of regulation and a lot of clinical trials and a special biologic license to use this clinically. So you don't want to be there if you can avoid it. And when it comes to homologous use, the FDA really talks about the same function in the recipient as in the donor site. And the FDA actually challenged the use of fat grafting to the breast, saying that it was non-homologous. And the FDA said, well, the main function of the breast is lactation, and fat grafting doesn't help restore lactation, therefore it is not homologous. Now, you can imagine that there was a lot of dissent, and in fact, I testified on behalf of the ASPS at FDA hearings. Many of our colleagues testified, and fortunately, the FDA dropped this position. So fat grafting to the breast is considered a homologous function, or in the eyes of the regulations, it is not prohibited because of non-homologous use. Now, in reality, we have this whole continuum of products based on components of adipose tissue. And we have our standard fat graft, which is large particles of fat tissue. And we also have methods to make smaller particles that we give all kinds of fancy names to. And ultimately, you can have a cellular product. Now, the FDA, in terms of minimal manipulation, is pretty silent on these products right now. And we think that making the particle size smaller is okay. However, if you are separating a cellular product like SVF, even if it's done by mechanical means, this is not acceptable for use, even if it's by mechanical means, not by enzymes, and we can't do that. So the FDA has really put a firm line in the sand here, but we think that just resizing the particles is okay. So at this time, fat grafting to the breast in most cases is regulated as a surgical procedure, and that's very favorable, and we want it to stay in that area of regulation. But remember, when you start isolating stem cells, then you are in a different category. So following that overview of the regulation, let's talk about oncologic risk and what are the problems. Well, cancer surveillance could be a problem. I'm going to talk about that during this lecture. Growth factor release from fat tissue and fat stem cells, that seems to be the biggest issue that we're working around right now. Stem cell malignant transformation is not really an issue with adipose tissue, and enhanced migration and metastasis of cancer cells induced by growth factors, that could be a problem as well. So these are all things that we worry about. And if we ask the question, will secretory factors from adipose stem cells stimulate cancer cell growth in vitro or even in animal models? The answer, unfortunately, is yes. However, a lot of these models are very highly flawed because they have large concentrations of stem cells adjacent to tumor cells, and that's not something that we really do clinically. And what we really need to do is look specifically at fat. So we have seen in the lab, this is a micrograph from our lab, that high concentrations of stem cells will induce tumor growth if tumor cells are present. And we need a new set of experimental models that better represents the clinical scenario. We've been working under NIH funding for quite a number of years. And one of the questions that we asked in the lab is what happens when you actually just mix tumor cells directly into the fat graft? Is that even a favorable environment for the tumor cells? And we found it's not. In fact, you need an order of magnitude higher dose of tumor cells to get them to engraft within fat. And then we asked the question, can we better model fat grafting with residual tumor in an animal? So we injected MCF7 tumor cells into the mammary fat pads of mice. And once they engrafted, we had tumors in place. We fat grafted around them. And then on harvest, we found that the tumor size and histologic grade, and in fact, all the tumor characteristics were not larger or more dangerous when fat grafting was in the region. And we think that this is a very good model that better represents fat grafting to the breast as a reconstructive therapy. And this is a very meaningful to be able to actually model this in an animal with retained tumors in a large number of rodents to show this, that there was not an effect. So what about clinical studies? Well, some large review articles that look at many, many patients have found no increased rate of recurrence compared to the general population. We've seen that in several different studies. This one by Dennis Orgill's group looked at over 3,500 patients and found a mean recurrence rate similar to the general population. And Emmanuel Delay did a very large study also looking at, in a retrospective manner, at recurrence rates and did not find any danger signs here. However, there's a wrinkle in the story because Pettit's group found in their study that they had a subset of patients with DCIS or intraepithelial neoplasia that showed a higher recurrence rate. And they did some really nice follow-up work in a matched cohort study and unfortunately had this same effect in patients with DCIS. And this really had the alarm bells ringing because we were worried about this. And what happened over time with this story is that the control patients caught up in recurrence. And when they did a reanalysis of the data, they found that the control groups and the experimental groups were actually equivalent. There was no statistical difference. And Pettit's group published these definitive results of the long-term analysis in plastic and reconstructive surgery. And you can see from the Kaplan-Meier curves that there's no real significant difference in the groups. And we've seen this in other cohort studies as well. And these matched cohort studies are just a really nice way, since you can't really randomize one-to-one. This is a very good way to look at the data. And we've seen subsequent work by Catherine Gale showing no increased recurrence rates, and in fact, same with the DCIS patients, that we didn't see that effect in that subgroup. And Steve Kronowitz also showed in a very nice retrospective case-controlled study that the recurrence rates were not significantly different. So what about mammography? Our group looked at a cohort of breast reduction patients and a cohort of lipotransfer patients. We had their 1-year mammograms blind read by 8 attending radiologists, and we found that the BI-RAD scores were actually worse in the breast reduction patients, indicating much more scarring and surgical damage than in the lipo-augmentation patients. The radiologists are actually very comfortable reading these studies at this point. So in conclusion, in vitro studies have shown concerning results, but many don't accurately model the clinical scenario. We need new scientific models, and these are being developed. Current clinical data sets appear to show no increased risk of recurrence, but the issue is still not definitively settled. We need more robust data collection to really follow these patients and look into this in a very rigorous manner. But fortunately, the clinical studies are not really ringing the alarm bells at this time. This is our lab, the Adipose Stem Cell Center, and give great thanks and gratitude to all of our team members, and I thank you for your attention.
Thank you, Dr. Rubin. So we have the ability to have questions for Dr. Rubin from the floor. Anyone?
Great. Can you see and hear me?
We can see and hear you.
Great. Excellent.
And
yeah, I wish I could be with you guys in person. I apologize for the not being able to join, hopefully in the future.
Sure.
And I know that was a lot of material, so apologies for that. But
so we'll start with questions from the floor. We have the first one from Mark Clemens.
Thank you for that very thorough review and really up to date on the way the government approaches this as well as the way that the science does. Even though you said that it's not definitively known, you really kind of presented that in post-mastectomy reconstruction, it kind of feels that it's definitively settled, that there's not an oncologic risk. Where do you stand, though, on fat grafting to breast-conserving therapy defects, either in a delayed fashion, or we're starting to even see presentations at national meetings, immediate fat grafting into BCT defects to supplement the resulting tissue in that breast. Is that a subset that's maybe less definitively settled?
that's exactly the subset that's less definitively settled. I agree with you. I have no qualms at all about the post-mastectomy reconstructions, you know, assuming they are otherwise disease-free and you have complete control of the tumor. The population you mentioned, the breast-conserving therapy patients, that's where we still need more data on the timing of treatment and also the timing relative to the tumor characteristics, tumor grade, and other characteristics of the tumor. So that is not definitively settled yet.
Question?
Sure. Dr. Rubin, David Edelman from MD Anderson. You mentioned that with current status, it's okay to do a macro or a micro or even a nano fat transfer, but as soon as you start separating stem cells, we get into difficult FDA-related territory. So does it matter how we prepare our fat? If we centrifuge or Telfer roll or merely irrigate it, are we potentially manipulating the tissue in a way that might get us as surgeons into trouble?
So all the things that you just mentioned are not a problem. You can filter, you can Telfer roll, you can gravity separate. And I'll tell you from personal experience dealing with the FDA in some meetings about some technology that we've been developing, where they start to get a little nervous is when you are passing the fat tissue through graded filters, and especially if those filters get really small. then they would consider this as a cellular processing device. And very recently, control of these devices switched from CDRH to CBER. And the same way that CDRH is taking over a lot of the meshes, biologic meshes that we're using, that same shift has happened with fat grafting devices and fat processing devices. So, you know, this is still a little bit of a gray area. What is really clear is that if you separate out cells, doesn't matter how you do it, you are running afoul of the minimal manipulation guidelines. And the FDA was really clear about that in a guidance document that they published.
Great. Well, thanks, Dr. Rubin, for your time and answering our questions today.
Thank you so much for having me on the program.
Great.
Next time I'll be there with you in person.
Sounds great. In Rome.
In Rome, yes. Fantastic. Thank you so much.
Okay, our next speaker here in person is Dr. Renee Largo from MD Anderson. A secondary flap no more, why the PAP flap is my first choice.
Thank you very much, Fabio and Mark, for giving me this title. My goal will be to show you that the PAP flap is not a secondary option, but could be a first choice in select patients.
Press it kind of hard. I have no disclosures. So the deep flap is widely considered the gold standard, but as we heard earlier, there's a significant rate for bulging and hernia. Maybe the robot can address some of these things, but in some patients there's also insufficient volume in the lower abdomen, or it's just not possible to do a deep flap because of previous surgery, or there's a patient preference to have a different donor site. The PAP flap was first introduced by Claudio Andregiani, who described the adductor flap, and then later it was popularized by Bob Allen's group to use the PAP flap for breast reconstruction. I want to focus this talk on first giving you some flap characteristics and outcomes, then give you some pits and pearls in breast reconstruction, then also comparing the abdomen with the thigh. So we did a study on 70 patients undergoing a PAP flap for reconstruction. They were mostly for oncologic reasons in the head and neck and breast area. And we harvested flaps in the dimension up to 14 times 26 centimeter, and the pedicle length was in average about 11 centimeter, artery about 2 millimeter, and vein 3 millimeter. And the study really targeted to facilitate flap harvest. So we wanted to look like we did for the ALT flap, where are these perforators located? And we found a very constant pattern. So we found that the A, B, and C is about 7, 13 centimeter, and 17 centimeter distal to the pubic tubercle along the adductor longus axis, and about 8, 7, and 6 centimeter posterior to the adductor longus axis. So which is a very important information if you want to plan a PAP flap. Then if you have a proximal perforator, like an A is in 13% a septocutaneous perforator, and if you go further distal, similar like the ALT flap, it becomes in 98% a musculocutaneous perforator. We also looked at merging patterns. We found that in 60% these perforator merge, most commonly between B and C, and then also A and B. And we found in all vertical PAP flaps, we found an A and a B perforator. And in 14% we didn't find a C perforator. But that's important if you want to do a horizontal PAP flap, for example, that you're always going to have a perforator. So in terms of complication rate, they were comparable. The wound dehiscence is here 11%, but remember there were 50% were head and neck patients with a lot of comorbidities. So if you only look at the breast flap patient, then it's closer to 6%, which is comparable to previous study that have been published. The closest competitor in the area is the TOG flap. The PAP flap has the longer pedicle though, better donor site morbidity, larger skin paddle, and there's no muscle, so the volume change is more predictable, and you have the variability of the skin paddle orientation. There are different flap designs you can use, from horizontal, vertical, or boomerang, or diagonal,
And then from Dietmar, he has published a very nice study on optimizing the PAP flap design and to finally get the scar in the right position, which is ultimately the goal. You don't want to have only a nice breast reconstruction, but you also want to have a nice donor site. So you have to try to, if you do a horizontal PAP flap or any orientation, you don't want to have anything visible in the front. If a patient doesn't see a scar, patient is happier. In the back, you don't want to cross the lateral border of the gluteal fold. The cranial incision should be about 1 centimeter or more above the gluteal fold to have the final scar very close to the buttocks fold. These are two examples which are maybe not as favorable, so they cross the lateral border and the scars are too low. So you want to have it look more like this, so that the scar is eventually in the fold or hardly visible. And if you have a vertical component, for example, a boomerang diagonal or vertical fashion, you want to have it seen from the front and just barely from the posterior part. So in about 95% or 92%, you can do just a straightforward horizontal PAP flap design with your perforator within the 7 centimeter, maybe 8-9 range. And that goes pretty straightforward, but in about 6% you have to perforate a little bit more distal, so about 9 or 10 centimeter. So in the unexperienced hand, it's advisable to do a CT angiogram if you want to do a horizontal design to just make sure that you know where your perforator is and that you can maybe adjust the flap design, or if you are more experienced, you can do it a little bit outside your skin island, but that needs a little bit more experience in microsurgery. So this is an example if you have on the right side a lower perforator, so your design is going to be a little bit lower, but eventually it will heal. You just shouldn't cross the lateral border of the gluteal fold. The PAP flap can be shaped very nicely. Like an implant, you can leave a skin island, or you can just bury the flap and monitor with implantable Doppler. And sometimes some fat grafting is necessary. And I don't want to bother you with showing all these pictures for these, the simple, just uni PAP flap. I want to go a little bit in the scenario with the increase of bilateral reconstruction or insufficient tissue in the abdomen, or overall on patients who want to have just minimal number of surgeries and no implants. You can stack flaps. We heard that earlier. There are other concepts you can use like fat grafting. If you want to stack flaps, the safety has been shown in several studies of this. This is a patient who had a left breast cancer, had a tram flap in the past, and had a new cancer on the right side. Tissue expander got referred to me. She wanted to be more balanced, and we did a boomerang PAP flap from both sides just to meet the volume requirement because the breast was quite large. And she was quite happy with that more balanced look. She didn't want to have nipple reconstruction or a mastopexy on the left side. Or then a patient I did with Dr. Edelman with preoperative radiation, which is more commonly performed now, had mastectomy, then stacked PAP flaps just because she had such little tissue. And for the right side, she even wanted to have then larger breasts overall, and she got augmentation and a mastopexy on the left side. And she has an acceptable donor side. Then the unique scenario where you do 4 flaps, this is just about 1% of the practice, where you do take tissue from the belly and the thigh. The PAP flap can be shaped nicely to an implant that can give you the really full look in the upper pole, then mastopexy, nipple reconstruction, and then acceptable donor side. Then we also looked, we did a study that was led by one of my colleagues, Dr. Lee, looking at abdomen versus thigh. We looked at pain scores, opioid consumption, length of stay, and so on, and then all PROs. And we had 30 patients and matched them to 60 deep flap patients, a 2-to-1 match. And we couldn't find a difference in narcotic consumption. During hospital stay afterwards, we couldn't assess it because it's a retrospective design. Then we also couldn't find a difference between length of stay, flap failure, donor site complication, or reoperations. And we also looked at just difficulty with everyday activities, discomfort, and so on. We could see a difference in tightness. So patients with PAP flap felt in this scenario was equal. The only thing that was different, almost statistically significant, was the negative impact on sexual life of the abdomen versus the thigh. So more deep flap patient reported to have a negative impact of their donor side to their sexual life. So this was statistically not significant, but a tendency. It's just probably a type 2 error because the study was underpowered. Then the same, we looked at satisfaction overall in clothing and so on, and we couldn't find a difference, but you see overall the thigh always scored a little higher than the abdomen. Then we looked at the unique patient population who had both a PAP and a deep flap, and we could see that tightness was significantly different. So PAP flap patients early on feel more tightness. You have to counsel your patients that you're going to have tightness. But you can see overall the discomfort was overall much higher in the abdomen versus the thigh. So overall, this study showed no significant difference in terms of pain score, opioid consumption, length of stay, and wound complication. And the PROs, they were pretty similar, just the only thing was that tightness was the main complaint of the PAP flap patients, but overall discomfort was higher in the deep flap patient group. So overall, I would like to conclude that the PAP and deep flap should be considered as equal first-line options for patients undergoing autologous breast reconstruction, and the selection should be more biased on, more based on patient preference, lifestyle, and less just because you just do a deep flap in every patient. So there are many other flaps that should be included here too, but there's not enough time for this. But I think the PAP flap is a very good option also in autologous breast reconstruction. Thank you very much.
Thank you, Dr. Lorio. Excellent study. Questions on the floor?
Yeah, thanks for a great presentation. Despite looking carefully at the pre-op CT angiogram and Doppling, I obviously put my scar a bit too high because when I got in there, I realized the one that I've been listening to was the pudendal perforator. But I've followed it a couple of times, and you can get a good caliber with some meticulous dissection, but it's tough dissection, and it's not the same kind of flap. So my question, maybe I'm biased because we have kind of patients in Stockholm that you may not have in Texas, but let me put it this way: if I put the incision too high and end up in this situation, would you rather take the pudendal? What's your experience with that? Or would you bevel the flap? I know Andreas Figus, he says, doesn't matter if it ends in the skin island, you can bevel it. What's your idea when I end up in this situation next time?
So the thing is, I think it's no longer about just having a nice breast, right? So it's about having also a nice donor side. So I always look at how I can achieve the best donor side, and I will look for whatever vessel I can find, and I include that, and I use that as the flap. So it's true, you can base it on a pudendal flap, but as you said, it's a very it's a struggle to get to follow that vessel, and it's a little shorter pedicle, but it's especially it's more time consuming than if you have just a traditional PAP. So what I mostly do is I just bevel. I don't make the skin island very wide. I make it quite narrow, but then I bevel, so the perforator is almost never centered on the skin island, almost never. But I always look at that big perforator, the 7 centimeter. It's really almost always there. There's very few patients, I think it's 4 or 5% that you really have to adjust the skin island design. But I think, if you get a little bit more experience, I think you can always just bevel and include that perforator and get a really nice aesthetic result of your donor site.
I've got the same remark, Martin. Also, our experience with the PEP flaps is comparable. And if you use the horizontal skin island, I also would recommend to do a more aggressive beveling of the flap. Then you can include it. It's much better. And in some patients, you have to do the boomerang incision also. But what we see with the boomerang incisions with the horizontal and vertical skin incision, you see much more skin complications of wound healing problems. And we published also this year a study of the donor site complications. In the very beginning of the donor site, of the boomerang incision, you see much more complications. You see terrible scars in the very beginning. After 1 year, it's fine, and they are fine, the patients then. But if you have these patients with these problems, you can make a boomerang incision also.
Sebastian Wincor.
Yeah, thanks, Renee. That was a great talk. It's really nice to see people pushing the envelope on thigh-based flaps. And I think what we're seeing more and more is, I mean, the reason why people are stacking flaps is that there's just not a lot of volume, and people are trying to get more volume out of the medial thigh. And you mentioned you use the boomerang flap a lot. What are your thoughts on, recently Ed Reese described a pug flap, a combination of an oblique vertical upper gracilis perforator with a profunda artery perforator flap, trying to get more volume. Could you foresee that being used with a 2-perforator, 2-pedicle boomerang just to get more volume, or is that just unnecessary?
No, I think it's in select patient. That's a great choice too. I mostly, if I have a unilateral reconstruction, I mostly stack just 2 pap flaps instead of going for one donor side and get more donors, more volume out of one donor side. But in select patient, this is a great option too. You always complicate things if you have several pedicles that you have to hook up, but it's an option as well.
Okay, great. Thank you, Dr. Largo.
Thank you.
Okay, thank you very much again. So the next presentation is from Dr. Spiegel, and she's talking Achieving the Sensate Breast.
I think it's good afternoon now. Thanks so much, Fabio and Mark, for the invitation. This year I didn't have to travel as far as Rome to get to speak here, since Houston is my hometown. So thanks for the invitation to let me speak about one of my favorite topics, is achieving the sensate breast. And Renee, I would propose another criteria for your flaps is the nerve. Because I think it is really an important goal for us coming up. And I'm just orienting myself to this clicker. Okay, here we go. Here are my disclosures. So we know that breast reconstruction improves the overall quality of life for our patients, and breast sensation does also increase patient satisfaction. As we have become more experienced with microsurgical procedures, our goals now have shifted just from pure flap survival to actually restoration of the breast as a sensory organ. And it's nice to know that increasing numbers of centers around the country and internationally are incorporating neurotization into their standard of reconstruction. So we can look at the deep flap as our main workhorse, since in my practice that's still the kind of #1 choice. And we can look over the past decade at the refinements we've had in the deep flap, and we've really worked hard to make it more safe, looked at the breast aesthetics, the abdominal donor site, we incorporated the lymphatics with it, and now I think sensation is really the next step, just to make it routine. My history and experience with this actually dates back into 2003. It was 2 years into my practice where I had this patient who I did a delayed reconstruction with an SIA flap, and back then I thought, oh, this is great, I really achieved a nice breast. And then 2 years later she came back to me with a 2nd-degree burn to her reconstructed flap because she didn't have protective sensation, and that's when I realized I really failed in really achieving the goals for breast reconstruction for this patient. Because I think we have to look at reconstruction not just as a before and after that you see in a conference, but really from the patient's standpoint. How does the flap feel for them? And are they happy with the way that the reconstruction, as far as the protective sensation and erogenous sensation component? So this is illustrated in these 2 patients. Both of these patients underwent nipple-sparing mastectomy with deep flap reconstruction, but the one on your left had an additional neurotization. And it's difficult, obviously, to show in a slide, but she actually had almost normal sensation to her breast skin, despite the fact that there was no real flap skin that was restored. And the patient on the right did not have much sensation at all. So I think it's an important thing to really think about and counsel patients, because oftentimes that conversation isn't really there during the reconstruction consultation. Oftentimes the general surgeon really doesn't mention the fact that the patients will lose most of their sensation with a mastectomy. So I think it really needs to be considered as a part of the reconstructive goal. And when we look at patients, it's actually quite interesting. When you really take the time to talk to them, the sensation spectrum varies, both for erogenous sensation and even protective sensation. We have a subgroup of patients that has very significant nipple areola sensation. They tend to have smaller breasts. The erogenous sensation to this subgroup is extremely important. In fact, some patients may choose to do a lumpectomy versus a mastectomy simply because they don't want to lose sensation in their breast, which is something that no one really talks about. But when I talk to my patients, that's one of the things that really we discuss, because for some patients, that's a part of their femininity and sexuality, and that really does bear a big downfall of mastectomies. So there's also a subset of patients, though, that have very limited nipple areola sensation. They tend to have large breasts that are tautic, the nerves are stretched, perhaps they've had previous surgery, and sensation really isn't that important for them. So I think that's something that you need to discuss, because that should be part of the goal for reconstruction. And we know breast anatomy. This is something that is very clear, but unfortunately, oftentimes general surgeons don't really know a lot about nerve anatomy, and hence we have a lot of patients, unfortunately, that present with post-mastectomy neuromas that could be simply prevented by either repairing the nerve or burying the nerve. So I think counseling the patients on that, talking to your general surgeon about it, and then inspecting the post-mastectomy defect to make sure there are no nerves that could be either repaired or protected from neuromas. So quickly looking at autologous reconstruction, there are three main components that we can look at when we're looking at neurotization: the recipient nerves, the donor nerves, and the way that they're connected together. So the recipient nerves, as we know, could be either the lateral nerves, which are the preferential ones that go to the nipple, or the medial or anterior nerves. And interestingly, both can be spared completely with a very sound, oncologically sound mastectomy, so patients can have very nice sensation without neurotization, but it's obviously very unpredictable. I prefer to use the anterior nerve or the medial nerve because it is one that I can see very quickly in the microsurgical field when you're using the internal mammary vessels for reconstruction. This is something that I published a long time ago. This was my first kind of routine. I decided that I really would like to do this routinely for all patients, and so looking for the lateral nerve is very difficult, particularly in those delayed reconstructions where you really need to find that nerve. Frequently it's radiated, scarred, so the lateral nerve is difficult to find. This one is right there, readily available when you're doing your microsurgical anastomosis, and it doesn't really add a lot of time to your microsurgery. The donor nerves, of course, in the abdominal area are very standardized, and we have segmental innervation. It's important to really look at the dissection, and if you can look at this oriented with the left side being the umbilicus, you can see that the progression of nerve size increases as you go down, and the perforator size decreases. So I usually like to use that lower nerve, which is traditionally T12, and you can dissect it up to its motor branch. Obviously, you want to protect the motor branch that runs to the muscles so that you can usually get around 2 to 3 centimeters of nerve length quite nicely. As far as the way that you would connect the nerves, there are several choices for nerve conduits. So there is nerve connectors and then longer PGD tubes, and really they facilitate the connection between the nerves so that they have biochemical cues for tissue regeneration. You can also harvest autografts because, again, you have segmental neurotization of the abdominal flap, so whenever you're not using a perforator, there's always a readily available autograft that you can harvest, again, about 3 centimeters in length. And then, of course, allografts are also available. So my personal preference is always actually to use a nerve connector, even if I don't have a nerve gap, because the fascicles of these small nerves usually don't align very well together. So it's nice to have even a small gap so they can find one another and grow together. For longer nerve gaps, I still use a nerve connector up to about 1.5 centimeters. Between 1 to 3 centimeters, it's a longer PGD tube. Beyond 3 centimeters, as we know from our hand surgery experience, you really need an autograft or an allograft. So 3 to 5 centimeters, I think you can get an autograft, which is obviously much less expensive. If you're really having a large gap, then you need an allograft. And I think that's really important to think about when you're designing your flap, when you're looking at not only the perforator choice, but also how your nerves align together and how big the gap will be between the nerves. So it really depends on how you design and inset your flap. I particularly like actually an ipsilateral flap, and this is for a unilateral reconstruction, where that flap, as it's rotated 180 degrees, allows the nerve to be very close to your microvascular anastomosis, and so there's very minimal gap in the nerve. If you have a contralateral reconstruction, this is still the ipsilateral. You can see that it's nicely positioned. For a contralateral, if you rotate it 180, you will be close to the lateral nerve. Again, that's the one that's sometimes tough to find, but preferable because it does have a better supply to the nipple areola complex and perhaps has a component of erogenous sensation. But you can also rotate your contralateral flap 90 degrees, and then you can be close to the medial nerve. So even now, in 2018, I actually had another patient present with an issue, even though I neurotized her flap. So you can see that this patient presented with quite a significant modified radical mastectomy defect post-radiation. And so I actually did this conjoined sensate deep flap with a lymph node transfer on her. And 2 months after that, she had a burn just from a heating blanket. And so then she underwent a contralateral prophylactic mastectomy with a DTI. And about a year later, she already said, you know what, I'm getting protective sensation. And in fact, I just operated on her 2 days ago, reconstructed her nipple, and she said she had absolutely normal sensation to that breast. So this really illustrates that sensation improves. That's why it's important to really look at these patients. Now, really quickly, what do we do for our implant-based reconstructions? We know that there is a new sort of algorithm for being able to do neurotization of alloplastic reconstruction. This is something that you can really do simply by using an allograft. I use the lateral nerve for this purpose. You can tunnel it through the flap, and this allows a way for us to be able to neurotize alloplastic reconstruction. This is new, where the data is still coming out on this. This is my first patient, and actually she's an out-of-town patient, but when she returned, she said that she started to have a little patch of sensation just under the nipple areola complex, so that was very exciting. So I think we've really evolved with neurotization, starting from just using it in delayed flaps, then even in nipple-sparing reconstructions, autologous reconstructions, and now in alloplastic or implant-based reconstructions, which is really exciting. Future directions, I think, involve an increasing level of level 1 and 2 evidence, improving the standardization of neurotization studies, because this is really a part of the issue, and then perhaps eliminating that subjective component and using functional MRI for determining sensory recovery of the breast after reconstruction. Thanks so much for your attention.
Great. Thank you. Any questions from the floor? Dr. Chang.
So nerve conduits and grafts obviously have a significant cost associated with them. And then in the peripheral nerve literature, the length of an effective conduit or graft is always debated. What is your personal experience with the longest conduit you would consider using?
So so for autologous reconstruction, I actually rarely use an allograft. Again, if you can design your flap to minimize the gap, it's really an inexpensive operation. For alloplastic reconstruction, obviously autologous grafts are really not great. So the maximum allografts that we have are 7 centimeters. And that's kind of, I think, the fine line. I think going any longer is problematic. There are some constraints to that. Obviously, when you're looking at your arc length, sometimes that nerve is too short to actually reach the nipple areola complex, so you have to figure out if you can offer it to larger breasted patients because that's a longer length. So I think all of that is still something we're still trying to figure out. But I think it's an excellent question. There is a limit.
Question? Hello, Dionysiou from Thessaloniki, Greece. Congratulations for your talk. Apart of the cost, I mean, when we use different kind of nerve conduits or allograft or autograft, from the peripheral nerve studies, we do know that we have different outcomes. Do you have a similar experience regarding what you find in your breast neurotization?
So I did a study about 8 years ago comparing 3 groups, direct coaptation, one with a conduit that was a PGD tube that was 3 centimeters, and then patients that didn't have neurotization. I thought that the direct coaptation patient group would have the best results. Actually, they didn't. The PGD tube did, and I think the reason why is because that fascicle anatomy is different. So I think you can get a really nice result with a short gap using a PGD tube, which is not very expensive.
Question?
I'm Afifi from the University of Wisconsin. So when you're doing the nerve reconstruction with an implant, what are you suturing the nerve graft to on the bottom of the areola? And what's your goal, or what's your results? Are you getting sensation back in the nipple only, in the nipple and areola, in the skin? What have you achieved with this so far?
Yeah, so the pioneering work on this was done by the Pellet Group in San Francisco. They identified some vestigial neural elements in the nipple areola complex after the kind of biopsy that's done under the nipple. So the theory is that, and it kind of actually came from corneal neurotization, where you basically splay the nerve out on a cornea without attaching it to anything, and it kind of grows in. So Susan McKinnon has a great talk about sensory nerves being like weeds. They like to innervate things that are asensate. So if you allow a nerve to grow into tissue, which is nice and healthy, it has a tendency to do that. So that's kind of the theory, that you're not actually connecting the distal part of the nerve to anything. You're allowing it to grow under the nipple areola complex. And I think, this is really early. We're still looking at these studies. I probably have only 25 patients, so not very many, that are pretty early. I think, 3 years at the most so far. So we're kind of accruing this data. And I think a lot of other centers are doing the same to try to get some answers to those questions. So thank you.
Okay, thank you very much. Okay, our next talk, Dr. Demiri, is going to be presenting on fat-augmented latissimus dorsi flaps.
So, hello again. So, my second talk is on autologous breast reconstruction, and specifically on the use of the autologous fat-augmented latissimus dorsi. So most of us, when we think about autologous breast reconstruction, of course, our first thought is of using the abdominal tissue, as we've already heard about it today, and the deep flap still remains the gold standard. However, there are many other options. We have already heard about the pap flap and many other flaps that may be used, or reconstruction only with fat. And the decision that we should take about which is the most suitable, the best technique for each patient should be based on the available donor sites, the opposite breast, of course, patient's characteristics and wishes, and of course the surgeon's experience and choice. So the autologous latissimus dorsi was first introduced about 40 years ago. It's an old-fashioned technique by Hawking, and then it was popularized at the late 90s by Emmanuel Delay in France, and thereafter many centers worldwide have started using this flap with quite nice results. So in our practice, when we are using this flap for breast reconstruction, we first of all, we draw our skin island obliquely and parallel to the skin laxity. And then we try to incorporate as much fat as we can from the back, including the fat components with compartments which are situated above and below our skin island. And then this is how our flap looks like after being transferred to the thoracic area. And then we continue with fat grafting, fat harvesting in a classical way. We collect the fat in sterile collectors, and then we prepare it using washing and strainers. We can use the pure graft by Satori if we have it in the department. And then we inject the fat using 1.5 cannulas intramuscularly in a 3D drill pattern, but also not only in the LD flap, but also in the pec major, and of course subcutaneously in the thoracic skin flaps and also in the skin island of our latissimus dorsi flap. So how much fat to inject? I would say that until the recipient site is saturated, but this of course is something that we have to check until we can get the volume that we desire to have. Different authors have reported different volumes. Santanelli in 2014 reported about a mean of 100 cc's per session per breast, but these were mainly immediate reconstructions. In our delayed reconstruction series, we have a mean of 254 cc's, which is a little bit more, and delay reaches up to 400 cc's per session per breast. So always we try to overcorrect the reconstructed breast because we know at the end of the procedure, because we know that we will have some volume loss, of course. Fat resorption is expected to be around 30 to 40%. So although the intramuscular fat grafting is expected to survive better comparing to the subcutaneous, but still we would have some volume loss, so additional lipofilling should be considered, and we should inform our patients that perhaps some extra surgeries might be needed in the future. So indications of this flap are both immediate and delayed reconstructions. In our immediate cases, there are again skin sparing. In most cases, breast surgeon remove the areola. So we remove only the areola, and then we try to keep as much skin as possible. Here we can see the drawings of the flap. Fat is harvested from the abdomen or the hips or the thighs, depending on the available donor sites. And thereafter, we can orient our skin island horizontal or vertical, depending on the shape that we want to get, and we deepithelialize the rest of the skin island, and we always fold the flap in order to get a much more projection, especially on the lower pole. So this is a case of immediate breast reconstruction, and the result after only a single session of fat grafting. Another case, this was a conversion from implant-based reconstruction to autologous with a fat augmented latissimus dorsi, because this patient had some recurrences of infections, and this is the result using the same lateral incision, and this is the donor side. Delayed reconstructions are more challenging because in those cases the whole breast cone is missing, where there is skin missing, volume projection, and also inframammary fold which should be created, and this is not always very easy in previous irradiated patients. So in those cases we need to have more fat available, fat volume is needed, so multiple lipofilling sessions perhaps should be also considered. This is one of our cases, a young lady, a young patient who had previous mastectomy, a small contralateral breast. She didn't want to have any augmentation, and she had heavy thighs. So she was very happy to get rid of this fat and to offer this fat for breast reconstruction. And this is the result after a single session of breast reconstruction. Another case, this was a lady, she was a very good candidate for a DIEP flap, but she had a very severe lipodystrophy on the thighs, so she was very happy for us to use the fat of the thighs to reconstruct the breast, and this is the result after 2 sessions of lipofilling. And another case, an old lady with other comorbidities, not a very good candidate for microsurgery, so we used, again, the fat-augmented latissimus dorsi with a very good and symmetrical result, with a very small mastopexy on the other side. So we conducted a retrospective study in our department, comparing the DIEPs, delayed DIEPs to delayed fat-augmented latissimus dorsi flaps. Of course, the group of our DIEP flaps were longer. The latissimus is mainly offered to more selected cases, as we will see. In terms of complications, results were very similar. The overall complications in both groups and still not very high. And patient satisfaction, again, although it was a little bit higher in the DIEP flap, but still there were no significant differences. This is an interesting pair of patients, both with the same characteristics, BMI, age. They had both 2 children, and they came after irradiation for delayed reconstruction. Both were a very good candidates. Our first choice was a DIEP flap, of course, but the left one didn't want to have a big surgery, and also she wanted us to reduce the other breast. So we offered. One of our patients was underwent a reconstruction with a fat-augmented latissimus dorsi, the other with a DIEP flap. And here we can see the result after complete reconstruction. Both were very happy with their reconstructed breasts. And another interesting case, this lady had a right breast cancer. She was reconstructed with an immediate DIEP flap. The other breast was not touched for oncological issues, and indeed, 1 year later, she developed cancer on the other side, so we did a latissimus dorsi on the other side. This is the primary result after the first session, and this is after a second, an additional lipofilling. It's quite, there is a small asymmetry, but the patient was very happy. Perhaps we offered her a third lipofilling, but she didn't want to go through. Last but not least is how we can deal with lymphedema patients. We can combine this flap with lymph node transfer. This patient had previous abdominal surgery. She was not a good candidate for a DIEP flap, so we did in the same procedure a pedicle latissimus dorsi with fat and also a groin lymph node transfer. And this is the result not only with a good breast reconstruction, but mainly with a good reduction of the volume difference of her lymphedematous arm. So to conclude, fat-augmented latissimus dorsi is an effective alternative for reconstruction, especially when microsurgery is not indicated or it is not scheduled for some patients. It provides a pure autologous reconstruction, very good results, sometimes comparable to DIEPs. It's easier, and it is also a good indication for lymphedema patients. Of course, several lipofilling sessions might be considered for some patients who have bigger breasts, and the donor site scar and morbidity also should be discussed with our patients. In our practice, this flap, the fat-augmented latissimus dorsi, is the best indication, and perhaps sometimes it's our first choice, especially for young, thin women who had small breasts to reconstruct, medium or small breasts, and had adequate fat donor site, this pear-shaped body. Thank you for your attention.
Thank you. Any questions from the floor?
I've got one question about your remark about patients with lymphedema. And sometimes, and I'm a bit afraid, we also do the lymphedema surgery in my department.
Yeah.
We are sometimes afraid to do an LD flap, a pedicled LD flap in patients with lymphedema problems. Have you seen ever problems in patients who already have a lymphedema, and a significant lymphedema on one side, and to use the pedicled flaps because you do some scar release also in the axilla? Do you have any remarks?
Thank you very much for the question. No, in the contrary, when we prepare our tunnel to pass the pedicle of the flap, then we can release all axillary tissue. So in terms of correcting the scar tissue, which might be involved in lymphedema etiology, this might help to release the scar and to help the lymphatic circulation. We have a series of latissimus patients with simultaneous correction of lymphedema. In most cases, we are doing free inguinal lymph node transfer, but also we have done some pedicle lateral thoracic lymph node flap, which may be done together with the latissimus. But this is a question whether there are some lymph nodes that are available to be used just for a pedicle lymph node flap.
Okay.
Question?
Thanks, Debbie, for a great talk and for promoting Swedish vodka. I have a scar-related question. What do you have the oblique scar in order to achieve as much fat as you can? Do they don't complain about that compared to horizontal, that is hidden in the bra? And when it comes to insetting, what's your preferable, sometimes it's preferable to put it in the IMF, but with a lot of fat, would you say you always put it in a mastectomy scar?
Thank you. When we put our the lower part of the skin island on the intramammary crease, then the result is better because we can fold better the flap, we can reproduce the lower pole and the projection of the scar, but this is not always feasible because we have the mastectomy scar a little bit higher. So we try to, either with some incisions of the lower pole of the fat to expand intraoperatively our lower pole, and then with fat grafting. Then we can, and interestingly, in most cases of delayed reconstructions have been irradiated before. With fat grafting and some rigotomies on the skin, this can be expanded later on very, very interestingly well. We have seen some cases with very good amelioration of their skin, and their contracted tissues. So even if we put our skin island on the mastectomy scar, we can expand the lower pole quite, not very easily, but quite well.
Okay, great. Thank you very much.
Okay, thank you.
Okay, our final talk for this session will be from Sebastian Winokur from Baylor College of Medicine here in Houston. He'll be speaking on aesthetic refinements of deep flap breast reconstruction.
Good afternoon. I'm sure all of you are very impatiently waiting to get something to eat, so I'm going to keep this brief. But for those of you who don't know me, I'm just from across the street at Baylor, so also not a long trip for me to come over here. So I'd like to thank Mark and Fabio for the opportunity of presenting today. I'm going to be talking about deep flap donor sites and some of the refinements of flap insets. So a lot of the refinements and techniques over the last few decades have had to do with functional benefit. There's extensive literature on this. Many of the people in this room have published on this. Nevertheless, it's only until recently that there's really been a number of studies that have looked at the aesthetic components to optimizing these donor sites. And so in order to look at this, you need to ask yourself, what makes a good aesthetic donor site? And we have to look towards the aesthetic components of our specialty, and that has to do with abdominoplasties. Ideally, we want our patients to be looking like this after a DIEP flap, and we have, even many of us are exclusive reconstructive surgeons, we have to be taking into account what our aesthetic colleagues are doing. And so what makes an ideal DIEP flap donor site? So we talk about the scar, and ideally we want that scar to be low, we want it to be symmetric, short, thin, with a smooth transition. We want the shape to not have any protruding bulge or rectus diastasis. You want the umbilicus ideally not to be, the scar not to be visible, for that to be low, appropriate shape. You can debate the shape, or there's a number of different techniques. And however, there are inherent differences between a tummy tuck and a DIEP flap. I mean, these are typically, DIEP flaps are done in patients that may have low or high BMIs, while tummy tucks are typically done, at least for most people, in lower BMI patients. Operative time, the donor site closure and DIEP flaps is at the end of the procedure. People are tired. Nevertheless, this is a major component to achieving a good aesthetic result. DIEP flaps have larger teams. Often there's delegation of roles. Residents or PAs may be closing your donor site. And so often you are not the one doing that, and that's a major component to the procedure. And then you have to deal with a fascial defect and all the consequences that are associated with that. With tummy tucks or abdominoplasties, there's patient expectations of a single operations, but with DIEP flaps, at least in the higher BMI patients, I typically tell patients that a revision operation is necessary. And so patient expectation is important. And so how do you set yourself up for success? And so the way I think I approach it is that I look at the aesthetics that are hard to correct down the road with a revision and try to get those right so that your revision down the road is a slam dunk. And so what are those critical elements? I think symmetry is really, really important. If you're asymmetric on your donor site, sometimes it's extremely hard to correct it. Shape, a rectus diastasis or a bulge later on, really hard to go and do a revisional tummy tuck on the patient and reset the whole healing clock with drains and everything like that can be challenging. And for an umbilicus, if you have an external scar, you have to redo the whole part of the procedure. And so I think ideally, if you can get no scar, that would be the ideal. So what do I do? For scar symmetry, I think everybody has their own approach. We try to do an objective, standardized approach that we publish just with standardized markings, and those markings lead to greater symmetry and consistency. It's important to identify bony landmarks or landmarks that traditionally don't move rather than freehanding these flaps. If you look towards our aesthetic colleagues, many of their outcomes are very much identified on the initial pre-op photos. If you can go back and look at your photos, you can identify the asymmetries that occur down the road. And so I think it's important to standardize that to get an objective assessment of symmetry. And so what does that look like? Well, we do standardized marks that look at the average width of the donor site to make sure that they're symmetric, and we measure those out at standardized lengths, and that's what it looks like when you do this on the abdomen. This needs to be done in a standing position to take into account the different levels of laxity that occur. And if you do that, you can get really, really symmetrical results. And not only that, if the scar ends up being high, it's really easy to lower that scar and still end up with symmetry later on, rather than trying to deal with an asymmetrical scar and dealing with the pull of the upper and the lower parts of the scar as they differentiate to achieve symmetry. Fascial plication is also a very important part. I think it's difficult to revise without extensive undermining. You're going to be looking at doing a mini tummy tuck if you have a bulge in the upper abdomen. I think it's a balance between fascial tension and abdominal wall enclosure, but I do think the suprapubic part of the fascial closure is more important. And if you can see here in these patients, it actually makes a difference. If you go back and you look at your lateral photos, you can see how much these fascial plications really give a better contour to the abdomen. The success that we should be measuring is not just on the success of the flaps and the survival of the flaps, it's also on really critiquing your ability to become an aesthetic surgeon and give a really good post-operative result. What is the aesthetically pleasing umbilicus? Well, there's many different techniques. I'm sure all of your partners do a different technique, and that usually means that they all work. The main goal is really no visible scar. And we published this year an algorithm that I use, and I use this for deep flaps, on decisions of whether to put fascial anchoring sutures or not. And I base that based on the thickness of the subcutaneous flap, whether it's thick or thin, the length of the stalk, and then the depth of the bowl. So what does that mean in comparison to an abdominoplasty? Well, as I mentioned, abdominoplasties are thin patients typically. The amount of subcutaneous tissue is very thin. In general, fascial anchoring sutures only get placed when the subcutaneous tissue is really thin and the bowl is superficial. I'll describe my algorithm, how I do it. I always trim the umbilical stalk when it's long and the bowl is deep, because you're trying to pull that scar closer to the fascia. So what does that look like? This is probably the most challenging type of umbilicus to make to make aesthetically pleasing. If you have a shallow bowl, a long stalk, and a thin flap, that's a recipe for having an external scar. So I think these are the type of patients that really need anchoring stitches. So if you have a thin subcutaneous flap and then you have a shallow bowl, you really need to put these stitches in. What do you do when your umbilical stalk length is really short? Well, you don't need to trim it because it's going to get pulled in. But what happens when that stalk length is really long? It really depends on the subcutaneous tissue. If your bowl is really deep, you can amputate that. There's many surgeons that I know that just amputate the umbilicus routinely to try to get that scar to be pulled in. But that is probably your simplest solution to getting an aesthetically pleasing result. So how do I manage the non-ideal breast footprint? So what is the ideal breast footprint? So I think the ideal footprint would be a nipple-sparing mastectomy, preferably with an IMF incision where there's no violation of the fold. So it's really easy to inset that breast, particularly a smaller breast, or an immediate skin-sparing mastectomy. I think we would all agree that this is going to be a really straightforward inset. A unilateral deep flap with this nature with an IMF incision is going to have a good breast footprint. But what's the non-ideal breast foot? That's a radiated breast, that's a delayed non-radiated breast, and perhaps even a delayed immediate reconstruction. So this would be an example. If you just forget about the contralateral breast, you've got a radiated skin-sparing mastectomy, a really challenging breast footprint. And this is my strategy for managing the radiated breast. I think the lower pole skin is useless, and I think that needs to be excised or deepithelialized, whatever your technique is. But I think symmetry with a contralateral IMF is critical, and so this needs to be marked pre-op. You cannot mark this on the table. You need to inset the abdominal closure ideally first. I was always taught close the belly before you inset the breast, but with the pace of the OR teams and with just the desire to get these patients off the table, we tend to start to inset the breasts as the bellies are getting closed. And so you need to take that into account with the closures and take into account that the IMF is going to drop. So the skin above the skin-sparing mastectomy incision can be used sparingly, but I typically don't excise it because that will raise your scar, and even though at the expense of radiating that tissue. And then you need to maintain enough skin on the flap. So what does that look like? Here's an example of a patient, radiated, delayed flap. You can see I mark the inframammary fold initially, and then we mark it slightly lower to take into account the greater drop that typically would occur on the other side. And then the skin that's below the incisions excise. I typically use the radiated skin on the inferior lateral side just to support the side of the breast, and then I do a 90-degree turn, or just over 90 degrees, to support the upper pole. And you can take a breast that was really a non-ideal footprint, and you can make it very, very symmetrical with the other side if you do a symmetry procedure. Here, let's move on to the radiated delayed immediate reconstruction. So I consider placing tissue expanders on all these patients. I think the goal of the tissue expander is really to expand the upper pole skin, not the lower pole skin. I still excise the lower pole skin regardless. I don't find that skin as useful. I think symmetry with a contralateral inframammary fold is the key to achieving a good result and is essential for creating this footprint for symmetry. And like I mentioned, all the skin above the upper pole, that's what I'm trying to expand and try to use that skin. And so if you do that, you excise that lower pole skin, you can really get a nice nice symmetry. So what is the next frontier for this type of reconstruction? I think we have to, again, look to our aesthetic colleagues. And those have to do with using, with procedures that are involving the belly. I think high-def liposuction has now become the standard of care in the aesthetic world. I think that's the next step for us. I think we need to start considering doing liposuction at the time of our closures, and perhaps even lipoetching at the time of our revisions. Thank you.
Any questions from the floor? Mark?
Thank you so much, Sebastian. I can say after doing a couple thousand of these procedures, I'm amazed at how much I just learned from your presentation. And so I particularly appreciated that you put it with a nod to being in an academic center and having to so often delegate a lot of these responsibilities. With the focus that patients are obviously going to place on this donor site, is it fair to delegate this, or how much personal responsibility do you take in these procedures?
So it comes down to supervision, right? So I think we have we know our own personal environments the best, right? So in my environment, I have trainees, I have physician assistants, but it's trainees that are really doing closures under supervision. And so I have to be vigilant and watching. If you have your own physician assistants that you have trained to do those procedures, I think it's important. But even in that scenario, you have physician assistants that are training other physician assistants. And so you have to trust that their delegation of roles is appropriate as well. So I think you have to know your own practice environment, but I don't think this is an opportunity for you just to walk out of the room. You need to be vigilant and know that, because at the end of the day, that's going to be your result. They're going to see what's on the outside, and we should be striving for more than just a living flap. And I think that's what a lot of our measurements in the literature do, is they look at our success based on that.
My question dovetails with Mark's as well. And again, Sebastian, excellent talk. I really enjoyed it. David Mathis and his group at University of Colorado, they did a study a couple of years ago where they looked at two groups of patients that had deep flaps. One had their scarpus layer closed, the other did not. The other was simply a deep dermal layer and a subcuticular. And the argument was that he was seeing a lot of incidences of fat necrosis because he was allowing his trainees to close the abdomen, and they weren't necessarily grabbing the fascia, they were just kind of grabbing a glob of fat. And oftentimes those little areas of fat necrosis became very painful to the patient, to the point where they required revision and excision of the fat grafting. I've seen that myself in my practice. And so I've stopped closing scarpus layer, and I have seen a reduction in fat necrosis, but no real increase in donor site dehiscence. So I was wondering how you close your abdomen. Do you do 3 layers or just 2, and have you seen a difference?
So it's a good question. I think it brings up to the point. I think the way we should be really looking at the outcomes is look at the high BMI patients, because if you can achieve good outcomes in that subset of population, you can achieve it with any patient. The residents know, many of them are in the room here, that I do a 3-layer closure, and what I emphasize is don't strangulate the fat, but now I don't know what the motivation of that study was. Was the motivation to decrease a complication at the expense of a better aesthetic result, or should we be striving to get that better aesthetic result? So just because you don't have fat necrosis, is that the best we can do? If they don't have fat necrosis, but they have a step off or hollowing, is that a success? I don't know what the answer is. I think we need to strive to do better. And I mean, it's a long operation, and so I get why people are trying to simplify closures with barbed sutures and whatnot. But at the end of the day, I think we should be really trying to achieve like an abdominoplasty result. And when you do an abdominoplasty, you are very careful when you're doing your closure, because the patient's paying for it. And we really need to strive for that.
All right. Thank you very much. Dr. Winokur. And thank you, everyone, for mostly staying on time, and because we were only 7 minutes over. So this. Oh, We have an announcement. So
yeah, just
we're
a
going
short
on.
announcement. I would like to ask you to either stay here to follow an industry symposium or go to the next room for lunch. Okay? So, just to, we're going to have
Okay, so industry symposium in here or lunch next door.
no, it wasn't a choice, you know, I'm just saying, you stay here, don't chit chat, either go there.
Thank you very much. Yeah,
Thank
absolutely.
you.
Great job.
Sorry.
It was really interesting. Ruben had 16 minutes of presentation, so we like 2 minutes of time, but it's great.
Yeah, there were a couple, there was like 3 people that knocked off the time.
Yeah,
it's all right.
It was pretty okay.
It's a great session. Of course, everybody's going to choose food over an industry.
I'm a little hungry, I have to admit.
I actually didn't sleep tonight, because I'm still jet lagged. No,
Jet lag.
I woke up at 1:30. I didn't know what to do.
Yeah.
I just stayed awake.
I get that when I go across too.
Yeah.
All of a sudden you're like awake. I can't get to bed.
Exactly. After a long day.
Yeah, that's exactly what it felt like.
Okay. All right, well, we're going to get started here. Thank you for attending the Mentor Symposium, lunch symposium, on the science of breast implants, how to boost innovation and patient outcomes. I'm William Kane, Bill Kane. I'm the medical director of Mentor, board-certified plastic surgeon before I became the medical director about 7 years ago. And I'd like to thank Mark and the other organizers of the meeting for having us. It's a real honor for Mentor to be a diamond sponsor for this event. You know, it's interesting when we talk about the innovation of breast implants, because I started my practice in 1994, and at that time the moratorium had just been placed, so I was pretty much limited to saline implants for my augmentation patients at the Mayo Clinic, where I started my practice, and only allowed to use gel devices if, in the setting of reconstruction. And we've come a long way. Through the course of my 20-year practice, we saw innovations such as shaping and texturing, increasing of the cohesivity of the gel. And what we now have embarked upon is an era where, at least in the United States, there's a push to use round implants, particularly without texture. And so our engineers and our scientists have gone to work on trying to look at the device and do as much innovation to the shell, to the gel, and to the fill in an effort to try and make a better implant. And just as Mark pointed out, you know, for plastic surgeons, the effort should always be, in the spirit for this meeting, to be better. I see that very much alive in Mentor, in terms of us always trying to build a better implant to give surgeons more in their toolbox, but also to get a better outcome for our patients. So it's my pleasure today to kind of show you some of our early results, and we're very honored to have with us Dr. Brian Thornton from Louisville, Kentucky, who has a very busy reconstructive practice and is going to talk to us about how Boost and other Mentor implants are helping him achieve the results he's looking for in his practice. We're also joined by Dr. Essie Yates from Fort Lauderdale, Florida, who is the director of the Yates Institute of Plastic Surgery. And she is a very broad practice that features both reconstruction and cosmetic breast procedures involving breast implants. And will really talk to us how she's putting the entire Mentor portfolio to work to address clinical needs and to get better outcomes. And then we're also joined by Lucas Heldman, who is one of the principal engineers at Mentor, involved in the R&D department, and he is very much involved in the development of Boost, and will speak to you as to how it was developed and many of the preclinical studies that went on at the benchtop to make an implant that would address surgeons' needs as they were expressed to us. And without further ado, I'd like to give the podium to Dr. Brian Thornton. Thank you, Brian.
Thanks, Bill. Thank you for those of us in the room and joining us online as well. And thanks for that kind introduction, Bill. Let's see if I can make this move forward. So some disclosures. So before I move off disclosures, which is one of the most fantastic slides always to stop and peer at for a long period of time, I want to challenge us all to think about an implant for a second, in particular a silicone implant. And I want to think about what drives the performance of the implant, right? I had never thought about that in 17 years of practice until recently. Like, what is it in the implant that's giving my good or bad results, right? And it's really more than just the silicone, right? That's what I've always considered. It's just the silicone that's really doing everything, and that's all I should be really worried about. But with Mentor, we really think about three different opportunities or three different things that really contribute to the performance of the implant. The synergy of all three of these we think are terribly important. So the first thing is the gel, right? And we'll talk a little bit about the gel, but the shell, that container around that silicone, is terribly important for the performance of the implant. And then lastly, how much is filled in that implant, or the precision filling of the gel, is critically important as well. So let's talk about gel for a second, right? So we all kind of know that silicone is a cyclic molecule. The cyclic ring is broken open to create these long strands of silicone. And that silicone is very fluid unless we start collecting or connecting the silicone molecules together, right? Cross-linking it. The more cross-linked the silicone is, the more cohesive it is, right? I think about silicone molecules themselves being kind of rungs on a ladder or rails on a ladder, with the rung is the cross-link. And so if you get on a ladder and it's got its two rails and it only has one cross-link around it, you know, be prepared to get your health insurance card out, because it's not a very stable ladder. Like, I'm not crawling up that ladder to change light bulbs. But the more cross-linking we put between those silicone molecules or the rails on the ladder, the more stable it becomes and the more cross-linked that is, right? So that's what cross-linking is. And you can't really talk about cross-linking or cohesivity across manufacturers. Cohesivity one of one company is not equal to cohesivity one of another company. It may be equal to something entirely different. I'm a big fan of electric cars. I have a Tesla I'm very happy and proud of. It's like comparing all electric cars is the same. Oh, a Prius is the same as your Model X. Well, I will tell you the performance is very different between a Model X and a Toyota Prius, right? They're both electric cars. We're not going to disagree with that, but it's not the same thing. So when we're talking about cohesivity, we have to be careful about talking about that across the manufacturers. So when we think about gel, there is a standard of what Mentor uses to measure their cohesivity. They want to be the same in every implant they create. They have two different ways they do this. One is a penetration test where they're simply compressing the silicone. More highly cohesive silicone implants in their manufacturing line will not penetrate as well. Less cohesivity will penetrate further. Slump test is another thing they do. A certain molecules or a volume of silicone is placed across this, and then over a 30-minute time frame, we look to see how much is slumping or settling through these little circles to make sure that we're doing the same cohesivity, the same cross-linking within the company. But again, this is not a standard across all manufacturers or required by the FDA. Next is really about the shell. Does the shell have some impact on the performance of the implant? Well, we believe it does. So at Mentor, we have a trilaminar shell, right? We have these two methyl groups that have a phenyl group on the inside. That phenyl group is what's preventing bleed of our silicone from outside of our implants. But it's that trilaminar shell that really is the magic of holding all the silicone together inside the device. Mentor has a very unique thing of how they go about their shell. So they do have validated requirements that are required by the FDA or standardized across all manufacturers in the way the shell is performing on the device. But the shell can impact the actual look of the device as well. It can impact the way it feels. So firm devices can feel maybe a little bit softer with the right shell, and soft devices you can make feel firmer with a little bit difference or change in the shell as well. So that shell has a real impact on the performance of the device as well. Interestingly, I think with Mentor is the way they create their shells. So following the automobile manufacturing way, they have robot technology that's spraying their shells. So even though their shells are stronger than your manufacturers, but it's also thinner. So it's a thinner shell that performs better than the other manufacturers, and it's stronger in its overall materials and properties. Lastly is the fill of the device. So does the fill or how much is in the device affect the performance of the implant as well? And the answer, of course, is yes. Most manufacturers, including Mentor through at least the last, all but the last two product lines, would fill their implants based either on a percentage fill or some fill ratio. But starting with the Mentor Memory Gel Extra line of implants, we really started asking the question, a simple question really, could we not just put more silicone in the device? Could we avoid ashtraying of the implant if we overfilled or filled the device a little bit more? And we know that as a result of that, that certainly impacts the way the device looks, as we show here with Memory Gel Boost compared to another cohesive implant. So precision filling makes a huge difference in this. It can also impact the fill of the devices we talked about. It can make a firm implant feel softer or a soft implant feel firmer simply by the precision fill. This is equated easily with less highly filled devices. So when we're thinking about Mentor Memory Gel in this way, the shell doesn't play a lot of role in the way that implant performs or the way that implant handles. But as we started doing more precision filling, we started seeing that the shell had a major role or a more important role in the way that device performed or how it handled. So precision filling can impact that. So we feel like there should be an optimum amount of silicone in every implant device. And as I talked about for Mentor Memory Gel, originally that did not start with that, but with the extra gel it did. So every one of those implants that you see that doesn't have a volume number that makes any sense when you're ordering out of the catalog, it's because the manufacturer, Mentor, decided to take each one of those implant shells, fill that shell with differing levels of silicone to see what its performance is, to figure out what is the optimum fill of each of these implant SKUs. And so that's why for both Mentor Memory Gel Boost and Extra, we see this. We see very strange numbers. That's because of the precision filling technology. We also see this in the way the implants are performing, right? So Memory Gel Extra on the left, followed by Boost, followed by two other cohesive devices, typically don't reveal itself with as much rippling and wrinkling as maybe the other manufacturers do. And again, this is precision fill technology that really got ahead of this in our standing. So the question is, how does that all form and stand up against other competitors? And in particular, how's it measured, right? It's really hard to measure that subjectively in vitro inside of patients, but at least Lucas is going to explain to us some options of what they figured out for some benchtop testing. So Lucas, come talk to us a little bit.
All right, thank you, Dr. Thornton. So yes, the main focus of this will be Memory Gel Boost, but we also want to be inclusive of the entire Mentor line, where we have three distinct options: the Memory Gel Extra, and now the new Memory Gel Boost that launched earlier this year in the United States. So when we talk about Memory Gel Boost, that is the round, highly cohesive gel implant. And so the one main thing when you think about look is form stability, right? How is it going to hold the upper pole? So there was two different ways we did to look at the performance of this. One was a single point analysis where we were looking at maximum point of projection, or we also call it maximum point of peak projection. And that's indicated by the star in each of those three images. Essentially, it's where the peak projection occurs in the lower pole. You can see for Memory Gel Boost all the way on the right in that blue that it has the highest maximum point of projection, mostly because of that highly cohesive gel that's inside. Moving to the left, you have Memory Gel Extra and Memory Gel, both with slightly lower maximum points of projection. There we go. So building off that single point analysis, we also looked at a three-dimensional analysis. We would be remiss to talk about upper pole without looking at upper pole volume. So in this case, we are looking at how much upper pole is retained when we move from the horizontal to vertical orientation. Again, you can see the Mentor's portfolio. We have Memory Gel Extra, as well as Memory Gel Boost in ascending order in terms of upper pole fullness. So talk a little bit more about the maximum point of projection and how we actually measured that. So we started the implants in a latex pocket. And this latex is the same that Hollywood uses in The Walking Dead or any of those shows or movies that you see to kind of replicate skin. And the reason we did this is it's very thin but very elastic. And it really kind of represents a pre-pec reconstruction where you have maybe a little bit of a skin flap, but also just a little bit of subcutaneous tissue, but overall very thin tissue flap covering the implant. We put the implants inside of this latex pocket and we 3D scanned them in the horizontal orientation. When we did that, we found that maximum point of projection in the horizontal, and that was basically our baseline. And this was a 3D scan, completely hands-free. There's no calipers or height gauges or anything like that. This is using 3D scanning software and importing it into CAD where we can take these measurements all through the software. We then flipped that implant into the vertical orientation, and we measured how much that maximum point of projection dropped. So the lower that maximum point of projection drop, the less form stable the implant, or vice versa. The minimal drop, the more form stable it is. So we're really characterizing the form stability implant by how much that maximum point of projection changes as we move from horizontal to vertical. So looking at the competitive results across major implants in the US, Memory Gel Boost actually has the lowest bar or the lowest drop in maximum point of projection, indicating it is the most form stable implant in this test method. So other implants that we tested included the Inspire Cohesive and Soft Touch, as well as the Sientra HSC Plus. And you can see visually on the right-hand side that star indicates that maximum point of projection, and you can see how it sits highest for the Memory Gel Boost implant. That green dashed line represents where that maximum point of projection sits for Memory Gel Boost, and you can see the stars for all the other competitor implants sit below that line, indicating a lower maximum point of projection. So that's a great analysis, but that's only one single point. That does not characterize an entire surface or implant. So that's where we took those results and built upon them to look at the upper pole retention, essentially how much volume is being retained in the upper pole. So in a similar method, we put the implants in horizontal. In this case, they're not in a latex pocket. This is purely just sitting on the benchtop. And then we move them into the vertical orientation. In this case, they were fixated to a board, and so you can kind of see how they're glued at the very top of the implant. And we essentially let the implants hang and see how they deform as a result of gravity. So this is essentially the implant under its own weight, just purely from gravity, no other forces acting on it. Of course, as we move from horizontal to vertical, the more upper pole volume that's maintained, the more form stable the implant, and vice versa. So again, looking at the competitive results, we have from left to right the Sientra HSC Plus, both the Inspire Soft Touch and Cohesive, and the best performing is Memory Gel Boost with 85.8% upper pole fullness. I just want to make very clear, this is a benchtop method. This is not anticipated to be clinical results. These do look slightly artificial in the sense that they are just fixated to a board. There is no soft tissue coverage. There is no IMF. There is nothing kind of obstructing the implants from just hanging and taking their own shape as a result of gravity. But you can clearly see how Memory Gel Boost has the highest upper pole fullness across the different implants we tested. Building off of that, so not only does look matter, but of course softness matters as well when we talk about breast implant performance. So we conducted this lateral compression test where we have these two little white spacers that come in and are motorized and compress the implant a set distance about 1/3 of the diameter of the implant. And so again, this is very scientific and an objective method where we're not touching the implant in any way, and it's all controlled through software. So for the Mentor line, we have 3 distinct results: Memory Gel Extra, and Memory Gel Boost. And you can see that on the bar graph on the right, on the left. And you can see how each one differentiates itself from the other. When we compare the results across competitors, we can see Sientra HSC and HSC Plus really don't offer much differentiation. They're actually perform very similar in this test method, and they both perform similarly to the Memory Gel Extra. When we look at Memory Gel Extra in particular, we can see how it is softer than the Allergan Soft Touch. The lower that bar is, the softer the implant, or the higher the bar is, the more firm the implant is. We can also see that the Memory Gel Boost sits directly in between the Allergan Soft Touch and Cohesive, and is slightly softer than the Allergan Cohesive in particular. So again, Mentor now has 3 distinct options. One's not better than the other per se, but there's 3 options depending on patient and your preferred needs. So we have the existing Memory Gel and Memory Gel Extra, and now we are very excited about the new Memory Gel Boost that provides the increased form stability to shape the breast while maintaining the natural feel. So when we kind of characterize both the feel and the look together, we kind of plot them here on the XY chart. So the x-axis is the lateral compression that we just viewed on the previous slide. You can see again, Memory Gel Extra, and now Memory Gel Boost are 3 distinct options both in terms of feel and look in terms of form stability, which is characterized on the y-axis. That's the upper pole retention. But we didn't just stop there to show what Mentor looks like. We also plotted the competitors. And again, you can see for Sientra, the HSC and the HSC Plus, very similar performance. They don't offer much differentiation. And while HSC Plus might be claimed as a form stable implant, it's really performing at the level of Memory Gel Extra. When we look at Memory Gel Boost in particular, we can see how it sort of sits exactly between Allergan Soft Touch and Cohesive. Whereas Soft Touch, you might have to look for more better feel, but compromise on form stability. And on Cohesive, you might have to have more form stability, but compromise on feel. Memory Gel Boost offers both, where you no longer have to compromise. You can have both feel and look without compromising on either. So that's just an overview of the benchtop performance for Memory Gel Boost. I'm going to pass it to Dr. Yates to talk a little bit about the clinical performance so far.
Would you be able to pull up my slides, please? Thank you so much. Hi, good afternoon, everybody. Thank you both for the science and the innovation behind the Mentor portfolio of breast implants. I'm hoping to talk about how I've utilized that and understanding that to optimize my outcomes in the aesthetic breast surgery world. Okay, so just some disclosures. And the first case example that I have is looking at primary breast augmentation and how different implants help us to achieve better outcomes in better suited patients, even when clinically they present with the same goal. But as you can see from those patients, even though they have a similar BMI, a similar height, a similar body habitus, they're presenting with very different initial presentations in terms of baseline. The patient number 1, you can see, has a small breast with normatosis, appropriate nipple areola complex size and position. Patient number 2 has asymmetries in breast volume, nipple areola complex size and position, and breast volume. Okay. So in addition to all the typical things we do when assessing a patient for primary breast augmentation, where we look at breast volume, symmetry, density, size and position of the areola, degree of ptosis, we also obviously need to look at things such as chest wall characteristics. Pectus and scoliosis can result in postoperative asymmetries in a primary breast augmentation. We also need to talk with the patients about their desires, whether that's volume and upper pole fullness. That will help guide us in the next stage of our evaluation, which is the considerations for implant selection. So when I examine a patient, I'm looking at what the projection that the patient will require to meet their aesthetic goals. I'm measuring the base width of the patient to help me to guide implant selection. And then to the focus of this presentation, I'm looking at what implant style and type will best achieve the patient's goals and aspirations. So in the first patient, who you can see has a beautiful baseline breast shape and really was just opting for volumization, opting to go from a 32B to a double D. I approached this patient with an inframammary fold approach. I used a high-profile implant, 475 cc's, and you can see here that in terms of base width and projection, she got that full upper pole that she was seeking for in terms of her aesthetic aspirations. The second patient in this case series, who was more interested in more upper pole fullness, resolution of the breast shape to reflect her pre-pregnancy breast, and really just a small incremental increase in size, was best suited with a memory gel boost. And the side view best explains why this was chosen, and you can see how we were able to get much better upper pole fullness, even though there is a distinct porosity in soft tissue. There's a poor quality skin envelope, but we were able to achieve a stable upper pole fullness. She did not want to go significantly bigger, so the base width of this implant did not particularly increase the diameter of the breast, as you can see here. And the thing that she liked the most was, in addition it to being soft, in addition to her upper pole fullness, that the overall shape of the gland, particularly in the region of the nipple areola complex and the lower pole, met her aesthetic goals. So you've seen this slide before, and this is just to reiterate and illustrate the point that the whole portfolio have different strengths and limitations, like any implant that's on the market. I think our job as aesthetic or reconstructive surgeons is really to identify what is our patient's clinical problem. And if we understand the advantages and disadvantages of each particular device in the portfolio, we can help guide our patients with implant selection and produce more optimal aesthetic results. This case study is a more complicated patient who came in. She was seeking, ideally, a single-stage augmentation mastopexy. And of course, like many of you in the audience, this may be routinely approached as a two-stage approach. If it is attempted as a one-stage approach, which I do routinely in my practice, I do set the patient up with an estimated 50% likelihood of a revision. And we all know that revision rates are high in these patients if we do them as a single stage. In analysis of this patient, and it was an interesting case as she came from out of town, the processes in my practice is they come in a day or two before after doing a televisit with videos, photos, for an in-person physical exam and counseling. So obviously she has severe ptosis, minimal soft tissue coverage, and clinically it was even worse than is illustrated in the photos. Distinct lack of upper pole fullness, which was a combination of lactation and massive weight loss over 100 pounds. And clearly poor skin elasticity and no recoil of the tissue following deflation of the breast tissue. She had, on top of that, just to complicate matters, considerations regarding a dynamic breast deformity, as her goals were related to becoming a fitness model and photographing the breast, and so a dynamic breast was a serious consideration for her, and she had a strong desire to avoid this. So like all of us, we counsel the patients, what are the advantages and disadvantages in terms of approach, in terms of subglandular and subpectoral when it comes to dynamic deformities, rippling or visibility of the implant, what a likely breast shape is going to be untable in the short term, and in the long term in terms of longevity and stability of the pexy and breast shape. In this particular case, given that she said most likely I'll need a secondary procedure, I really don't want a dynamic breast, I'd like to go ahead and do a subglandular aug mastopexy with the understanding, if this doesn't work out for me, I will come for a secondary procedure. Unsurprisingly, the result was not outstanding with a subglandular pexy, but what we did get to do was reduce all of the extra skin envelope, reposition the nipple areolar complex, and you can see here that to no great surprise with skin elasticity that's poor. She had very quick recurrent ptosis, and that was the result 6 months out. So she did come back to me to do the secondary procedure as we discussed, and given that she saw the outcome in the subglandular plane, she did agree to exchange planes into the submuscular plane. Another point that is hard to appreciate with these particular tables, which patient pictures which are on table, is that she had pretty severe rippling in that ptotic breast that had downward displacement of the implant position. So I did switch planes, I did upsize her implant a little bit, and I did switch her to the memory gel boost. So I switched her to a high profile 520 cc breast implant here, and just for illustration, I think it's labeled, but I just want to make sure it's clear. So this was one side with the secondary procedure done in the submuscular plane with the boost implant, and the 6 months post-op on the left side there was the patient with the memory gel implant in situ. So this was her results 2 months post-op, so much more stable result, wonderful upper pole fullness, and she did go on to do the modeling. That was her goals, aspirations, and drive to do the surgery in the first place. So what I learned from this case is that when I really want a lot of upper pole fullness, and speaking to the results from some of the scientific studies, that we get a better retention of upper pole fullness in patients using a boost device compared to a memory gel or an extra. And where this is mostly relevant, and it's important because in the cosmetic space, cost is an important consideration for patients. So recognizing that in these particular patients, even though it is a slightly more costly device, if you want to have more upper pole projection, if the patient's prone to rippling, if the patient is highly desiring of a shape when there is this much progress that needs to be made by the intraoperative intervention, you're probably going to get that with a boost device and less so with memory gel. So this comes back to my initial point, was understanding the strength and attributes of the implant. It really shows how in the same patient with the same operation, choice of implant device can really impact your outcomes. The other thing to point out is when we measure the base width of patients that want a lot of upper pole fullness and a highly projecting implant, one of the things that often gets missed is the fact that within the portfolio, there can be quite substantial differences. So you can see here for the memory gel extra, in that particular patient, she ended up with an implant in the 500 cc range. You can see there that the base width is 13.1 for that device. In comparison to the boost device, you can get almost a centimeter less of base width. So in a patient who wants certain fullness and projection, that has a narrower chest wall, that's very afraid of excess breast or implant on the lateral breast, a paucity of breast tissue that may result in increased rippling, if there is excessive lateral fullness, you're really seeing an advantage to understanding the portfolio and recognizing for the same volume, you can get more projection, significantly more projection. In this case, almost a centimeter more projection with a centimeter reduction in base width. So in well-selected patients, that's really going to improve your outcomes. So when do I use the shaped implant? I use it in patients that desire a more natural upper pole, and really those patients are limited in my practice to the unilateral hypoplastic breast. The adolescent girl, you're doing a reductional mastopexy on the contralateral breast. You know in 3 or 4 years there's going to be some ptosis of that breast, so putting a round implant is less likely to give you a stable, long-term cosmetic outcome. In some patients, multiple revisions. It's important to stabilize the breast implant, especially if they're prone to bottoming out or have a superiorly based nipple areolar complex. So those are the instances where I do think there's a distinct advantage to a shaped implant. For revision aesthetic breast surgery, of course, we analyze size, shape, projection, and symmetry. I'm always evaluating the nipple areolar complex, size, shape, and position. Is the visibility or rippling of the implant? And if there's a dynamic deformity. As a person that does a lot of secondary and tertiary revisions, both referred to me from the community and people that find me from afar, I spend a lot of time counseling patients that sometimes the enemy of good is better. Sometimes patients have unrealistic expectations, but by evaluating them systematically in that way and knowing our implant portfolio, we can really give a realistic expectation in terms of risks and benefits and predicted outcomes for our patients. The last case here, which I'll go through quickly in the interest of time, was a capsular contraction case. You can see this patient has a capsular contraction of the left breast, squaring of the breast. She has nipple areolar complex asymmetry, and you can see here, just in the footprints that are marked here, that when you measure things out, there's pretty significant differences here. She'd had a lumpectomy of the right breast for benign lesion and had significant tethering and indentation there. So in terms of the surgical plan, what I did for her was a bilateral implant exchange, capsulectomy bilaterally, and I did switch implant planes. That can be a tenuous and a little risky, and I think being mindful that your internal mammary perforators are intact is an important consideration in that setting of switching planes together with a mastopexy. I did do liposuction to the lateral breast and bra line, and then subcision for tethering of the scar in the right upper quadrant. So you can see her postoperatively here. I used a high-profile mental memory gel implant, and you can see that her breast footprints were normalized, the nipple areolar complex were equalized, and I don't think the side view's there, but she had much more improvement in her projection of her breast postoperatively. Another thing to touch on is in addition to implant selection, your postoperative protocols are going to increase the success of some of these complex cases, such as multiple time recurrent capsular contraction. And so in addition to the surgical plan as outlined, I think it's really important for compression, activity restrictions to involve to decrease hematoma. As soon as they come in and on the schedule, I do put them on a regimen of vitamin E, doxycycline, and Singular. So it's 1,000 international units of vitamin E, doxycycline 100 milligrams once daily, and Singular 10 milligrams. Low threshold for implant massage, ultrasound therapies, banding therapies post-procedure, and then, a lot of counseling and laying crepe in, 3rd, 4th time recurrent capsular contractions. And in this case, nobody had really done a total capsulectomy. Nobody had put her on preoperative oral regimen, no aggressive postoperative regimen, which is, the reason we approached and offered her the surgery. But realistically, we know there's a high chance of recurrence in these cosmetic patients. So in terms of final pearls, I really believe that understanding the portfolio of implants really optimize our outcome. Each device in the mental portfolio was designed with a problem in mind. If you can identify what that problem is, whether it's rippling, whether it's I want a softer breast, whether it's I need more upper pole fullness, whether I have a perfect breast and I'm really cost sensitive, and if it's too expensive, it'll be cost prohibitive to me. It allows you to work through all of the patient's needs and wants, all of your surgical considerations to recommend the best device for the patient. Of course, systematic evaluation, surgical planning is going to produce the most consistent and predictable outcomes. I really rely on implant consignment because it gives me the opportunity intraoperatively to be dynamic and make game day decisions, which are very important because even though we try our best to pay attention to things like chest wall asymmetry and preoperative volume asymmetry, it's not unfrequently that I find myself tweaking my plan slightly. So having sizes available and full implant consignment in my surgical office really helps me to give patients more symmetrical outcomes. The Mentor Memory Gel Boost was what I find to be an innovative and recent addition to the portfolio. I do have a reconstructive practice, and I've moved almost universally to using the Boost in the reconstructive setting purely because one of the commonest complaints is lack of upper pole fullness, extensive rippling, and of course, not only do they have often thin skin flaps, they have no breast tissue. So that reduction in rippling and increased form stability allows us to reduce revisions and things such as fat grafting, et cetera. And of course, realistic patient expectations, minimize revisions, and increase patient satisfactions.
Thank you, everybody. Those were excellent presentations, very enlightening and very thoughtful. I have a couple of questions. Lucas, if you could maybe elaborate a bit more on just the history of filling a shell with gel. I mean, what parameters went into the original design of like our memory gel implant? And then obviously that gave you the opportunity to kind of change that single variable with our newer products.
Yeah, so definitely. So for memory gel, I think it was purposely underfilled to really allow it to take the shape of the breast, right? So if you're doing a two-stage reconstruction and you create that pocket, the implant's going to take its shape. Of course, the recent trends are the precision, what we call precision filling. So with memory gel extra and memory gel boost, it's a very SKU by SKU analysis. So it's not like we went 10% across the board and put just 10% more gel in every single SKU. It was literally going into the lab and basically perfecting or optimizing every single SKU to have that optimal precision fill. And it wasn't a case where we did it once for memory gel extra and we did this, just took those values and went forward with memory gel boost. We repeated the whole process for memory gel boost. So we went through quite a painful process, if you will, but it was well worth it because you get the optimized look and feel of each individual implant.
Yeah, and to me, it emphasizes the art of not only breast surgery with an implant, but the creation of an implant itself, because some of it is subjective in terms of filling it out so that it has the least amount of wrinkles and creases and folds. And then the other part I took from your talk and Brian's was that to some extent, when you take a memory gel implant and you turn it on end, it kind of becomes, to a degree, a shaped implant, because it does so more so than boost or extra in terms of the degree to which it holds its roundness of shape in a vertical position. So I think there's probably also opportunities there for circumstances where you intend to use a more shaped implant is to think about it in those terms as well. Any comments from our panelists on that in terms of something that's between a shaped implant and a round implant? Going the whole spectrum from something that stays very round to something that's designed to be shaped.
Yeah, I think in the recon space where I mostly jog or run or toddle along, for me it's now becoming this concept of thin patient, not great soft tissue support after two-stage reconstruction. That's a great boost patient, I think. I think for our heavy patients, obese patients with thick flaps where they probably just don't need any fat grafting at all, but I want a lot of softness, I think more about Mentor memory gel. And then extra kind of straddles the line of those two things. Mm-hmm. So I do think in my mind there's this evolution of best implant for best patient, and now I have three options to consider in that line. I don't know if Dr. Yates has additional thoughts.
Yeah, I do a lot of direct implant reconstruction or pre-pectoral. So I really feel that the boost implant has kind of revolutionized the number of takebacks I'm having to do for fat grafting. And in particular in those patients, my breast surgeons are wonderful, but they do produce thinner flaps. And so seeing the difference in performance of the implants did change some of my decision-making in terms of implant selection.
Very good. Yes, Dr. Clemens.
When I reach for a higher cohesive implant, I am looking for something that holds its shape better and has that extra projection. And I think that you covered that really elegantly through the presentation. However, I think that my patients, when they're thinking about getting a higher cohesive implant, they're more thinking about the long-term safety profile of that high cohesive. Specifically, rupture rate, if it's higher cohesive, ideally it would stay together better. And also gel bleed. Shell is intact, but some of that silicone comes out. higher cohesive, we would think that it would be less. That didn't seem to pan out with the shaped, textured implants. That was the hope, 10 years ago. And yet we saw with tissue ingrowth, particularly with the macrotextured implants, that it was almost the tissue ingrowth could fracture or rip the shell apart. We actually saw higher implant rupture rates. With an implant like this, higher cohesive, round, smooth, are we finally to a point, and do we have the data to say it is lower rupture because of the higher cohesive, it is lower gel bleed because of the higher cohesive?
I'll take a stab at that. I think that, and I think you hit the mark on the head, Mark, is the fact that, the problem with the form stable devices, they were firm. I just didn't like them in breast reconstruction. And then texture became an issue, as you certainly well know. But I think it's that combination of the texture with that. And I don't think we know yet. To your real question, we'll know in years, right, whether this really is the panacea of less rupture, everything that we would have thought out of the form stable devices that never panned out.
Is there even any preclinical work to show that the cross-linking of that cohesivity doesn't migrate a shell as much? Obviously we need biopsies long-term, but we just don't have that data yet.
Don't think we have that data.
I can speak to it, yeah. I mean, part of our FDA submission did include gel bleed testing for memory gel boost, and I mean, the levels that we operate in, they're so small, it's beyond our detectable limits. So both for, obviously the memory gel line, but now the memory gel boost have gone gel bleed testing. And, in terms of, risks and exposure limits for heavy metals or anything like that, they're all well below any potential dangerous, exposure limits.
Did you just have an X amount, or did you actually compare it to your older generation implants?
I don't think we've done a comparative analysis quite per se, but again, it's hard to compare apples to apples in some senses, just because the test is so sensitive. There's a lot of noise in the test as well.
Thank you so much.
Yeah, I guess I would add to that by saying, in terms of rupture, it'll be interesting to see, because, in terms of filling the device out so that the shell is not creased, wrinkled, redundant on itself, you'd hope that would have a positive influence over time on rupture, but it's going to take a number of years to see whether that's true or not. And in addition, capsular contracture sometimes has the final word on all of that, because, obviously if a capsule tightens around an implant. And that was one of the questions I was going to ask you guys. As we talk more and more about form stability, do you think there's a level of capsular contracture that can be overcome by a more form stable implant that in the past, with a softer implant, would create a clinical problem or noticeable firmness or asymmetry?
I haven't seen anything personally that would...
Yeah, I mean, we've used Boost since March, but I think regardless, to me, as I try to explain to patients, capsular contracture is progressive. A little bad this year, worse next year, continues to get worse. So if you talk about a really soft implant, it's contracting, it will feel better long term compared to a more stiffer implant or more cohesive. But I think at the end of the day, they're all going to feel terrible. It's just a question of time.
Yes, sir.
Yeah, in the Swedish breast implant registry, we just introduced a new variable, which is cohesivity, and we try to simplify it like dichotomous yes or no. For the mentor implants, we said 1 is not form stable, and 2 and 3 are form stable. But here you have, the softer gel with overfill. So I've got the question, how should we, characterize memory gel extra? And I say it's form stable. So do you agree?
It's more cohesive, but I don't know if that determines that it's form stable, personally. Because I don't think about that. I think about Boost as really being that, at least to us in the U.S. who prefer to stay away from texture, is the first form stable device that feels comfortable to use, right? But I don't think about extra gel being form stable in the same sense. Lucas?
Yeah, no, I would definitely agree. Memory gel boost is very clearly the most form stable. I think every implant is form stable to some degree, right? Even memory gel. It's not like it's a puddle of water completely losing its shape as a result of gravity. I think memory gel extra is kind of in that middle nebulous space in the sense that it almost behaves like a form stable implant, but it is, we call it, cohesive one, that cohesive gel that's not quite the same as memory gel boost. So it's certainly in that gray area middle zone, but it has some form stability performance to it for sure.
No answer. We got no answer for you.
Thank you.
I got another question, just in terms of wrinkling and rippling. You know, my whole career, I knew it was attributable to multiple factors, right? Because sometimes you saw it with the woman with her leaning forward, like a traction type rippling. Sometimes it was related to the thickness of the shell. So you used a textured implant, got less capsular contracture, but you got a thicker shell that in certain positions created rippling and wrinkling. Had nothing to do with the implant. Sometimes it's the skin can cause that. So you guys have had a chance to look at this device with one variable controlled. That is, you know, if you're going to try and reduce rippling and wrinkling, go after the one thing you can control, which is start with an implant that has less rippling and wrinkling to begin with. What's your impact on terms of how much you're disguising that or camouflaging it, having to revise for it, using fat grafting, now that you have an implant that doesn't have any ripples or wrinkles?
Yeah, unlike Dr. Clemens, I still fat graft routinely on every tissue expander to implant exchange. What's changed for me is it used to we averaged about 2 surgeries of fat grafting, so 1 in exchange, and then 70% of our patients, according to the database, would need 1 more fat grafting. Since March, that number has gotten down to 30%. So I tell patients they need 2.3 surgeries on average to complete their reconstruction. So it feels like we're doing the need to do less fat grafting since March. Now, that's very loosely feeling in the practice and everything else, and I've not published that data by any means, but I do think it's doing it. Now, it's not the panacea. And I tell patients, look, if we put a brick in your breast, it won't ripple, but I don't think a breast should feel like a brick either. So there's got to be this trade-off of still softness with less rippling and wrinkling, and exactly to your point, there's so many variables that make that happen between patient characteristics and type of breast surgeon and a variety of things. I think it's always going to be difficult. I think our unique challenge is to either think about doing escape techniques like Mark does or a P1 technique, all these other options that kind of further help limit the total number of surgeries we have to put our patients through.
You know, I think specifically in the reconstructive space, it's going to be breast surgeon dependent and surgeon dependent. If you have a higher BMI cohort as your general patient demographics, your dependency on the implant to give you decreased rippling and visibility is going to be totally different to those low BMI patients, pre-pec versus sub-pec, mastectomy flap thickness. So I think there's a lot of variables, but certainly in the thinner patient, we are seeing, at least anecdotally, the need for less rounds of fat grafting for the upper pole in terms of both step up and rippling and visibility of the implant.
Very nice. Unless there are any other questions, I think we're out of time, but once again, thank you to our panelists and thank you for attending.
Sì, adesso glielo dico, non ti preoccupare.
Okay.
Do you want us to go ahead and start, or do you want us to wait for, okay.
No, we try to send everything.
questions at the end?
Questions at the end or after each?
Oh, I'm sorry.
11 minutes presentation and 4 minutes.
It's written all here. Okay, perfect.
You're going to have a timer there. So once the timer is done, a 4-minute timer starts for the question.
As you can see, you have
And we do
three
questions
virtual
after every presentation.
here.
Okay.
It's Nelican, Singai, Yacheng, they're all virtual.
Nelican.
They should be joining for the discussion, but they still haven't joined
Single.
yet.
Okay, all right. So how long do we have for discussions at the end? 4 minutes at the end.
We just show you everything. So you just see 11 minutes presentation, 4 minutes discussion. But I will be here again for any if you need.
Okay.
Do you want me to
Huh? Why don't we alternate, yes? Huh?
Who's starting?
Is Neligan here?
I think it's virtual.
Neligan's virtual. Okay. All right, I think we're going to go ahead and get started with this session. We've been really looking forward to this. Management of lymphedema in the post-mastectomy setting is a exciting topic that we've seen a lot of growth and exciting new research in, and we have some excellent speakers lined up for this session. So without further ado, we have Dr. Mark Shavrin, who is an associate professor of plastic surgery at University of Texas MD Anderson Cancer Center and one of our partners. So welcome, Mark.
Thank you, Carrie, and thank you to Mark and Fabio for inviting me to talk today on patient selection decision algorithm for lymphedema surgery. I have no disclosures. This process really starts off with a diagnosis and staging, understanding that there's no optimal modality for diagnosing a patient with lymphedema. And so a multimodal approach is necessary to increase the reliability of a diagnosis. This primarily starts with a focused history and clinical examination, and then there are other adjunctive tests to support a diagnosis, including a physiological staging. This is usually done with ICG lymphography, although it can be done with magnetic resonance lymphography, and in selected cases, lymphoscintigraphy. Volume measurements are important, and these are predominantly done by pyrometry, although it can be done with tape measure circumferential measurements. Extracellular fluid measurements using bioimpedance spectroscopy, and patient-reported outcomes are important also. And so a typical lymphedema patient evaluation in the outpatient setting will consist of pyrometer measurements. It's really important these are standardized for consistency in following outcomes. Bioimpedance spectroscopy, we use the SOZO iteration, which we found to be highly reliable, and then ICG lymphography. And again, we can use adjunctive MRL or lymphoscintigraphy as is necessary to support a diagnosis. And so from there, we ascribe a staging. We use the MD Anderson staging ICG scale, which is highly reliable and reproducible, and it evaluates the qualitative and quantitative distribution of the dermal backflow. It's also important to characterize the dermal backflow, as this corresponds histologically to the condition of the lymphatic vessels, and therefore to the likelihood of a patient being suitable for a lymphovenous bypass. And it's also important to note that almost all patients, if not all, have a component of comorbid venous insufficiency. And where this is clinically significant, this needs to be investigated in coordination with our vascular surgery colleagues, if necessary, addressed through percutaneous or open approach before lymphedema surgery is considered. And this is in addition to, obviously, a thorough axillary scar lysis. And so when it comes to patient selection, it's important to note that these patients are very complicated and they need to be managed in a multidisciplinary, patient-centered approach, predominantly in concert with our colleagues in lymphedema physical therapy, but also radiology, oncology, medicine. It is important that these patients are regarded as research patients because we still have a lot to learn. And this can be coordinated in a center of excellence. At MD Anderson, we are a lymphedema comprehensive cancer center of excellence through the LEARN organization. And when it comes to patient selection, it's important to note that once patients have a diagnosis of lymphedema confirmed on lymphatic imaging and other causes of lymph swelling are excluded, these patients are potentially candidates for surgery. However, those with untreated or uncontrolled cancer, locoregional recurrence, those medically unfit, or those with uncorrectable venous insufficiency should receive optimized non-surgical management only. And this is where judgment comes in. Prehabilitation is a really important part of getting consistency in outcomes, and this is an individualized, multidisciplinary, patient-centered approach, predominantly centered around the physical therapy requirements, and that's compliance with optimized, customized conservative therapy. Ideally, patients should have their weight managed preoperatively towards a stable normal weight, although in Texas that can be very challenging to achieve. And those with frequent episodes of infection can be managed by perioperative prophylactic antibiotics to provide a window in which to operate on them. And this is what complete decongestive therapy consists of. Initially, it's a reduction phase through specialized reduction garments or bandaging, and then transitioning to typically custom compression garments and a pneumatic compression device if necessary. It's important to have a decision algorithm for these patients, and it's really important to understand the pathophysiology of lymphedema. It starts a condition of lymphatic fluid stasis, and then through processes of inflammation and fibrosis and sclerosis, it becomes a condition of adipose soft tissue differentiation hypertrophy. And that's why initially these patients have pitting edema, and then the chronic lymphedema phenotype is that of a limb that cannot be reduced by maximal conservative therapy. And so from there, you can develop an evidence-based lymphedema treatment algorithm. Those patients with early-stage lymphedema that have linear obstructed lymphatic vessels are candidates for lymphovenous bypass. Those with advanced-stage lymphedema characterized by few lymphatic vessels are typically candidates for vascularized lymph node transplant, which brings in new lymphatic function, in concert with lymphovenous bypass, which we'll talk about a little bit later on. And those with advanced disease are treated initially by suction-assisted debulking, and then they are downstage where they can become candidates for a physiological procedure, and occasionally we have to perform direct excisional procedures. So with lymphovenous bypass, it's important to note this is a targeted procedure, so we only identify the obstructed lymphatic vessels. It's important not to bypass functioning lymphatic vessels, as patients can be made worse. And we bypass these close to the area of dermal backflow, just distal to these, where the lymphatic vessel characteristics are optimal. And it's important to have a decision algorithm for this, as it's important to maximize the flow gradient between the lymphatic vessel and the vein. And this will often necessitate a multi-barreled approach, or end-to-side bypass has particular utility in these patients. For vascularized lymph node transplant, it's important to note that there are many options available. And a center specializing in lymphedema should be able to offer the majority of these. And the reason being is that no one treatment is optimal. It's always a careful balance between the risks and benefits, the patient characteristics, the needs of the recipient site, and where patients have had previous surgeries. And so typically the algorithm actually is determined by what the needs of the recipient site are. So it's an aesthetic transplantation. Understanding that most patients will benefit from a radical scar release in the axilla, we're increasingly doing dual-level transplantation for these patients. Most of our patients present with post-mastectomy lymphedema, and so these patients are candidates for composite DIEP flap, breast reconstruction, and groin vascularized lymph node transplantation. And there are many algorithms for how this can be performed optimally without sacrificing the aesthetics of the DIEP flap. It's really essential that these patients do get reverse lymphatic mapping. We do this preoperatively using SPECT-CT. This gives a three-dimensional appreciation of the nodes draining the lower extremity. And then from there, we can develop three-dimensional models for intraoperative guidance. And this is because patients will commonly drain to these lymph nodes, and therefore they have to be avoided. The groin lymph node flap is treated like any lymph node flap. It has to be respected as a separate anatomical unit, and for that reason it has to be supercharged in the axilla to maintain perfusion and adequate drainage. We are increasingly using the ammental vascularized lymphatic flap, and we use this for patients who don't desire breast reconstruction or after breast conserving surgery. The real advantage of this is it can be harvested minimally invasively, laparoscopically, and it can be divided into multiple parts for dual level transfer. As a standard, we will combine our vascularized lymph node transplants with lymphovenous bypass wherever there are linear lymphatic vessels that are obstructed. And our group and other groups have shown that this does improve outcomes. When we looked at a study of 134 patients with prospectively collected data over a 24-month period, we found minimally clinically significant improvements in limb volume change and LDEX score in 90% of patients, in patient-reported quality of life in 95%, and reduction in infections in 98% of patients. Perhaps the most interesting part of vascularized lymph node transplant surgery. As I mentioned before, those with advanced fibroadipose disease, they require debulking, and this is performed by suction-assisted lipectomy, and a really vital component of this is the controlled compression therapy. And so as you can see here, this tissue is extremely fibrous and has to be removed by power-assisted liposuction. However, we can achieve, in the majority of patients, a complete reduction, which gives the patients an incredibly beneficial improvement in their quality of life and also reduces the incidence of infections. As long as compression is worn lifelong, patients won't get a recurrence of their swelling, as has been demonstrated by our colleague Hakan Bråsen. However, what we're increasingly doing is combining this surgery with physiological surgery, initially debulking the patients to downstage them, and then subsequently doing physiological surgery. This patient had a dual-level omentum and mesenteric vascularized lymph node transplant, and consequently had minimal requirements for compression therapy. And this is perhaps the most exciting current arena in lymphedema surgery. So with that, thank you, and I welcome any questions.
Thank you, Mark. I think we're going to collectively do questions at the end. Yeah. So.
We're going to move on here, and excited to have Dr. Peter Nelligan from the University of Washington to talk to us about assessment of the lymphedema patient, something he's published extensively on.
Good morning. I'm Peter Nelligan, and I'm so sorry not to be with you in person. As Fabio may have mentioned, I've had some health issues that prevented me from traveling today. I'm going to talk about the assessment of the lymphedema patient. My disclosures are book royalties from TEMA and from Elsevier, and as well I'm on the medical advisory board of Microsure, which is one of the microsurgical robotic companies. Now, assessment of the lymphedema patient is really important, and this applies to all lymphedema patients, regardless of whether they're breast-related or not. Clinical history is important to distinguish between primary and secondary lymphedema. We obviously want to know the duration of the disease. We want to know the history of cellulitis, because each episode of cellulitis causes further damage to the lymphatic system. We want to know the patient's treatment history and how they responded to that treatment. Whether they've had treatment with therapy, treatment they've had. And we want to, as I said, we want to know the response to this treatment. Physical examination is equally important. We want to look for pitting edema. Now, pitting edema can occur in other conditions, but it's very common in the early stages of lymphedema, and it's very helpful in assessing the patient. We want to look for trophic skin changes because this may impact any surgical procedure that we're going to undertake. We want to look for folds and festoons in the skin, because these may increase the risk of the patient in developing infection. And of course, we want to see if there's any evidence of active infection. We also want to measure the limb, and most people use limb circumference measurements, which are fine, but more accurate are volumetric measurements, and these can actually be calculated from the limb circumference measurements. Ken Bråsen has published on how to do this, and it's very, very useful because, as I said, volume is more accurate than limb circumference. There are other ways of measuring volume. The gold standard way is water displacement, but it's messy and most clinics don't have the availability for this. And the more modern way is using perometry. Now, perometer is a frame with light transmitters on two limbs and photosensors on the opposite limbs. And the limb to be measured is placed within the frame, and the frame is moved up and down the limb so that you get a digital assessment of volume. Another modality that is useful is bioimpedance spectroscopy. And bioimpedance spectroscopy is based on the premise that the amount of opposition to the flow of an electrical current, in other words, the impedance through the body, is inversely proportional to the volume of fluid in the tissue. And of course, in lymphedema, tissue impedance decreases because of the accumulation of fluid. But cost may be an issue for some clinics, and insurance coverage may be another impediment. Imaging is vital for the assessment of a lymphedema patient. And I should mention that none of these assessments by themselves are pathognomonic or useful by themselves, but together they give us an idea of what's going on with the patient and allow us to assess their disease. So the common imaging modalities that we use are lymphoscintigraphy, MRI, pre- and intraoperative fluorescent lymphangiography with indocyanine green, and more recently, ultra-high frequency ultrasound. Lymphoscintigraphy is good for diagnosing lymphedema, but it doesn't give you any details, I'll show you. Immoral lymphangiography does give you detail not only about the lymphatics, but about the limb in general. And fluorescent lymphangiography gives you superficial information, but information specific for the lymphatics and for the superficial lymphatics, whereas ultra-high frequency ultrasound gives you detailed information and is very useful, as I'll show you, for imaging lymphatics and veins. So these assessment modalities that we use are not individual. A group of us come together at regular intervals to come up with a consensus of how we should assess these patients. This is a photograph taken in Barcelona several years ago, where a group of us were discussing exactly this. So lymphoscintigraphy is based on the injection of the filtered sulfur colloid, technetium-99, gives you good information on lymph nodes, documents lymphedema, gives you good information on lymphatic function, and you can actually measure the transport index, or the time taken for the gadolinium or for the technetium to travel from the injection site to the regional lymph nodes. But it's not helpful to identify lymphatic channels. The images are fuzzy. It does have an application in inverse lymphatic mapping, which I don't have time to talk about today. MR lymphangiography gives you good and accurate information on the anatomy of the limb and information about the whole limb, not just about the lymphatics. It's a very useful tool in preoperative as well as postoperative assessment of lymphedema patients, and it gives important 3D information that ICG just doesn't deliver. In our practice, it's an indispensable complementary part of our armamentarium. And the way we do it is with using gadolinium to inject it into the web space of the hands or feet to image the lymphatic channels. And then a second dye, ferriheme, which is an iron pigment, is injected intravenously. And that essentially blocks out the venous signal so that you know that what you're looking at are lymphatic channels and not just blood vessels. And it can be very difficult to distinguish between those two. ICG is indispensable, and it involves the injection of small amounts into the web spaces with fluorescent light source to activate the fluorescence, or laser light source to activate the fluorescence, and then imaging with near infrared imaging. And Kushima and his group helped us to figure out what all of these patterns that we see with ICG are. The linear pattern we see in normal individuals, and then the splash pattern going on to the stardust pattern and the diffuse pattern. And these correspond with decreasing diameter of the lymphatic channels, as well as increasing sclerosis, which is going on, which is the reason for the decreased diameter. And this is what it looks like clinically. This is a normal lymphatic. This is an ectatic lymphatic that we see in early stage lymphedema. And then the lymphatics start to contract and ultimately sclerose. And this corresponds with the clinical stages of lymphedema that we see. So ICG is extremely useful. Now, ultrasound, whether it's conventional or ultra-high frequency, it's non-invasive and it images veins as well as lymphatics. And obviously, with ultra-high frequency ultrasound, you get more detail. And this is what it looks like. And I want you to look at the lymphatic channel down here. And what you see is that when you move the probe, the vein collapses, but the lymphatic channel doesn't collapse. And what that has allowed us to do, this is a paper from Aki Hayashi. And this is an area up near the groin of dermal backflow, which we normally wouldn't go near because it's hard to find lymphatic channels with ICG or any other imaging modality. But look what you can see with ultrasound. You can see a lymphatic and a vein. And this is the actual clinical case that Aki did, showing a branch of the vein, anastomosed end to side to the lymphatic. So ultra-high frequency ultrasound is really a game changer. So apart from preoperative imaging, as I've shown, you can also image intraoperatively. And with ICG, for example, you can map the lymphatics. This is a patient about to have an LVA operation. You can see we're mapping the lymphatics. These dark lines on top are veins crossing the lymphatics. And that gives you a roadmap of where to make your incisions and allows you to plan. So to summarize patient assessment, in my practice, all patients undergo full clinical examination and preoperative imaging, usually with MRL, though more recently with ultra-high frequency ultrasound. And that allows me to make a decision on a treatment approach. And then we use intraoperative imaging, if indicated, to map out the lymphatics. And all of this put together allows the potential for multiple surgical approaches. So thank you very much for your kind attention, and I hope to answer questions during the Q&A session. Thank you.
We'll take a few minutes here for questions.
Hi, Peter. This is Fabio. I'm not at the level to ask you anything because you did an excellent presentation, very instructive. I only have to learn from you, but I want to thank you very much for the effort you put to join us, although virtually, and with the discussion on question and answer. So thank you very much, and I hope to see you next year in Rome. I bet you will. Thank you.
And also Dr. Shavrin, as we skipped over the questions on his lecture. Just as it's relevant to the preoperative assessment, I know that one of the challenges surgeons face is insurance approval for these cases, both immediate prophylactic at the time of axillary lymph dissection and as well as therapeutic. Have you seen, or in terms of these preoperative imaging and assessments, is there anything that is needed for insurance approval, either private insurance or Medicare, or that's beneficial for achieving insurance approval in your experience?
Yeah, so this is obviously a uniquely, or predominantly a US problem. So there are, you okay?
Peter, can you hear us? Can we get Peter? Hello, Peter. Hello? Can you hear us?
Okay. I guess I'd maybe extend that question to Dr. Shavrin. obviously a problem predominantly in the United States, but it seems to be a significant issue for those who are in new areas trying to offer this to patients.
Yeah, it's still regarded as being experimental investigational by most payers. And however, there is increasing approval amongst payers, and I think that will kind of catch on as we collect better evidence, right? And so some of the recent publications have really moved the field forwards, and it is important that patients, do meet the traditional diagnoses of lymphedema. And so, it is necessary that they have a significant volume change that meets, pre-existing criteria for lymphedema and also LDEX. It's also important that they have maximized their, or at least are compliant with conservative therapy. As these are all things that insurers will review. And then also a part of this is using the appropriate CPT codes when you're, when you're pre-authorizing. But, we found really it's a minority of patients that, are getting challenged by payers. But with the quite large body of evidence that we have now, we can put together pretty convincing appeals for these patients, and patients that are truly being rejected are very few. So in answer to your question, I think it's important that patients are properly assessed and that they do meet the criteria for lymphedema, and that is all explicitly in the case notes, that they are engaged with physical therapy, and that because that seems to be what payers are looking for when they're adjudicating these cases. Hope that answers your question.
Yeah. Thank you.
So one remark from Europe, from the Netherlands, we've got the same problem. 2 years ago and 3 years ago, we had the problem that was not covered by the insurance company, or the AVAs, and also the lymph node transfers. And we tried to make it with some different operation codes, but now we have 2 centers in the Netherlands. One is in Nijmegen and one in my department, and the other one is in Maastricht. We've got 2 bigger randomized controlled trials. And we included there for the upper extremity 100 patients. And now we stopped with the trial, and the results will be there next year. And the second one, now we've got an approval also for the lower extremities. And due to the first study for us in our country, we are able to get from the insurance company that they are okay and fine with the. We can treat them, and we got covered by the insurance companies also.
Thank you. We are next joined by Dr. Suzanne Klimberg. We're honored to have you join us from UTMB. She is the chair in general surgery, as well as the professor and chief of the division of surgical oncology at UTMB. She's a pioneer in the field of axillary reverse mapping. So look forward to your sharing your experience with us.
It says danger. Okay. All right. Well, thank you. It's an honor to be here, and appreciate it. And I've enjoyed the lectures that I've heard. I don't really have any disclosures. And so there's lots of, as we know, non-controllable factors that cause lymphedema, including, in addition to these, we've published some medications that can actually increase the risk of lymphedema, like calcium channel blockers, for example. So we do have to look at all of that. But controlling weight and controlling hypertension, especially for lower limb lymphedema, is important. Okay, there we go. But what we can control as surgeons, of course, is surgery. And in the beginning, when we started thinking about this, I was a core trainer for the B-32, where we went around teaching sentinel lymph node across the United States and Puerto Rico. And what I noticed is that everybody the sentinel lymph node was prescribed very specifically, but then people would follow with an axillary node dissection, and everybody did it differently. It wasn't standardized, which explains here why not only people have varied the sentinel lymph node as well, from 0 to 13% lymphedema in these randomized studies. They cannot be doing the same procedure, and here 7 to 77% axillary node dissection lymphedema, they cannot be doing the same surgery. So we said we can try to figure out how to do better surgery. And so we came up with the idea, first published in 2007, about axillary reverse mapping, or the arm procedure. And it's basically mapping the lymphatics out of the arm, and it's basically dual mapping. So here you see the gamma probe on the sentinel lymph node, which is denoting what's coming from the breast. And here the final procedure is injecting blue dye in the upper intervolar surface of the arm, where most lymphatics go. Other lymphatics, as you know, go along the cephalic or up behind and or above the axillary vein or directly into the subclavian vein. There you can just see what we're doing. And you can see I'm going all the way across because you don't know exactly where they come in. Feldy, of course, is the father of lymphatics and lymphatic mapping, and he very carefully mapped all the lymphatics out of the upper extremity, and when he got to the axilla, he just called it axillary lymph nodes. He didn't map further. So the first thing we did is to map the lymphatics as they go through the axilla, and we put radioactivity in the breast and let it, split mapping, if you will, activity in the breast, let it show the sentinel lymph node and blue dye in the arm, and so that we could see where they came together, if they were together or they're completely separate. So split mapping, radioactivity in the breast, blue dye in the arm, and that's important because if you have N2 or 5 or more positive nodes, you can get back up into the arm. The lymphatics can back up in the arm. You need to know when that happens. And that's why it's important to know, is the blue node or blue lymph nodes coming from the arm, are they also sentinel lymph nodes? That happens about 4% of the time, so we really need to know that. So, you know, most of us were taught that the lymphatics run underneath the axillary vein, and if we stay a centimeter below, we won't get lymphedema. This is actually a very rare occurrence. I don't see it most of the time. And here's a large lymphatic trunk, 4 millimeters coming underneath the axillary vein. And then we described a sling pattern, which comes well below. And here you see the axillary vein, the extremities to the right, the breast is to the left. This is during axillary node dissection, but you see the vein where it is. And 4 centimeters below, you can see this huge blue lymphatic coming across. You take that and you're going to get lymphedema if you don't do something different. Head is to the left and the breast is up, arm is down. And here you see another blue lymph node sling, which I can lift up and perform the axillary node dissection underneath it, so you don't need to take it. So the idea is not to take it if at all possible and not to disturb it. We also described a apron-like pattern laterally and medially. And here is a lateral pattern. You can see that you can just lift that up out of the axilla. And then this came into a sling pattern as you come across there. And it's huge. There's a twine-like pattern that's really rare. And you can see multiple blue nodes here. I don't know if this works. Let's see. Oh, okay. Multiple lymphatics just coming through here and blue nodes throughout. And that's you can come underneath that and do your axillary node dissection. And this is also an uncommon one. And this is a chain of lymph nodes. It comes across one lymph node like a pearl necklace, one lymph node right after the other. And here you can see if I can do it. Here's a lymph node, here's a lymph node, here's a lymph node. Now, there was a blue node here that was also hot, so I took it and then reanastomosed these lymphatics. But this is just a chain coming across there. So it's a wonder we don't get more lymphedema with all these different variations than we do. So that's what makes this arm an important thing. So we published our 654 patients prospective trial, phase 2 in 2017. And basically our sentinel lymph node plus arm is less than 1% lymphedema. And this is with volume displacement. Axillary node dissection plus arm was 6%, 26-month follow-up. 29% of the time, if we just made a sentinel lymph node 2-centimeter incision, we could see blue node within the scar, meaning it's in harm's way. So very important to know. 8% of the time, the arm node was right next to the sentinel lymph node. In the original B32 trial that proved the value of sentinel lymph node, we were instructed to take the hot node plus nodes around it. So you can imagine, and indeed, I'm going to back up there just a second. There we go. And the lymphedema rate on the B32 was 8%. 4% of the time, the sentinel lymph node was also blue. And when the blue node was also hot due to radioactivity, it was positive, as you would think any sentinel lymph node would be, about 20% of the time. 4% of the lymph nodes, initially we took all the blue nodes if they were within the axillary node dissection, and 4% were positive, so very low, and all of those were N2 disease, 5 or more positive nodes. And in this prospective study, 1 out of 3 patients had radiation and/or chemotherapy. The local recurrence was less than 1% in each group. This is one of the first randomized trials, 127 patients, and it showed the same thing, about 30% lymphedema at 20 months and 6% if they added arm for an axillary node dissection. There's been 4 randomized multi-center trials now. They don't always do it with the split mapping, which you can't really tell that you've got a sentinel lymph node or not. So I think that's important to note when you're doing this, because you want to be sure and take the disease nodes. So what if you can't find an efferent lymphatic? Well, people are going to talk after me and have talked about lympha. And so you can put the lymphatics back together. And we did that in the initial study too. We added to that, if we just did a sentinel lymph node, we put the lymphatics of the sentinel lymph node back together. And I think that's important. And we initially were making anastomosis, and then we said, well, I think we can just tie them together because they can have lymphogenesis. And so we did a rat study, and we showed that, rats have 2 tail lymphatics. We cut one and put it back together with an absorbable suture, because they're too tiny to anastomose, I think. Not without a microscope, I guess. And we looked at lymphogenesis markers, and indeed they recanalized. And they recanalized in the rat model almost 90% by 6 to 9 weeks. And the only ones that didn't recanalize still had a stitch in place and hadn't reabsorbed. So I think it's important to note, if you can't make an anastomosis, then you should reapproximate the lymphatics. And when we did that, we just looked at that same study, that's within that same study I showed you, that the lymphedema rate, if we didn't reanastomosis, it wasn't 100%, but when we reanastomose, it was 0. Now, nothing's ever going to be 0, but it's low. And this is just simply what we're doing with the lymph nodes. This is a lymph node in the Babcock, and the Berlischer is showing the blue node. And here I'm just sweeping that away from it so I can put those back together. And here you can see we're just taking the fat out so you don't have something, in the axilla that's palpable, really. And this is just a reanastomosis, and you can see the blue lymph already reanastomosing. So that led to the 702 ARM trial by the Alliance Group. We recruited our final patient in nearly 600 patients in June. So our first data will be out next June, so just a little year away. Now, we did allow lympha on this, not prophylactically. We didn't want to cut any lymphatics, but we did prophylactically allow it on the study if the lymphatics were cut and they needed to put it back together. And that's just simply arm, no arm for the study. So thank you very much, and thanks to all those that helped put that trial together. Thank you.
to 4 minutes for questions. Dr. Clemens? You have
Dr. Klimberg, thank you so much for that presentation, as well as coming speak to a plastic surgery meeting. Your pioneering effort on this is large shoulders for which a lot of our work stands, and so thank you for that. It's been nice to see all of this data come together. An amazingly massive shift in the standard of care that we've seen in plastic surgery. For instance, 2 years ago, we did 20 prophylactic lymphovenous bypasses. This year, we're on track to do 300. It's really become a very fast standard of care that our breast surgeons are really expecting the plastic surgeons to participate in. While it's standard of care, or it's still questionable, we're still doing clinical trials on it, but really seems to be that way for axillary dissection. I know that you do this for sentinel lymph node biopsy. In 12 years, I haven't seen a lymphedema after just a sentinel lymph node biopsy. What do you see is the benefit for hooking that up? Should that be a standard of care?
Absolutely. I just showed you randomized trials on sentinel lymph node, and it's 1 to 13% in randomized trials. It's 8% on the B32. So it does happen because not everybody does it the same. So we should figure out what you're doing that doesn't cause lymphedema. And it hasn't been so quick. It took me 10 years to get this on clinical trial. And why do we have to have a national clinical trial? Because we have other trials, lots of trials. I've showed you my phase 2 data and 4 other randomized trials. I think there's another one just out too. It's not very quick that we change things. And so insurance is behind. Also, I published, somebody talked about the reverse mapping on the leg. We published that also at near the same time, and we called it the leg procedure, lower extremity glandography. So it's a nice algorithm so that patients can understand what you're talking about, because I think sentinel lymph node is the worst term in the world. Thank you so much. All right, thanks so much.
Yep, thank you. We'll move on here to our next speaker. Dr. Singhal is joining us from Beth Israel Deaconess Medical Center in Boston, and we'll be talking about prophylactic lymphovenous bypass, or lympha, which we were just hearing about. Thank you.
Good afternoon. My name is Dhruv Singhal. I'm a plastic surgeon at the Beth Israel Deaconess Medical Center, co-director of the Boston Lymphatic Center, and it's really my pleasure to speak to everyone this afternoon about immediate lymphatic reconstruction. Before I begin, I really want to express my gratitude to Dr. Clemens and Professor Pompeo for the invitation of speaking at the 8th International Breast Surgery Workshop and 4th World Consensus Conference on BIA-ALCL. One disclosure, I'm the founder of a non-for-profit that runs a symposium annually on the lymphatic system. While I make no money from this, I do work directly with industry to fund this. So, outline of my talk in the next 10 minutes, I'm going to give a little background on breast cancer-related lymphedema, talk about ILR, immediate lymphatic reconstruction, and then talk about really a research interest of mine that I think is going to become very clinically important in the future, and that is the role of lymphatic anatomy and potentially preventing lymphedema. And then I'll make some concluding remarks. So for background, there's 3.8 million breast cancer survivors in the US, and 1 in 5 will go on to develop lymphedema. And while lymph node transplant, LV bypass, and debulking do a lot to improve a patient's quality of life, I don't know a single lymphatic surgeon that walks around and says they can reliably and reproducibly cure lymphedema. In 2022, there is still no cure for this disease. So if we know that this is a progressive disease, why not consider prevention? So that's the background leading into ILR. And so I'd like to talk a little bit about the modern history. And the modern history begins, and this talk is going to be focused on breast cancer-related lymphedema. The modern history really begins with Dr. Klimberg, a breast surgeon who you're going to be hearing from in just a few minutes. She's an incredible individual and human being. And she came up with this concept of axillary reverse mapping. She identified axillary lymph node dissection as the #1 risk factor for BCRL. And so she said, well, why don't we inject blue dye into the ipsilateral arm before the axillary lymph node dissection and then leave the blue lymph nodes behind because they're draining the arm and not the breast. And she was right. By doing that, lymphedema rates plummeted, but the problem is there's some crosstalk between arm lymphatics and breast lymphatics. So some of those blue lymph nodes could harbor metastatic breast cancer. So the safety of arm and other techniques is currently being studied in a multi-center trial, and I know Dr. Klimberg will be speaking more about that. But to carry on with her story, when she first introduced this concept in 2007, in 2009, lymphatic surgeons in Italy, Dr. Riccardo, Dr. Capisi, said, let's take this idea one step further. Let's go ahead and remove that blue lymph node, and then we'll take the blue arm lymphatics that were going into the lymph node, and we're going to bypass them into a vein. And by doing so, they showed with 4-year follow-up, the rates of lymphedema were down to 4%. Now, this is against historical controls, where the rate really should be somewhere in the 25 to 33% range. So this was a significant reduction. And that's a brief modern history of LR. And I want to talk about our experience. We published our early experience in 2021 in PRS. And I just want to show this quick video. This is where we're injecting fluorescein in the upper arm before we start. And here we're looking in the axilla. Here are your level 1 lymph nodes, your arms over here, your head's over here. And now we turn on the filter, and here you can actually see the arm lymphatics glowing green right into the lymph nodes. Now the lymph nodes are removed. We come back in with our microscope, and here you go. You can see where the arm lymphatics have been divided. You can actually see arm lymph spilling right into the wound bed. And now what you're going to see is we isolate these lymphatics. They're anywhere between 0.2 to 0.8 millimeters in diameter. And actually what we do is we take them and we just intercept them right into this vein. As you can see here, this vein is draining to the axillary vein. This is a temporary stitch. We'll take it out later. And what we first do is we secure the vein to the perilymphatic tissue. We remove that stitch. You can now see the dye going up to our clamp. We remove the clamp, put in a tissue expander in this patient, and 1 hour later, we're looking down, and you'll see we'll turn on our filter, and the entire vein is now full of arm lymph draining to the axillary vein. So this was what we published back in 2021, where we showed our earlier experience, where we had a rate of 3.1% of lymphedema, and this was an average follow-up of 11.4 months. This was recently accepted into PRS, and this is our 4-year institutional experience, where we had 136 patients eligible. We're only reporting on 90 because we wanted a minimum of 6 months follow-up, and they had to have actually completed ILR, not just taken to the OR for ILR. But what I want you to really note here in our 90 group right here is the majority of patients got adjuvant radiotherapy, and they got true axillary lymph node dissection with about 14 lymph nodes removed. So their baseline rate really should be in that 25 to 36%. This is a figure showing all 90 patients, and every clear circle represents a visit in our clinic where they did not meet the criteria for lymphedema, and every dark circle represents where they did meet the criteria for lymphedema. So with an average follow-up of 17 months, the lymphedema rate is 9%. So that is our experience with ILR. And what I'd like to do now is talk briefly about lymphatic anatomy, which I really think is the future of prevention. And briefly, when you look at what are the risk factors for developing lymphedema, we know what they are. Axillary lymph node dissection, regional lymph node radiation, and an elevated BMI. But what's striking to me is that if you take a woman with all 3 of those risk factors, if you take 100 women with all 3 of those risk factors, only 1 in 3 will go on to develop lymphedema. So why are the other 2 not getting lymphedema? And this is a really important question, because I think this is a complete paradigm shift potentially in cancer care. Imagine a breast tumor board sitting down, reviewing a case, and a lymphatic specialist is sitting there saying, look, I want you to know based on this patient's lymphatic anatomy, let's say, her risk of getting lymphedema is 100% if you do an axillary node dissection. well, they may consider other approaches for her. So if you go into the literature and you see, well, why is it that certain women are getting this and other women are not after breast cancer treatment? There are two theories. One is genetics. That is, that all lymphedema is primary lymphedema. It exists, but patients have it subclinically, and then they get cancer, and their cancer treatment spills them over into clinical lymphedema. And the other theory is it's anatomy. There's anatomic variations. When I started really diving into this, I was very much in the anatomy camp, 100%. I actually believe at the end of the day, like many things in life, it's going to be a mix. But I do think anatomy is driving this. Look at this panel. This is from the original 1874 textbook by Sappi. And you can see where all these arm lymphatics are going right here into the axilla. But look right here. Here's a lymphatic backup channel avoiding the axilla. This is called the Mastagni-Sappi pathway. We call it the lateral upper arm pathway, but it's a backup pathway where the lymph can get out of the arm even if the axillary lymph node dissection occurs. So we became very interested in this pathway years ago. And we knew based on anatomic work done in the 1800s that this pathway existed very close to the cephalic vein. So we started injecting indocyanine green into the skin right over the cephalic vein. And as you can see in this image, this Sappi pathway traveled right alongside the cephalic vein. And this is a beautiful dissection done by Hiro Suwami at our Boston Lymphatic Symposium in 2018, where you can see all the arm lymphatics going to the axilla. Here it is. Here's the backup pathway. Here's a close-up of it. And here's ICT imaging from our own clinic, where we can show you right there in the outpatient setting. Here's the main pathway. Here's the backup pathway. And what we found, and what we were able to show in vivo, is something that was described in the 1900s by Cubic, where another anatomist, that there are two different ways that this pathway exists. It exists as a long bundle, and it exists as a short bundle, meaning this pathway can sometimes connect to the forearm, which I think is a good thing, because now the entire arm can drain via this pathway if you take out the main pathway, for example, after an axillary node dissection. But then there's this short bundle scenario where the pathway only exists in the upper arm. And so you can imagine if you take out the main pathways, now you have a problem. Now you have a watershed area that you have to overcome to get adequate drainage out of the arm. What we found in looking at 60 consecutive patients pre-op before they had any treatment, we noticed that about 2/3 had a long bundle or favorable scenario, 1/3 had the short bundle, unfavorable scenario, and a very small percentage had no bundle at all. And all I want to show you here is that even though the short bundle only made up 1/3 of the cohort, when we looked at who had any kind of concerning symptoms post-op, I can't say it was lymphedema, but let's just say they had an elevated LDAX or elevated volume, we noticed that 2/3 of them had the short bundle. So this led, and further research ultimately led to an RL1 from the NHLBI, where we are further characterizing the Sappi pathway, as well as looking at lymphatic function in a swine model, and also a U54 we recently got a few weeks ago from the NIH, NHLBI, where here at the Boston Lymphatic Center, we're going to be leading an effort to map the entire human lymphatic system. So with that, and in conclusion, I really believe ILR reduces lymphedema incidence, and I do think lymphatic anatomy study is going to be critical for the future of lymphedema prevention. I want to thank everyone here at the Boston Lymphatic Center, our research team, really an incredible job, amazing collaborators here in Boston and around the country. We do have a lymphatic surgery clinical fellowship. We are about to close applications for July 2023, but it's a rolling, and if anybody's interested in July 2024, please feel free to reach out to us, and we welcome you all to our symposium. Our next clinical program will be in 2023. Thank you again for the opportunity to speak in this forum.
Thank you, Drew. That was a great presentation as always. Any questions from the audience? Dr. Chang?
Hey, Drew, it's Angela Chang. So I'm
Hey, how are
curious, with this new kind of mapping technique of short bundles and long bundles, and potentially being able to predict who's actually at highest risk for having lymphedema. Would you see a subset of patients that you would say, okay, we don't need to do, ILR and they'll be fine? Because I think the concern is currently doing lympha for everybody, you're going to be treating some people who don't need it.
Angela, great question. And yeah, that's the ultimate goal here. It's a little simplified. I don't think it's just the MS pathway. As we've started enrolling volunteers into the R01 and we are starting to map them and inject them with technetium, I think other pathways are going to come into play. It's going to ultimately be a combination of pathways. For example, the tricipital pathway, MS pathway, and we're identifying potentially another deep pathway that might play a role in this. But ultimately, you're right. The goal is to identify who's at highest risk and then, not offer them ILR if we don't need to do it. It's funny, I heard earlier in the Q&A questions about coverage, right? And when we've gone to insurance companies, we've been successful actually for getting coverage for treatment, but on prevention, that's the argument we get back. They're saying we're operating on 3 to 4 patients. We don't need to be, 3 out of 4, we don't need to be operating on. It's a valid argument, but in plastic surgery, it's spare parts. We're just putting it together. So I would still do it on my own family member, given the data we have today.
About that before.
Thanks for the question.
I've not been able to get it covered by insurance, and that's been a problem. Last question, have you been seeing symmetry in right versus left, or are they independent?
I'm only laughing because that's the first paper we're going to write out of the R01. We are not seeing symmetry, but we felt it's a very controversial topic, and it was the first question we thought we could answer very quickly. So thanks, Ian. That's a great question.
Just looking at, we're doing more and more lympha. What do you do with regards to these patients that may require a future latissimus dorsi flap? Having to operate back in that area, do you worry about disrupting the lymphatics that you hooked up with in the original surgery? Does it change your algorithm with regards to what we've traditionally used as lifeboats in plastic surgery?
Thanks for that question. When I started doing this, I never would use the thoracodorsal vein. I will say there was a short period of time where, I had nothing in the axilla and our data was coming out so strong in favor of it. I took the thoracodorsal vein, but that was just a short period of time. I don't do that at all because you're right. We need to save the lat ultimately as a lifeboat. And I have, after ILR, gone back, taken the lat, and it really does not disrupt what you've done up in the axilla. There's ways to do this. You just limit your dissection going up and maybe just place your skin pad a little lower, and you can get the swing and reach you need, in my experience. But thanks for that question. Just never use the thoracodorsal vein. And I guess the only other thing is, so about a year and a half ago, we started routinely taking vein grafts. And that's really given us just the flexibility to go anywhere and get it. Because that was the main reason we were aborting, was we didn't have enough venous length, vein length off the, usually the accessory vein. Thanks.
Hey, Drew, this is Suzanne. Thank you for that lecture. I just wanted to caution people, you don't want to cut an intact blue lymphatic, and I don't think that's what you're doing. You want to leave 70 to 80%. You do not need to do any other procedure or a lympha procedure. Now, that doesn't really work out well if it's not like you can plan to be all day in the or a couple hours in the operating room doing a lympha procedure or whatever it takes you, and then you don't do one. So how do you work that in terms of somebody doing an axillary node dissection or sentinel lymph node, and you're doing a lympha procedure or not? How do you work the logistics of that?
Great, I've done it in 2 different ways. When I was at the University of Florida working with Lisa Spiegel and Anna Shaw, they would convert sentinel node to axillary node dissection on the table. And just to be clear, I don't perform any kind of lymphatic reconstruction for sentinel node biopsies. So I'm only doing this for axillary lymph node dissection patients, and I always find lymphatics. that are divided, draining the hand and forearm. I've also modified my injection so I can identify which lymphatics are draining the distal arm, which is what I'm most concerned about. So to go over the logistics of it, when I was at the University of Florida, I would just be waiting. And if they converted, they would identify the high-risk patients. If they converted sentinel node to axillary node dissection, then I would come in. Otherwise, I would not. Here, we've just made it across the board. Everything's done delayed. So sentinel node biopsies are done, the patient's closed, and we wait for the results. And that's also allowed us to expand the program. So regionally, we now offer it for patients in Maine, Western Mass. They'll come down after their sentinel node biopsies if they're node positive, and they need a full clearance. So logistically, it's now made it 100% for me. I know when I'm operating and when I'm not needed. Thanks for the question.
Of lymphedema progresses increasingly, the management of breast cancer-related lymphedema and breast reconstruction is being recognized as a important direction for the future. So we're very excited to have Professor Demiri Dionysiou from Greece, from the Aristotle University of Thessaloniki, joining us to talk on this very topic.
Dear Chairman, dear colleagues, thanks the organizing committee, Dr. Santanelli and Dr. Clemens for the invitation. The incidence of lymphedema in breast cancer patients varies, but the last studies in 2019 so that in a population of 486 patients, within 3 years, 37.8% of those patients that had lymph node dissection and radiotherapy, they developed lymphedema. So the incidence is not so low as some studies used to say. And we do have requirements for undergo for reconstruction of both breast and lymphedema many times. There is more than a decade now we have published a lot in plastic surgery regarding this field. And the options we have is mainly the free chimeric combined DIEP flap with a LNT flap. And also we have published that we can use the latissimus dorsi with a pedicle, lateral thoracic, or a free inguinal lymph node transfer. As in many hospitals, we do have our algorithm. This is the algorithm we use in Thessaloniki, and it is divided in two planes, in the partial mastectomy patients and how we are going to reconstruct them, and in total mastectomy patients. And then we have here the DIEP patients with the LNT flaps, and also we have the fat-augmented latissimus dorsi with either local or free lymph node flap. And when we assess the patients, then we discuss with the patients about how we are going to proceed in breast and lymphedema reconstruction, discussing the options we have with Autologous, and also in those patients they are deciding to go for a DIEP flap, we ask them to do a CT abdominal wall, and then assess for the lymphedema with all the management, as I'm going to discuss later. According to the findings of the CTA, we can select the best perforator that can fit the abdominal wall, and also we use the information how to design a pre-abdominal flap, so to reduce the time and make better asymmetrical results. And also, we are going to discuss about thalassa, and I'm going to explain you what thalassa is in a while. So the findings of the CTA, the best perforators give us information about the size, the location, and the intramuscular course and the cutaneous branch that is well published before. And second, the information we use is how to pre-design our abdominal flap. And this is published, the modification of John Burman in 2014 PRS, said that taking information about the contralateral breast, the healthy breast, how can measure it and how can make a template, bringing to the abdominal wall, and that can save us time and having an aesthetical pleasant breast, and even we can tailor the breast on the patient's abdomen, and even we can do, as you can see here, the nipple at the same time. And the design can give us information and give us good symmetry with in a breast size, in a small breast, in a larger breast. Even if it is ptotic, again, we can have a good symmetry. And also in a bigger breast, in C-cup breast, or even bigger breast that patients don't desire to have any symmetrization to the contralateral breast. So what about thalassa? What about the lymphedema treatment? Thalassa means sea in Greek. And sea because sea is everywhere around surrounding Greece. And we all know that we do our holidays, we enjoy with the sea. So we thought about using the word thalassa as an acronym for the lymphedema treatment. And you may know thalassa from the word thalassotherapy, which is a kind of psychological support in our holidays. And even as a youngest, we enjoy and we can dream with the thalassa. Or even as a big boy, we can again enjoy the thalassa, the sea. So what means thalassa is an acronym from Thessaloniki, our town, algorithm for lymphatic analysis, safe surgical approach. What does that mean? That when we see a patient, we have to do a diagnosis using the history and clinical examination, thorough clinical examination, and use as much as information we can have. And then we can ask the patient for the diagnosis. And I mean, that was, as Mark Saverian and Peter Nelligan said before, we have too many tools how to do the diagnosis. But we're concentrating mainly on the SPECT-CT, lymphoscintigraphy, ICG, and MRL in our department. But also, we have to check the donor site. And we check the donor site with a SPECT-CT, not only with ICG. So we need to have more information and also to compare the donor areas of the inguinal flap. And the SPECT-CT is actually an amalgamation of two countries of lymphoscintigraphy and CT in one examination. It gives us information about the accurate anatomical and functional information of the lymph nodes we are going to select for a lymph node flap. We can select it preoperatively and then can give us information how to avoid to do a donor site lymphedema. In a coronal and in transverse view, we can select where is the most functional lymph nodes, as here, for example, and then we know that is in a transverse also area. It is above the fascia, and we can see in a sagittal again the safety of the flap. And then we do the measurements from the pubic symphysis. We go above, and then from the midline, and then we know where exactly we're going to select, and we're going to harvest the flap. We transfer all these measurements of the patient's abdomen, and then we elevate exactly the flap without to jeopardize any other lymph nodes of the area. Normally, we take 2 to 4 lymph nodes, as we have seen with an ultrasound from the groin, and we always complete an axillary scar release before to do the implantation of the lymph node flaps. And we do 2 anastomosis when we do with a DIEP flap, which is a combined flap. And always we measure the patients and we stage the patients, and also we measure the difference volume between the 2 arms. We test the pain, we ask them about the pain, and we, in a VAS scale, also we characterize the feeling of heaviness, the pain, the infection episodes per year, and they answer a quality of life questionnaires. We do the SPECT-CT and the CTA, and then we transfer everything to the patient's abdomen. And these are the post-operative results. As we can see, again, we measure the follow-up of the patients and the results. And again, this is another patient with a combined 2 flaps. That was the selected of the lymph nodes, and then everything was transferred to the patient's abdomen. The lymph node flap is going to go on the axilla, so we have to reverse 180 degrees all this flap, and this is the result, quite satisfactory symmetry of the patients and reduce of the volume of the lymphedema, as we can see, the pre and post-operative up to 5 years in this patient. So how to plan this flap? The most important is to consider the site of the mastectomy and the location of the dominant DIEP, artery and vein, and the selected lymph nodes. So in cases that the lymph node flap and the deep artery and veins are ipsilateral to the mastectomy sites, then everything is going to move upwards. And then we have enough length to connect all the subcutaneous bridge with the lymph node to the axilla. In cases that the lymph node flap is ipsilateral to the mastectomy, but the deep artery is contralateral to that, again, we have to move upwards everything, but we need to have enough length of the connecting subcutaneous bridge again. And in those cases that the lymph node flap is in the contralateral side from the mastectomy and the deep flap are either contralateral or ipsilateral, then everything is going to rotate 180 degrees, but we design the whole flap oppositely again. And then, as in a conclusion, all of these messages, we have to move everything upwards when the lymph node flap is in ipsilateral, or we have to do it contralateral if it is the flap is going to be rotated. And we leave a small subcutaneous fat at the superior abdominal flap just to fill the defect from the harvested lymph node flap from the groin. In a small study we have done, and that was presented in Europe back a few years ago, some of the patients that they had this flap, they were tested, and we saw that the 77% of the patients they had functional lymph nodes, other they had positive reduction of the dermal flow of the arm. So the advantages of these techniques is that we use the preoperative planning of the whole procedure. We can have accurate information of the location and the function of the lymph nodes. We have a reduced operating time because everything was pre-planned and optimizing both aesthetic and functional outcomes while minimizing complications at the donor site lymphedema. And one of the important messages are that maximizing the outcomes while minimizing complications is still dependent on the appropriate planning and preparation skill and training and meticulous techniques and experience. And of course, unfortunately, it's not everything ideal. We do have complications. This is one of those cases. This is a patient who required both bilateral breast mastectomy. In those cases, we don't need this plan because it's a bilateral. We're not going to symmetrize something with the other side. So this patient was designed to have a hemidieps and one of the two dieps to have the lymph node flap. Unfortunately, she had a complication the next day, so I went to the OR. We couldn't salvage the flap for 3 days after that one, and then the 4th day we went back in OR, and both flaps were a disaster. And also the patient had a complication of the abdominal wound opening and also pressure ulcer at the head, just because she had a huge coagulopathy, which we didn't test before. So thank you so much, and I'm happy to answer any questions.
Thank you for a great presentation. Still, we don't have large cohorts to evaluate if it's oncologically safe to put the lymph nodes back when you've been radiated and empty axilla. 2 weeks ago, I had a patient when we cleared the axilla. We had a lump. We sent it preoperatively. It was cancer. So I just chopped the lymph nodes off and did a regular DIEP after consulting the breast oncology surgeon. And that's the second time this happened. We did a pre-op workup with mammography and a CT. But, I mean, still, you should be secure about the oncological safety. How was your pre-op workup?
Thanks for the question. I mean, it's quite important. All cases were secondary cases. So we have a period of some years before to do the procedure, either breast reconstruction or lymph node transfer. So we always sit after the oncologist and we ask if we are able to do the procedure, and we do the MRI examination at least and before to do the procedure. And we know that at least 3 years they were free of any symptoms before to go, recurrence before to go for lymphedema reconstruction.
Yeah, these were all secondary cases, but several years after the actual cancer. But there's a big lump, a big chunk of scar that you're going to take away, and sometimes it's impossible to know what's in there, and you know, it's a quiescent state of the tumor that you may be activating. Just, you know, asking this question honestly, if it's safe and what we should, you know, think of doing this procedure.
Yeah, I mean, I agree. Some of the discussions we have with oncologists that if there is a recurrence, it's not just local, it's generalized, so chemotherapy is going to work anyway. I don't know if that, I mean, bringing lymph node, bringing more tissue that is growth factors and reactivate any cancer locally can be worse in a generalized oncological safety. I mean, and also we have too many publications since the last decade for lymph node transfer in the axilla, even more years now. They don't raise that much this issue.
Just a quick comment or question in terms of your recipient in the axilla. I think you mentioned lateral thoracic. Is that in all cases, or do you find that absent or insufficient sometimes? Do you use thoracodorsal, serratus branch? What's your breakdown?
I mean, as Drew said before, we try to avoid the thoracodorsal just in case we're going to need it for, as a lifeboat, the LD flap. Lateral thoracic are always just front of us, and we use them the most of the times, or the other branches from the area. I mean, when you clean the axilla then we can mention, you can find some of the small arteries and you can use them to hook the small flap. It's a small flap, and I mean the vessels are quite tiny. And most of the times they are less than 1 millimeter size, so you can find even any branch and you can do it there.
Thanks.
All right. Thank you.
Thank you. And we'll finish here with our final speaker of the session. We're fortunate to have Dr. Mingwei Chang from Changgung Memorial, like many of all of our speakers, a giant in the field of lymphatic surgery. And he'll be speaking to us about approach and outcomes for vascularized lymph node transplant.
Good afternoon. This is Mingwei Chang. It's my great honor to present my experience at International Breast Surgery Workshop and the fourth consensus conference on BIA-ALCL. This is my disclosure. The indications for vascularized lymph node transfer include chest lymphedema grade 2 to 4, total obstruction on lymphocytography, no pattern lymphatic ducts on ICG lymphography, repeat episodes of cellulitis fail to rehabilitation. Contraindication include recurrence and metastasis. This is an example of total obstruction on Taiwan lymphocytography staging T5. As you can see, no axial lymph node present and dermatoperipheral in the entire upper limb. We also use our custom-made ICG device to detect the lymphatic duct. As you can see, no pattern lymphatic duct available in this patient. So this patient is as indicated for vascularized lymph node transplant. Since 2000, we use vascularized growing lymph node transfer for grade 4 lymphedema. As you can see in this patient, the recipient vessel was cephalic vein and radial artery dorsal branch. Here is a picture of post of 4 months and post of 4 years. The reduction rate at about elbow was 60%. At 11 years of follow-up, the reduction rate reached to 70% without compression garment. Another grade 2 lymphedema underwent vascularized growing lymph node transfer to elbow. At 2 years of follow-up, the reduction rate reached 80% above elbow, 56% below elbow without compression garment. We were looking around the new vascularized lymph node basin. We did this cadaver dissection at Duke with Dr. Zen and UT Southwestern with Dr. Sincere. As you can see, the submental artery nourishes a group of the lymph node, and also with the injectional lattice to have the territory of the submental artery with a group of the lymph node included. This cartoon summary the group 1A and 1B submental lymph node around the submandibular area. Since 2012, we use a vascularized submental lymph node transfer for breast cancer-related lymphedema, such as this case using volar form as the recipient site, hook the ulnar artery and the cephalic vein. It's a pre-op, post 3 months, the reduction rate reached 8% above elbow, 14% below elbow. At 33 months of follow-up, the reduction rate reached 95% above elbow, 80% below elbow without compression garment. Another case, pre-op, post 3 months, post 13 months, the skin pattern was incised to achieve better cosmesis. Post 48 months, the reduction rate reached 90% above elbow, 95% below elbow. The donor size scar was inconspicuous with minimal communication. This algorithm summary the treatment of breast cancer-related lymphedema. We prescribe TC99 lymphocytography and ICG lymphography and staging the partial obstruction and total obstruction and choose the appropriate procedure, either LOVA or vascular lymph node transfer. And we consider more functional recovery, we like to transfer dorsal wrist as the recipient site. At 1 year of follow-up, we do a flap revision for better cosmesis. How about the mechanism of vascularized lymph node transplant? This cartoon helps you to understand we transfer the lymph node to the distal recipient site who got artery in the vein, and the lymph node start to absorb the lymph drainage to the vein, followed by catchment effect and gravity effect. This is a flap transfer to the recipient site. We inject the ICG at the flap edge. At 6 minutes post the ICG injection, you can see the pedicle vein got fluorescent. This is a strong evidence to show the vascular lymph node can drain into the lymph with the ICG into the pedicle vein. We further inject the lymph node being transferred to the recipient site directly, and after 23 seconds, you can see the pedicle vein got fluorescence. This is showing the direct connection between the lymphatic system and venous system inside the transfer lymph node. We further did this study when we dissect the pedicle of the vascular submental lymph node flap with the pedicle still in continuity. We were able to collect some lymph from the recipient site preparation and put into a flask and mix it with the ICG. Then I press the flask below the level of the submental lymph node flap. Then we immerse the submental lymph node flap to the flask inside the lymph. Then to see if the lymph node can absorb the lymph directly. So after 10 minutes and 14 seconds, we observe the pedicle vein got fluorescent. So this is the right evidence showing the vascular lymph node can absorb the lymph with the ICG drainage into the pedicle vein. Outcomes of the vascular lymph node transfer. When we compare the circumferential difference versus the lymph-specific quality of life in upper extremity lymphedema post lymph node transfer, At 12 months of follow-up, the circumferential difference improved from 16% to 6.7%. The overall quality of life improved from 2.2 to 7.4 at 12 months of follow-up. Also for the low extremity, I have a similar result of the improvement of circumferential difference and the overall quality of life. We also compare the surgical versus non-surgical group for upper extremity, unilateral extremity lymphedema. We have 142 underwent surgical procedures, including LOVA and lymph node transfer, and non-surgical group has 93 patients. At 28 months of follow-up, the surgical group improved the circumferential difference from 24% to 15%. The non-surgical group even got worse of the circumference difference from 29% to 31%. Also, the episode cellulitis was improved in the surgical group from 2.1 times per year to 0.8 times per year. For the non-surgical group, the episodes of cellulitis even got worse from 2.5 times per year to 3.5 times per year. In conclusion, we report the first study of vascularized growing lymph node transfer to the wrist with a reliable functional recovery for upper extremity lymphedema. We invent the vascularized submental lymph node transfer for upper and lower limb lymphedema. We propose the pump mechanism of vascular lymph node transfer for the drainage of the lymph, and we prove lymph was drained from transfer lymph node to the venous system. We found the longer follow-up, the better functional recovery and the quality of life post-vascular lymph node transfer. And surgical group have statistically significant improvement in circumferential difference and the episode of cellulitis than non-surgical group in unilateral extremity lymphedema. Thank you for your attention. Stop.
Okay, I think that brings our session to a conclusion at this point. We're followed by coffee break at this point, yes? Thank you, everyone, and thank you to all of our panelists.
You're the first to present? No? Let's see. The laser, I don't know. You're the first, okay. So I don't know the laser because, yes. Because when I presented, I didn't know.
Good to see you. Hi, I'm Alex Richley. Hi, nice to meet you.
Nice to meet you too. Nice to meet you too. So we are together?
Yes.
Ah, great.
So how do you advance? This is the advance button?
Yes, exactly. So this is the laser perhaps?
Okay, laser point.
No?
No, this is the laser. Sorry, I'm hitching the app. All right, there's the laser. This is forward and this is backwards.
Yeah.
Yeah, I'm going to be, well, we've already discussed it. Angela's the good cop.
Oh, I'm good, Kat? Oh, okay, I'm the angel?
Yeah, you're the good cop.
You're the boss.
I'm fully capable of switching it. Just like that. Ask the residents.
I very much enjoyed your talk.
Oh, thank you. Same here. So you're in Greece?
Yes, I'm in Greece.
It's a country is high on my bucket list, but I haven't been able to make it there, especially with the economy was so crazy and then COVID.
No, it's much better. And tourism this year was crazy.
Oh, I keep seeing people posting pictures of, is it Mykonos? And,
Mykonos is very famous,
yes.
but all the islands are very, very nice. Santorini and all, everything. Yes. So it is a little bit more aesthetic now. There is still reconstructive papers.
Yeah, this
it's
is
not
like the
only,
last,
yes,
this is
it's
the
not,
last
yeah.
It's like a mishmash of
Yes, of both aesthetic and reconstruction.
Yes, it's like all the odds and ends of
yes,
the odds and ends section. Yes.
So we have all the presentations.
Okay.
You can follow the schedule, so we don't have any mix-ups. We have 11 minutes talk, followed by 4 minutes of discussion. You're going to see this timer here, and then when the discussion starts, it will be 4 minutes there. Okay, so you just have to follow the timer.
And all of our speakers are in person, correct?
Yes. No virtual, no Zoom, which makes things easier.
Oh,
We have to be very strict with timing because the dinner tonight is early.
Just a reminder, when is the shuttle picking up? So I think we can make that announcement.
Say 6:45.
6:45 at the front.
Yes, but I will give you. You have 2 shuttles, so I will give you the exact times during the.
Yeah. Well, just to say, every question you ask places you further away from food.
And if someone asks you questions, no food.
Yeah. No drink. All right. Okay. Well, I guess we'll get this session started. Thanks to everybody who's stuck around. I know we're the last session before dinner, so we're going to try and stay on time. This is kind of the odds and ends, bits and pieces of the last bits of breast reconstruction. So our first speaker, we have Mark Venturi from the INOVA system at VCU, and she's making almost everybody a candidate for nipple-sparing mastectomy and reconstruction. Can't wait.
Thank you. So first, I'd like to thank our program organizers, Drs. Clemens and Santanelli, for putting together this insightful and comprehensive program, and special thanks for including me in it. So I did take a little bit of poetic license with the title. It occurred to me that everybody can't be a candidate for nipple-sparing mastectomy because what if the nipple's involved with the DCIS or the cancer? So I used a little bit of poetic license and changed it to almost everybody. It's not advancing the controller. Is it on?
It's just hard. Yeah,
Okay,
click it hard.
maybe I'm just weak. I apologize. So first, my disclosures. It's really hard to argue against the aesthetic superiority of nipple-sparing mastectomy in breast reconstruction. I hearken back to when I was a fellow at MD Anderson in 2007, and nobody was doing nipple-sparing mastectomies. when I came out into practice, I found myself in a very similar situation, and I can honestly say I was never satisfied with a skin-sparing mastectomy. The deeps turned out a little better, but there was still something missing. There was still that skin patch or visible scar or asymmetry in the nipple that just detracted from the result. All that changed for me with nipple-sparing mastectomy. For the first time ever, I felt like I could potentially reconstruct a breast that arguably looked better than the one the patient started with. Believe it or not, the person in the United States who deserves a lot of credit for the popularization of nipple-sparing mastectomy is Angelina Jolie. In 2013, she wrote an op-ed piece in the New York Times where she documented her journey as a BRCA patient through breast reconstruction, and she commented on nipple-sparing mastectomy and said the results can be beautiful. This got the attention of a lot of patients who came to accept nipple-sparing mastectomy as a good option for breast reconstruction. The safety of nipple-sparing mastectomy has been studied and published on ad nauseum. This is just one article from the American College of Breast Surgeons showing that there really is no increase in recurrence and no decrease in survival with nipple-sparing mastectomy. So if we can agree that nipple-sparing mastectomies offer the best aesthetic results for our patients, the next logical question is, all right, so then how do we offer this to almost everyone? So large ptotic patients pose a significant challenge for nipple-sparing mastectomy. There really are three good options for these patients. Number one, you could do the reduction or mastopexy first. Number two, you could do an oncoplasty and reduction first, which is really the same thing, just in the presence of cancer. Or three, what I'm going to talk about today, which is an extended IMF flap with nipple preservation and perfusion imaging. This algorithm is from our practice. I'm really just going to focus on the right side of the algorithm. So these are patients who have multifocal disease, extensive DCIS, people who can't do an oncoplasty first, people who have to have a mastectomy for their treatment. A patient like this, I would usually never have considered for a nipple-sparing mastectomy. The degree of ptosis, the volume of the breast, make her not a good candidate for these procedures. But that was before I started doing the extended base IMF flap with nipple preservation. And this is not a new idea. This is basically an extension of the Botswick flap that includes the nipple areolar complex and uses perfusion imaging to show viability. But it is not a new idea, it is not a new concept. So here are the intraoperative markings. You can see we make the base as wide as humanly possible to take up almost the entire inframammary fold. And we don't go much beyond the nipple because you don't need to, but you want to go above the areola to just the crest of it so that you get as much blood supply as you can. We resize the nipple areolar complex first. This is important because after you lift that flap, it's actually really hard to get a good circle. So the first move we do is we resize the nipple areolar complex with a cookie cutter. Whenever possible, I raise the flap by myself. Now, sometimes I can get away with this, sometimes I can't. Some breast surgeons want to do this themselves. Some say, yes, have at it. But if you raise it by yourself and you hold it vertically, you can get a nice, thin, even plane. It is important to preserve a small amount of tissue immediately behind the nipple that is consistent with the subcutaneous plane of the rest of the flap. This tissue gets sampled just to make sure that it's not involved with any disease. When we deepithelialize the pedicle, we use facelift scissors. Why? Because this is a more precise way to deepithelialize, and it prevents you from interrupting the subdermal plexus. Here's a video of the flap. You can see it's pretty thin, but if you look at the nipple and if you look at the rest of it, you can see it looks pretty good. It looks alive and something we can work with. This is a pre-pec patient, so I'm probably just showing the rest of the boundaries for the prepectoral space, and it occurred to me that I do the same thing as Mark with the subcutaneous tissue in the upper pole. This is another patient, similar flap. We use 2 drains. We put one high and one low. The lower one we like to put behind the flap just to make sure that it sticks down to the ADM. But because there's such a big area with this, we tend to prefer 2 drains over one. Perfusion imaging. I've come to rely heavily on perfusion imaging with this technique. It will show you whether the nipple's alive and whether your pedicle is going to work. It's very important to do your perfusion imaging after you've tailor-tacked the skin together. You want to create as much of a realistic situation as possible before you test the flap. So we tailor-tack the skin together with staples before we do the perfusion imaging. And as you can see in this one, the nipple lit up nicely. It actually doesn't project as well on the projector as it does on the TV screen, but the nipple is lit up and the flap is perfused. So here's the same patient, pre-op, after tissue expanders, and 3 months after exchange to implants. And you can see we got an acceptable result in an otherwise high-risk patient by using this technique at all times, knowing that we were safe, that we were not going to create a complication. Sometimes you have to make a tough call, and if the perfusion imaging shows you that it's a dead nipple, you have to take it off at the time of surgery. This can be challenging to do because we don't like to do this. The whole reason we're doing this is to save the nipple. But if the perfusion imaging tells you it's dead, it probably is. And it's okay. You can still get a decent result, come back, do a nipple reconstruction and 3D tattoo, and still get the patient to a good place. No, I gotta go back. Sorry. Okay. These flaps hold up in radiation as well. This is an example of a patient who we knew was going to get radiated on her left breast. So we did the IMF flap and a tissue expander, got her through radiation, then came back and did a delayed on the left and an immediate deep on the right with also an IMF flap. So you can see that this does hold up in radiation. I published my first series, I think in 2019 on this, now up to about 64 breasts. We've only had about 3 losses, and I'll show you 2 of them in one patient in a second. But partial nipple necrosis is very common. These nipples take a hit, they get stunned. You can have blistering, you can have superficial epidermal lysis, but for the most part, it's usually very limited and they do well. I did have to remove 1 nipple for a positive margin, and this is unpublished data. So pearls. We size the areola before making the cuts. If possible, you raise the IMF flap yourself. Leave a small amount of tissue deep to the areola, even with the rest of the subcutaneous tissue of the flap. When we image, we do the perfusion imaging with the skin stapled together. This will recreate the tension, and if you need to make an adjustment, you can do it at that point. Also, loosely inset the nipple areolar complex. You don't want to do a subcuticular or anything that's going to strangle that delicate blood supply. And the last one, no bras. This patient was doing fine and came in 2 weeks out with a bra that a neighbor had given her that she liked when she had her mastectomies and reconstruction, and it just strangled the delicate blood supply of the flap, and that was the reason for 2 of my 3 losses. But everyone knows now, absolutely no bras. So if you couldn't tell from this talk, I'm a huge fan of nipple-sparing mastectomy. I think it really does give us the best option to deliver a high aesthetic result to our patient. But it's not about just doing these cases. This is a chip shot, IMF approach, direct to implant, pre-pec nipple-sparing mastectomy. It's about doing these cases, taking a patient like this who doesn't have a particularly good beginning and giving them an acceptable result from their mastectomy that they can be happy with and that we can be happy with. So in conclusion, the wide-based IMF full flap offers nipple-sparing mastectomy for patients who are otherwise not candidates for it. The approach improved with perfusion imaging and allows us to greatly expand the candidacy in large ptotic patients. Thank you.
We'll take questions from the audience. Mark?
Thanks, Mark. Really impressive results with some challenging cases. At our institution, the breast surgeon, I don't think that they'd let us create that flap for one thing, but the other aspect that they do is they core out the backside of the nipple. They send a button of that tissue for intraoperative margins. Are you having to do that? Because it almost seems like a full thickness skin graft when they've finished that.
So to answer your question, no. I think if you cored out the nipple, this wouldn't work.
Okay.
You have to leave something behind the nipple areolar complex, but you can, take some of that tissue and send it off for either frozen or permanent, so that they'd be satisfied that, it's not involved in any disease, and if it is, you come back and remove it. So that's how I kind of bargained with them on this. I said, look, we're going to take a piece behind it, we're going to send it off. If it's good, it's good. If it's not, we'll remove the nipple. But we can't make this work if we invert the nipple and core it out like that. You can't work with those situations.
The nipple, when it comes back and there's no perfusion, you're looking at it on the table and you're deciding whether to keep it. Is there any role for then converting to a full thickness skin graft or burying it and seeing if it's perfused and trying to finish it off in clinic by bringing it out to the skin?
I think a full thickness skin graft is a good idea. I haven't done that yet. I've just removed them, but I think it's an excellent suggestion.
Mark, one question. It seems like I would be, especially with how careful you are with having the patient not wear bras, I wonder, do you find yourself doing less intraoperative fill when you use this technique compared to, when you do other versions of pre-pec reconstruction?
Sure. So I rely a lot on the perfusion imaging. I do underfill. I would say I put about 25% of the volume of the tissue expander in, but if the imaging didn't look good, I'd have no problem taking that 25% out and seeing if it made a difference. So I definitely don't push the envelope with the expander. Having said that, we have done this technique with immediate deeps and direct to implants. So it is possible. It all depends on who raises that flap and what the blood supply looks like.
I also have a question. Do you have a cutoff, a maximum length of your pedicle? For example, 20 centimeters if you have a very long pending breast.
Oh, so 20 centimeters from the inframammary fold?
Yes.
Haven't encountered that. No, I mean, I would not. So to answer your question, no, I don't have a cutoff, but I would raise the flap. I would see what it looks like. If it imaged well, I'd keep it. If it didn't, I would remove it, and I would explain to the patient ahead of time, you're not a nipple-sparing candidate. We can't do a reduction first. We're going to do everything humanly possible to save your nipple, and if we can, we can. If we can't, please understand it's just because your anatomy didn't tolerate it. But a free nipple graft, like Mark suggested, is an excellent adjunct.
Yes, thank you.
I have one more question, Mark. So you obviously based this kind of like a Bostwick inferior pedicle, but have you considered doing superior medial or other orientations?
The problem with the superior medial is you then have to twist it to get it up, and if you twist it, it affects the veins. With this approach, you can really put the nipple wherever you want it, and it is under zero tension. There's no mechanical manipulation of the flap itself in terms of twists and turns. So I really do prefer this over a superior anatomic approach.
Thank you.
Okay. So I would like to introduce the next speaker, who is Dr. Akhan from Slovenia?
Yes.
Yes, okay. Who is going to present how to achieve good long-lasting results in breast symmetrization procedures.
First, thank you very much, Fabio and Mark, for invitation. It's a great pleasure and honor to be with you today here. So I will speak about good long-lasting result in breast symmetrization procedure. Our goal, just to remind, is to match the size, shape, projection, and even movement of the breast in one single surgery. and to create a breast that feels and appears natural and respond as well to weight changes. And the first question is how to achieve good long-lasting result and avoid symmetrization procedures. So immediate autologous breast reconstruction is the best option, and we just fill the skin envelope, and of course also inframammary fold is present with well-vascularized adipose tissue as an autoprosthesis. We just exchange and replace like with like, and then the DIEP flap is shaped to, as called, autologous implant of the similar size and shape. And finally, we get appropriate shape, size, volume, projection, and preserve inframammary fold. And this is some of the result with good symmetry and long-lasting result in one single surgery that we can achieve. So 3 hours or 4 hours operation, and we get a fine result and avoid symmetrization procedure. So we can recreate breast of different size, shape, ptosis, regarding to patient wishes in one single surgery, but if our goal perfect symmetry or if our goal perfect result. So I think that our goal is perfect result, and also patient has a very high expectation nowadays, even breast cancer patient. And according to the literature, about 50% of patients underwent unilateral, let's say, symmetrization procedure, 2/3 delayed and 1/3 immediate, and revision of symmetry procedure was performed in 20%. And I agree that performing simultaneous symmetrization is a very feasible way to achieve promising aesthetic result and patient satisfaction. And this is a typical case. You can see here the ptotic and large breast, typical markings before surgery, and then breast oncosurgeon performed mastectomy according to our markings, and simultaneously we performed breast reduction, calculate how much tissue we need for from the DIEP flap, and then just performed so-called well-vascularized autoprosthesis of the new breast from the DIEP flap, and this is then the final result. So we have the same breast width and the nipple to inframammary fold distance the same of the both sides, and of course also the diameter of the areola. And here we have the result, so symmetrization procedure and reconstructed breast below. Similar case, so markings on the both sides are the same. This is the patient with breast cancer on the right side, and after tumorectomy or quadrantectomy on the left side, as I mentioned, similar procedure, we can get an optimal reconstruction with single-stage approach, replace like with like, and long-lasting natural result. So as you can see here, before, so breast cancer on this side, quadrantectomy on this side, and after one single surgery, we can achieve a good result. But still, we have plenty of procedure in delayed symmetrization procedure, so breast lift, breast reduction, breast augmentation, lipomodeling and lipofilling, and of course combination, and we shouldn't forget personalized approach. So sometimes just some liposuction and lipofilling and skin excision is enough, but of course we have plenty of different more complicated cases with comorbidity and previous surgery. So in this case we performed LD implant, lipofilling on the left side, and breast reduction and liposuction on the right side to get a good symmetry. Another more difficult patient, elderly patient with poor skin quality, we performed on one side mastopexy, and on the other side new pocket formation, new implant, inframammary fold formation, matriderm and lipofilling to get a good result. And also more complex cases, in this case 42 years old patient, reconstruction with implant failed, and patient come to my office. We start with scar revision, radical necrectomy, particles of silicone shell is removed, and we find osteomyelitis on the rib. So put some well-vascularized tissue of pec major into the hole, and after we performed reconstruction with LD and implant and nipple reconstruction and tattooing, and finally we performed direct to implant because of BRCA positive patient to another side to get a good symmetric result. So nowadays it's maybe better to talk about beautification procedure, not symmetrization procedure. This is one case from last month, 22-year-old patient with a huge benign tumor on the left breast. Typical markings. Before surgery, I removed the tumor, which was 15 centimeter in diameter, and this is the result 5 days after surgery. So symmetrical and more beautiful breast. Also, this patient came to my office with perfect symmetry, but very unhappy because of the poor aesthetic result. So after correction, we can get a much better result and happy patient. And we shouldn't forget to reconstruct the nipple and areola by tattooing to have a natural result and symmetry, good symmetry, and beautiful breast. So let's continue with statement of Blondel. He wrote some in the paper that recreating an aesthetically pleasing breast is combination of good measurements, artistic insights, and the experience of the surgeon that are very abstract and ill-defined elements. That's why we can find in the literature a lot of different methods of ideal anthropomorphic measurements, then stereological methods, geometrical methods, mathematical modeling method, but finally, in conclusion of this article, there's a statement that more objective breast evaluation can be achieved if all 3 dimensions are considered. So what to do in delayed breast reconstruction, how to restore breast volume and shape, how to achieve maximum symmetry in comparison to unaffected site when we have plenty of question mark about weight, volume, contour, projection, where's the inframammary fold position and location of the upper and lateral breast bow. So we use from 2009 3D imaging technique, and we also published the article in 2011, how to use 3D laser imaging and new breast replica cast as a method to optimize autologous breast reconstruction after mastectomy. And today we use Artec 3D EVA, and 3D image of the remaining breast is taken with 3D scanner. Then to design the replica of the contralateral breast, then we print the healthy breast replica, and then we use this mold for markings and tissue shaping during surgery. This is typical markings in upright position before surgery, and this is how we make a new breast in the replica, so the new breast is complete copy of the contralateral healthy breast. And this is few days after the surgery. You can see a very good symmetry and nice result. So let's continue with my personal approach, how to achieve good long-lasting result, best breast symmetry and best result. So if healthy breast is nice shape and volume and patient desire just one single surgery, first I perform 3D scan, produce a mold, and then reconstruct with a DIEP flap a new breast into the mold so we can get a nice result. Another case, another case, another case. So if the healthy breast is small and let's say empty, as you can see here, and the patient want to have a bigger breast, we can first perform breast augmentation and then scan of the new breast with the scanner and print a 3D mold and then continue with DIEP reconstruction, and this is the final result of first augmented breast and then reconstructed breast. If healthy breast is ptotic, you can perform mastopexy and then 3D scan of the new breast and then produce the mold and breast reconstruction finally with DIEP flap to get a fine result. If healthy breast is big and ptotic, again, first breast reduction, then 3D scan, and this is then the final result and symmetry and good aesthetic result. Also in bilateral cases, this is a case of breast cancer on the right side and after mastectomy on the left side. So we performed 3D scan of the right side and then reconstruction with DIEP flap, and again you can get a good final result, symmetry and beauty breast. If there's no opposite breast, you can use the mold from the database, or you just scan the implant or outer prosthesis and use then the mold for the breast reconstruction, and again you can get a good symmetry at the end. So the aesthetic outcome of autologous breast reconstruction with 3D technology remains stable over time despite BMI. You can follow the patient here, the changes of BMI, but still good final result. So in conclusion, every woman deserves the right to choose the reconstruction options, and modern medicine doesn't just aim for the survival of the patient, but also sets higher goals on complete breast cancer treatment and restoring the best shape of the breast, as well as the complete well-being of the patient. Thank you very much.
Thank you very much for your great results and nice talk. Are there any questions from the audience? Yes, please. Michael Sorotas.
Thank you for your presentation, Professor Aksan. In patients where you do a mastopexy, how long do you wait before?
No. Usually I wait about 3 months, it's enough. And in the meantime, patient can go through the diagnostic and CT angio and all the rest. You know.
Very impressive results. I'm interested to hear more about the 3D imaging technology that you use, and specifically about the mold printing. Is that something you do by yourself, or do you use a third-party company that you contract with to do that?
We started in 2009 and we use CNC machine, and it was quite complicated, and the cost was about 500 euro, what is high. Today our technician make with 3D Artex scan, and then we bought a printer of 5,000 euro, and now it costs about 4 euro per mold. And it's time consuming. It's about 8 hours to print, but it's ready. They just do print a day before surgery, and it's ready the next day, and it's very easy, and it's not time consuming anymore.
And the mold is sterilizable?
Yes, it's sterilized. And you know, the advantages is then I shape the breast into the mold. The other team just close the abdomen, and we are quite faster. About 1/3 less time we need for the complete surgery. So because we work simultaneously.
Thank you.
So I noticed, so obviously we've all done flaps, and it's just kind of a floppy blob. I would plop it in the mold, and I would think it would just naturally conform to the mold. But most commonly, I saw that you were taking out maybe a dart inferiorly. Is that what you typically are doing? Are you excising that and shaping it, or are you just, I was trying to understand.
You have also the video in Sami Mardini book, and I have also here a short video clip. If you want, I can give you on the USB key. I just put some holding stitcher, and I mark also on the flap for the positioning, because positioning is quite fast. We need maybe 2-3 minutes with the stapler to position according to the markings on the thoracic wall and onto the DIEP flap in the mold.
And you discard the skin of the thorax?
I excise everything. The lower pole I excise, as you mentioned many times today, especially in an irradiated patient, I just excise maybe 1 centimeter upper, because when we pull the skin to the abdomen, it go lower for about 1 centimeter, but I excise everything, yes.
Okay. One more question. With this approach using the 3D mold, do you find it just as necessary to sit the patient upright during the surgery to do the insetting of the flap, or do you not have to rely on that as much with the mold?
No, nothing. We just go, because we make markings and we have everything, all the data in the mold. We don't need any other data about the weight, about the width, about nothing. It's just the complete replica of the healthy breast.
I think I have to buy one of those.
Have you used this mold with other flaps, PAP flaps or
No,
S-caps?
usually I don't perform many PAP flaps. We performed, in majority of cases, 90%, we perform DIAP flap, and our successful rate is more than 99%. And we have series of 250 DIAP flaps without failure.
Thank you.
All right, we'll see if you're a good boy.
I'd like to invite our next speaker, Dr. John Kim, who's going to be speaking with the title, My Evolution in Soft Tissue Mesh Support. And Dr. Kim is a professor of surgery at Northwestern University Feinberg School of Medicine.
Great. Thank you to Mark, Fabio, and the rest of the organizing committee for the invitation. I spent about 6 years here in Houston in the medical center, so it's nice to be back. Some important disclosures I have, including being an equity and patent holder in Surgical Innovation Associates, and some book royalties from Springer. So why do we need mesh or ADM in prosthetic breast reconstruction? Some of this talk will be retrospective. It's looking at the past of what we've done in prosthetic breast reconstruction, looking into the present, and then also peeking into the future. And so I think it really revolves around a simple, almost geometric principle, something that Dr. Akan and Dr. Venturi both mentioned, volume, shape, and positioning. And if we think about the challenges here of a skin-sparing mastectomy, we'll note that we oftentimes have issues with this skin being removed from the upper part of the cone. And very early on, we realized that there was a interrelationship between the art of making a nice breast and the geometry and math behind it. This was a study we presented in or published in an obscure journal here, where we talked about the change in volume of a breast mound related to the amount of skin that's removed as a linear relationship, and we found that that's actually exponential, so that even a 0.5 centimeter difference in the width of that excision could result in a 20% or more change in the volume. So just understanding that from a pure volume perspective is important. This modeling also shows that when you lose that upper part of the cone, you're going to end up with a shape difference too. So again, that interrelationship between volume, shape, surface area is important. And so when we think back to what we had to deal with, so some of us remember what it was like to do reconstruction with implants and expanders when we didn't have ADM, and we were oftentimes restricted by the tightness of that lower pole, that it would prevent the optimization of shape and volume. We also had the offset of the inner and outer lamellae. For many of those who are training now, this is something so obvious. Of course, you want to bring that inner and outer lamellae together, but that's what we had to deal with before, and this offset of the IMF. So I think when we think about controlling that surgically now, we are able to use ADM and now mesh, where we're able to bring a coincidence between that inner and outer lamellae. And so the combination of a new technique and a new technology, we can still go subpectoral. And then we can also get that same approach now with the prepectoral approach, where we obviate the use of going underneath the muscle. But again, that may be dependent somewhat on the quality of the mastectomy flaps that we're left with. So I would say that in terms of evolution, we are able to get a reconstruction that looks like an augmentation in many respects. We're able to respect that 45-55 balance and ratio that Malucci talked about, all because we're able to control things more. And I think the value proposition for ADM and for mesh has always been the idea that we can position better, we can get lower pole expansion, and that preservation of that lower pole always equates with a more natural shape. So if we think back to what ADM offered for us and what the future could potentially give us, we're looking at something that allows for elasticity for lower pole expansion, biologic integration. We're looking for structural stability, and then we're trying to obviate inflammation, foreign body response. Those are related, but we'd like to have some resistance to infection, and then resistance to extrusion, capsular contracture, and then possibly most importantly for these evolving technologies is the issue of cost efficacy. So about 10 years ago, we looked at the experience of ADM very early on and compared that to a cohort of submuscular reconstructions. And even back then, we realized that having ADM could connote a higher risk of infection. We also knew that studies showed that there's a higher inflammatory response. These are multinucleate giant cells that we see in unincorporated ADM. And that sometimes if you don't incorporate ADM, that could in turn lead to things like red breast syndrome and hyperinflammation. So the reaction of the body to ADM, while rare, could also connote its own problem. So very early on, when I was using ADM a lot, we realized that we were getting quite a few seromas. And so we had this interesting experiment where we could look at the natural history of these seromas, because at the time, we don't know what we know now, and we don't try to evacuate those seromas right away. So what we found was when we left it alone, approximately 3 to 4 weeks is how long it took a seroma to occur. And then once we got the seroma, again, this was before we knew what to do with it, we kind of left it alone. And it took, on average, about 10 days for it to form an infection. But then once a seroma became an infection, it was generally about a day before it became obvious that we had to explant. So leaving seromas alone in prosthetic breast reconstruction with ADM, there's a 20% chance that you'll get an infection. But then if you get an infection with ADM and a seroma, then 80% of these will go on to lose their expander. So because of this, like retrospective study, we started being much more aggressive with seromas, and anecdotally all over the country, people came to the same conclusion that a seroma with ADM is something you have to work with right away. So what are some of the economic challenges for those of our people in the audience who are not familiar with the American healthcare system? You know, we have issues related to cost here, where sometimes using a pre-pec just on one side, we could be spending $10,000 in ADM alone. So the value proposition of mesh in the same setting of a similar size is that we could have a significant difference in cost potentially. So what are some of the non-ADM soft tissue supports available right now? Some of us had an experience with series scaffold, which I'll go into later. There are some longer lasting materials. I'll use their trade names just because I don't know what the hell this is. And P4HB, commonly known as Galaflex, Vicro, and PDO or PDS, which is what I have conflicts with. And when we look at series scaffold, a lot of us were excited by this because it was something that was off the shelf. It seemed like it worked well. The problem is when you got past this magic 6-month window, anecdotally, we started realizing that a foreign body, especially something that's woven, that's lasting in this hypovascular milieu of a mastectomy flap after 6 months, well, it becomes a foreign body. And you can have a foreign body reaction where you get extrusion, you can get infections as a result of it. And so the value proposition of using mesh in this setting, this is P4HB or Galaflex. This is something that I started using quite widely because I was looking for ways to obviate some of the problems with other forms of mesh. So this would be an example of a good mesh. If you think about seri as a bad mesh, this would be a good mesh. So this is how I would use it. Initially in reconstructions, in revisions, but then increasingly in reconstruction revisions, and then occasionally in primary reconstructions. And you'd shape it differently, but it's a little bit easier than ADM to cut. It's thinner, so you can cut it, you can mold it, and so when you're doing a minimally accessed incision, like through an IMF, oftentimes this had a distinct advantage because you could control the human factor or the form factor better. And so this is actually this is the same patient, and the reason we were doing this was she had an animation. This is a combination of animation and a double bubble, and then we're able to go prepectorally, and you can see at 1 month she's corrected that. So what's interesting though is this mesh lasts, P4HB lasts for 18 to 24 plus months. So I was curious to see what happens to it over time, and you can see some of the tissue stays, but actually at about a year, you can see that there still is a little bit of tightness there. So that's something to consider with these meshes is that, again, although they do have give, these monofilament meshes, depending upon how long they last, that could be something to think about there. The other issue with some of these longer lasting meshes is that, again, going past that magic Goldilocks threshold of 6 months, you start to potentially get issues, not commonly. So one of the reasons why we started looking at PDO or PDS was precisely because of this Goldilocks principle of getting in between a time point in which it's too soon. Let's say Vicryl goes away at 3 or 4 weeks, and then some of these longer lasting meshes will last for 2+ years. And what happens is that the PDO is ideally suited, I think, because it goes away before that 6-month window. The question is, though, when it goes away, what happens? Do you lose that support? And this is some histomorphometric analysis. And what you're seeing here is a long-lasting mesh. And the blue represents some of that soft tissue collagen fibers coming back. And you see that a lot at 1 year in this animal study, the mesh itself is dominating the kind of the terrain. It's all mesh, a little bit of ingrowth here. With PDO, it's clear and that by this blue, the prevalence of the blue, that the mesh has completely gone away and it's replaced with collagen. So that's possibly good in terms of foreign body reaction, but what is it like with respect to strength? So when you look at this, again, in an animal study done by one of my colleagues, Dr. Milad now, you could see that the strength of the actual mesh, even though it's gone away, is something that persists even in a comparable way to normal tissue and mesh that stays longer. The second part of this is, what about the foreign body reaction? So as most of us who use a lot of Vicryl suture, monocryl suture, PDS suture will note, there is more inflammation that you'll find with woven versus monofilament. So this is the example of that same PDO mesh. You can see that it lays in very nicely. One of the advantages of ADM is that it lays in very, very nicely, and I think this is something that's replicated here. This is that same patient, you get that lower pole. So when I look at the issue of infection, this is something that I find comparable amongst the short-acting and long-acting meshes. So PH4B and PDO both seem to have a less than 5% infection rate. And then this is kind of a comparison of what they can look like. And for the interest of time, I'll also say one of the other things we like about ADM is that when we're using it in prosthetic breast reconstruction, you can create a lamina where you can inject fat in. So the question is that something that you can do also with a shorter lasting mesh, either Galaflex or PDS? And it seems like, at least with some of these initial studies, we're able to do that. So in conclusion, ADM has been and continues to be an important part of breast reconstruction. There are lingering issues of cost and complications. I think looking into the future, as we experiment more with shorter and longer lasting mesh, there are some value propositions that may be interesting, and we have at least a couple of options on the market and more that are coming through the pipeline. Thank you.
Fantastic results, and it's nice to see results possible like that with a much lower price point product. Is there, what type of studies, though, are required to finally give some company a breast indication? Because it seems like the companies can't even be in the room with you when you're sewing these in, can't talk about it, can't be in an advertisement, you can't get clinical support, nothing. Yeah. And the FDA's been taking a pretty hard line on this. What's the answer, and is any company willing to do it?
Yeah, so that's a great question. So what we have in the United States for our kind of European colleagues, European and Asian colleagues, is that we've got a dichotomy between what we actually do in practice and what the government agencies, the FDA, allow us to do. So ADM has been around for 15+ years. It's now I would say the gold standard for use in prosthetic breast reconstruction, yet it is not approved for use in the breast. So I think for a long time, the FDA kind of basically turned a blind eye to this because they felt that this fell under a non-medical device exclusion. But now they're coming back and making it harder for companies to market. And I think what's happening now, from my understanding, is that a number of companies, probably in excess of half a dozen, are actively working with the FDA, trying to get an indication both for ADM and for some of these evolving mesh technologies. And my understanding is that that should be possibly happening in the near future. But again, I think from what I know anecdotally, there's a lot of ferment of interest on both on the part of the FDA and surgeons, as well as industry, to try to get alignment on this regulatory conundrum. But thanks for pointing that out, Mark. Very important.
Thanks for great results and great talk. I don't know if you're aware of the study, a randomized controlled study of bilateral cases came out from Sweden recently. So they randomized from left to right, biological and synthetic mesh. And they had a 10-fold increase in seroma formation in ADM compared to the synthetic mesh. Did you evaluate, the comparison? What's your opinion about seroma formation between these two?
So great question. So that study I showed kind of highlighted why seroma is a problem. The question is what causes seromas. I think when we look back on, like those of us who used to use, for instance, the older form of ADM, some of the alloderm that we had to kind of reconstitute in water, seromas used to be a chronic problem. And depending on how thick the mastectomy flap was and how resistant it was to that, the seroma rates published and anecdotally were in excess of 10%. But I think what we've done is adopted a kind of a lower profile, thinner ADM using fenestrated ADM, and that's decreased it. But I would submit to you that taking that to the next extrapolated level is not to have something that is made out of or antigenic from either xenografts or allografts, and to use something synthetic. So I believe that study, and at least in my own institution, this is something we've been seeing as well. But so I think that study is a great, where did that come out? In what
It came
journal?
out in JSO, Journal of Solid Oncology, last year.
Okay.
Yeah.
Great, thank you.
Hanson is the primary author, yeah.
Got it, thank you.
Thank you, Kim. All right. I have the honor of introducing my partner at work, Bert Loskin. So Bert is talking to us about a topic near and dear to our heart at our institution, reconstruction of challenging oncoplastic defects. He's going to share some experience with double pedicle, extended pedicle, and other fancy oncoplastic.
All right. Thank you, Angela. Thank you, Mark and Fabio, for the invitation. It's good to see friends again. So we've come a long way with the whole oncoplastic concept. We've learned a lot from our colleagues in Europe. Around about 2000, early 2000s, when Alex Munoz and I were talking about the general oncoplastic principles, we're now seeing a lot more data that we're looking at safety factors like imaging, timing, margins. But along with that, we're evolving in the technique, and I think that's important. I'm going to talk about that today. Where my evolution started was with the massive weight loss patient. Because if you look at a patient like this, you can see there's loss of volume laterally. There's volume where you don't want it, and that's below the inframammary fold. So that was around about the time when, Dennis Hurwitz and Peter Rubin were talking about the whole auto-augmentation concept. And I came up with a concept on my own, which was like a rotation advancement flap using a superior medial pedicle to correct such a deformity. And you can see in this illustration that we took the superior medial pedicle and extended it all the way down to the chest wall. So among the very many benefits to this technique was that suspension of the mound and the auto-augmentation of that glandular tissue. And you can get a nice result like that. So I looked at that patient, I looked at my lumpectomy patient, I said, those are fairly similar deformities, so why can't we use this technique for the lumpectomy defect? And when we recently, that was back in 06, 05, and when we recently looked at our series, about 33% of the patients, so it's a third of our patients who get oncoplastic procedures, have some type of auto-augmentation technique. There are two main types of auto-augmentation techniques. The first is that extended primary pedicle that I spoke about. The second is a secondary pedicle. So you use the secondary pedicle for the defect, you use the primary pedicle for the nipple. Here's an example of an upper outer quadrant defect, not a very big breast. We cut the standard mastopexy markings, and you can see the defects from the skin all the way down to the chest wall. And I basically mark out extended the deepithelialization all the way down to the chest wall. And at this point, I'm doing it exactly the same way I would do a mastopexy. creating medial and lateral pillars. Just instead of throwing away that tissue, you can see the defect up there, we're taking that lower pole skin and we're basically tucking it up into that upper outer quadrant defect. And you don't have to tack it in. It's not going to go anywhere. You close your medial and lateral pillars the same way. I haven't taken out any additional tissue. And there she is on the table with the defect filled, early result. And a year after radiation therapy, you can see that contour has been nicely preserved laterally. This was last week, and I have tons of these videos because it's just a fun technique once you start doing it. It's kind of like, you know, you do it the same way every time. I'm not going to show you a bunch of the same videos. So the second way we do it is the secondary pedicle. And this is typically for larger patients, such as this one. She has a lateral quadrant defect. There's the resection, a nice generous lumpectomy resection. My plan is superior medial for the nipple. And I'm looking at the defect, and I'm kind of playing around with tissue. I haven't resected anything yet. The reason I like two flaps is now I can put the nipple where the nipple needs to go, and I can put that secondary flap where that needs to go to fill the defect. And the Weiss pattern is a very powerful technique. We're all familiar, everyone here knows how to do a breast reduction. It's really, you can do a lot of things for cavities in the breast. What I like to do is just close what I know. So I know we're gonna have to close that. I know we're gonna have to move the nipple up. I know I'm gonna have to close it medially. I don't know what I'm going to do laterally yet, but it doesn't matter. I've done everything else, and now I can look, right? I got that tissue. I haven't thrown anything away. I feel my defect. I decide how much I need to put in there, create a nice little flap to fill the defect, and that's that secondary auto-augmentation flap. There she is on the table, and there's the kind of result you can get after radiation therapy. And then you can kind of get creative. I don't plan anything like this, but this is an upper inner quadrant defect. And instead of throwing away the tissue above the superior medial pedicle, what I'm grabbing there, we deepthelialized it, and that's nicely filling that medial defect. And you can start getting creative. There's kind of my go-to. Smaller breasted patient, pushing the envelope for breast conservation therapy. With that lateral flap, you can even preserve skin. So if the breast surgeon has to take skin, I've got skin on that flap that I preserved, and that makes for a powerful tool as well. And then you kind of, you know, I don't always go in knowing exactly what I'm going to do. You kind of look at the defect, and you look at what you have left. I've never really done something like this before, but it's an inferior pedicle that we just deepthelialized everything. Those medial defects are sometimes tricky. So we deepthelialized everything, and that pedicle that extended pedicle just dropped nicely into that medial defect. And sometimes it takes you out of your comfort zone a little bit. Like I never do a superior lateral pedicle, but this was a medial defect. Obviously can't do a superior medial, my favorite. So we did an extended superior lateral pedicle, and we just took that tissue from the lower pole, we plicated the medial and lateral pillars, and we took that tissue into the medial quadrant. And there she is after the completion of radiation therapy. The big question is everyone always asks, well, you're moving a tissue around. What are your risks of fat necrosis? You don't want fat necrosis in these patients. It increases the risk of biopsies. So we've looked at it. We looked at the oncoplastic regular versus extended pedicle versus secondary pedicle. And you can see down here the fat necrosis rate, symptomatic fat necrosis, is exactly the same. So really complications are no higher. So then you kind of, you get comfortable doing these little flaps, and you look at a patient like this, and I need to figure out how to avoid that skin necrosis. Sometimes it's unavoidable. You have thin flaps. You're closing them in Weiss pattern techniques. I did a superior medial pedicle for the nipple, and I spied it, and it didn't look great where it was thin. I preserved a little flap inferiorly. I didn't take it off, and that skin flap's going to tolerate radiation therapy so much better than a potentially ischemic flap. Another patient, we spied it, tailor-tacked it, spied it. It just didn't light up. Fortunately, I'd preserved that inferior flap, so we cut out that thin skin. We inset that vascularized flap, and there she is early on, goes on to radiation therapy. And this is the kind of result you can get with someone like that. Her 5-year results in the bottom right, and you can't even see that little secondary flap, but she has nice shape and symmetry. And when you get comfortable doing these kind of flaps, this was actually 2 weeks ago. The breast surgeon finished the lumpectomy, and she drew out that little V there. She's like, the skin's really, it's really close to the skin. I really want to take that skin. I'm like, sure, actually take that whole square, because I had in my mind what I was going to do. So that's the defect. When she was done, she took the skin. I had preserved a little square because in my mind that's what she took of mine. That's above the Wise patent markings. We basically did the superior medial technique the usual way. We took tissue medially, and now I'm just kind of tailor tacking it closed and just reshaping it. And you can see everything's there. I'm just visualized what she took and what I need to replace, and everything else should come together just like your regular breast reduction. And this is where it gets kind of fun. It's almost like freestyle, kind of oncoplastic, you know, almost like Mohs defects. You never really know what type of defect you're going to get, but you got a lot of tools in your belt that you can get it closed with. And then you just kind of bring the nipple in. So from expanding the indications to sometimes trying to push the envelope, and, you know, Mark asked me to talk a little bit about extreme oncoplasty. This is obviously not where you want to start if you're going to do oncoplastic surgery. It's one of those things that these are patients who most physicians would say, well, they need a mastectomy. But for some reason or other, they're not a candidate, or the breast surgeon doesn't want to do it, or the patient doesn't want to do it. They're the large tumors, more than 5 centimeters, very extensive DCIS, multifocal, multicentric, patients who ordinarily would have been contraindications for breast conservation therapy. A lot of this has been pushed by Dr. Silverstein, who's a breast surgeon. He's looked at his results, and you can see in about 66 patients with extreme oncoplasty, the recurrence rate, local recurrence, was not any higher than the standard oncoplastic, so saying it's safe. I haven't done very many of these. This was one of them. You can see a large upper outer quadrant cancer. There it is after the resection. It's a wide defect. You could probably have closed out primarily, but to me that would have just distorted everything. It would have pulled my nipple over, would have pulled all my Weiss markings over. I wouldn't really know what to do. I lost my kind of sense of direction there. So I just took, like I showed earlier, I just took a little flap from locally, and I used that to fill the defect, and that filled the defect nicely, and now I'm back to doing my oncoplastic like that case I showed. So I do a superior medial pedicle, I resect tissue laterally, and then in my mind I'm thinking what type of defect I need to fill, like a little piece of the puzzle to fill it. So now you're combining the flaps, you're combining the auto-augmentation techniques, and basically your nipple goes where you marked it and where you feel like it needs to go. And then the rest of it's just once you go from where you know to where you don't know, it just makes it so much easier. I mean, we're all familiar with tailor tacking, and this is just taking the tailor tack to another whole level. So there's the patient on a table, and there she is a couple of weeks after the surgery. You can see it's not pretty because it's got a bunch of scars there, but I think it's a nice result. She went on to get radiation therapy, and she's subsequently done well. So I think this is a technique that's very useful to have in your toolbox for correcting deformities and really for broadening indications for oncoplastic surgery. Your complications are not increased. You can use local flaps at the same time, and I think that's very useful. This freestyle oncoplastic is there for advanced school, not where you start, but also for advanced cancers. And I think it's good to know the various options. Thank you.
So Bert, we play surgical Tetris obviously all the time, but is there anybody you would absolutely not offer this to?
Well, if someone doesn't have enough tissue left over after they've done their resection, then I wouldn't. And a patient like that, big defect, you could probably have done a LD flap or a perforated flap to try to fill that. But to me, the morbidity of that's greater than this, and I don't think there's a lot of downside. Obviously, if the nipple doesn't look good and it's close to the nipple, I just take it and do an amputation. But for the most part, some of these patients do better than if you're trying to do a mastectomy and a reconstruction on these high-risk, large-breasted women. So from a cancer standpoint, I'll leave it up to the breast surgeon. my main indication, as long as they're a candidate for breast conservation therapy and they have enough left over, we can do something.
Hi, I have a question. I was wondering, how do you deal with volumes? Like, do you take into consideration the effect of radiotherapy on the volume, and how do you deal when you...
Yeah, so typically I keep the breast cancer side about 15% bigger. So I over-resect the opposite side in anticipation of radiation therapy. And that's if you get whole breast radiation. If you have intraoperative radiation, it doesn't really affect it that much, so I just keep those fairly similar.
I have a question about these like subtotal mastectomy defects or the extreme oncoplasty. When I have a patient that has a defect like that, I often start thinking about like buried Tdap flap or an LD like you just mentioned. I was wondering, in your own kind of personal algorithm, where do those types of techniques, the volume replacement techniques, fit into this type of reconstruction?
Yeah, so my whole approach has, and it's different from the European approach, but if I have a patient who think is getting breast conservation therapy and they need a LD flap or some type of flap to reconstruct a partial defect, I'm thinking, why not just do a total mastectomy? So I lean more along the lines of, if someone's going to need a flap, maybe they're a better candidate for a mastectomy. But if I can avoid a flap and use what's left behind, almost kind of spare parts type surgery, then I would prefer to do that. Obviously, you can't do that all the time, but if I can, I do.
Thank you.
So for certain types of cancers, we can get the radiation oncologist to do localized or partial breast radiation therapy. It would seem like with so much rearrangement of the breast that you would obligate to whole breast radiation therapy, or that it might change the radiation protocol based on that. Can you have any kind of discussion with the radiation oncologist or localize the tumor cavity, or is it any tricks to that kind of communication? Because sometimes I feel like I can get a great result, but I've just subjected this patient to more radiation because of my surgical decisions.
Yeah, so that's where it gets tricky sometimes. We have started using Bizorb clips, and I think that helps localize. The breast surgeon will kind of put it right in the pocket, and then I try not to rearrange the tissue. If someone's getting intraoperative radiation therapy, I really don't have a whole lot of great options. So whatever they radiate, and then they close, and then I just kind of shape it around there. I would like to do a study sometime at whole breast radiation, and if this is better and you get less dosing in homogeneity with the reduced breast compared to the large breasted patient with lumpectomy alone. So we do work together with the radiation oncologist, and we do clip the cavity as well, and that helps them with figuring out where to boost if they have to, or whether to focus the radiation. Perfect. Thank you.
So we're going to move to the next speaker, Dr. Ellsworth, who's going to present about the use of synthetic mesh in cosmetic and both reconstructive surgery.
Thank you very much. And thanks to Mark and Fabio for the invitation. Honored to be here with such remarkable speakers and panelists and moderators. Thank you. So mine will be a different approach than what you just heard from John, which I think will complement his talk well, I hope at least. Much of my life, like yours, is spent reconstructing breast with autologous tissue as well as implants. And I've really enjoyed innovation in plastic surgery and enjoyed the idea of mesh and technology and support in soft tissue. As we learn more about large implants, and everything is indeed larger in Texas, the stress on the soft tissue envelope becomes more and more of an issue. So we'll talk a bit about that today. These are my disclosures, none of which are actually relevant to my talk. The problem that we face, and I argue in both cosmetic surgery as well as reconstructive surgery of the breast, are similar. And in reconstruction, we have a loss of landmarks. Often the IMF can be lost at the time of mastectomy. Medial breast can be lost. We have implant malposition over time, especially when implants are large. And most importantly, at least in my mind, is loss of pocket control, which in my opinion leads directly to rippling and implant malposition and general dissatisfaction in the reconstructive world. In cosmetics, sorry, this is going slow. We also have loss of skin integrity, and that's the patient in the upper part of your view. And the impact of large implants over time on the breast can be really powerful. I also think that the impact of radiation on tissue expanders and implants, like you see in the lower part of your picture, can cause a dilemma and a challenge for plastic surgeons. Trying to make the other breast look like that breast is very, very hard, if not impossible, without use of technology. Animation deformity is something that plagues all of us. This is a patient who self-referred to me with this deformity after mastectomies and implant reconstruction under her muscles, and it's something you and I see almost each and every day. These are the happiest patients when you simply switch them from the subpectoral pocket to a prepectoral position, but control of soft tissue becomes an issue there too. And so I think the summation of all of these different points really is found in the loss of soft tissue support and, of course, pocket control. And I think that's where synthetics are going to find a really important home. Traditional ADM, and to be honest, I use ADM every day in the operating room. Traditional ADM has excellent data. And like John mentioned, we've been using it for 20 years plus in breast with excellent results. We have a growing cohort of data in direct-to-implant and, of course, in prepectoral reconstruction with ADM. And I'm a firm believer of a two-stage breast reconstruction, at least in my hands, with a prepectoral coverage of ADM, offers the support needed for many patients, and of course the coverage and reconstruction of many lost landmarks during the time of mastectomy. This is a patient that I think is an ideal candidate for a nipple-sparing mastectomy and often direct-to-implant reconstruction. Sadly, in my practice, I'm rarely left with flaps that can afford an implant at the same time. So I try, and it doesn't always work. This patient got a two-stage reconstruction with an IMF, prepectoral total anterior coverage with ADM. And I think perfect no, but a reasonable result with use of ADM alone and a long-term support that she needed. What I've found is that without support, as the implant descends, we see more problems, and sometimes ADM just isn't enough. And this is an example, and sadly, I'll admit this is my own patient early on, and believe it or not, that initial picture's under the muscle with ADM, and then long-term follow-up in a woman who was too thin for an implant of this size, and despite the fact that she wanted this large of a reconstruction with time, no matter what, this soft tissue descends. And in my opinion, that descent leads not only to the uplifted nipples, but really the rippling and the severe deformity in the décolletage, which is hard to fix, even with fat grafting, and I think even with highly cohesive implants. So what synthetics are there, and what can they do, really is the beef of what I've been assigned to chat about. And these are the two synthetics I have the most experience with. Like John Kim, I was on the Sari scaffold trial, and that's where I really found a passion for synthetics in breast. Sari certainly had its challenge, but I think in its heart it was well suited for reconstructive and plastic and cosmetic plastic surgery because it supported the tissue well. And that's what you'll find in both Galaflex and Durasorb. They behave very differently. So Galaflex is P4HB, which is a monofilament that, the company says lasts about a year, but in all honesty, I think it lasts 2 years, if not a little bit longer. And there's a growing cohort of data supporting its use in reconstructive and cosmetic surgery. And Durasorb is newer to the market. So I would say that there's less data, although there's several reports that have come out in the last year. It's much quick to be absorbed. It's PDS, so just like we close the abdomen with, right? It's about 9 months. So there's different dynamics going on, and you can utilize them in different ways to create breast. This is an industry side, really just meant to show you the degradation of Galaflex over the course of a year. Like I said, in my opinion, I've gone back for various reasons at 2 years, and you can still sort of see the Galaflex there. But what's important in this slide is to realize that during that time period of absorption, collagen is being created, and collagen type 3 is being replaced by collagen type 1, which of course is what we want in support. This is a case, a lovely lady, obviously cosmetically conscious because she's had an augpexy before, sadly diagnosed with right-sided invasive ductal carcinoma. She has a history of an augpexy, like I mentioned, and is planned for mastectomies. So we did a nipple-sparing mastectomy through an IMF approach. I used 2-stage for her, TE, total coverage with ADM, and then transitioned her to an implant and fat grafting, much like all of you would do. She was happy, and then she came back 9 months later, and she was less happy, And of course, she's lovely and works out at my gym, and so I see her all the time. And you know, she was never, you know, openly disappointed, but you could just see it in her eyes, right? This young woman is simply not acceptable, and we should be able to do better for her, right? This rippling is bothersome both in clothes and in the nude, of course, and so it's an issue. So what can we do to fix it? I've already done fat. There's no more fat on this lady, as you can tell. So I don't really think that fat's the long-term answer. Support is. What I'm showing you here are two intraoperative pictures from her case. The upper picture, the nipple is sort of where my thumb is, and you can see the IMF where I've sewn Galaflex from 3 to 9 o'clock in what I call an internal bra technique. Really, it's used to support the lower pole of the breast, and then I suspend it over the permanent implant to the mastectomy flap. In the bigger picture, you see me having already suspended the right breast and showing you the difference between her right breast with Galaflex and the left breast. We can all create that on the table, right? The real question is what happens a year later. And happily, after this internal bra technique without additional fat, because I really couldn't get enough, this is her breast reconstruction with a long-lasting result with the support that I think these thin-skinned individuals need in reconstruction to avoid rippling of the décolletage. And again, her pre-op picture after my initial attempt, and then with the Galaflex internal bra technique. I enjoy using mesh in cosmetics too. We often see these patients, all of us do, congenital asymmetry in the breast. They want to lift, they want to be more symmetric, and they would like some upper pole fullness, but they don't want to be bigger, right? And they want it natural. They want all of those things, and you know, if your wand is like mine, it's relatively broken, and those things are not possible all at the same time. Well, I think you can do a relatively good job of achieving all of that when you consider using mesh. The reason mesh is important is, you can see I've done basically a standard reduction lift. I've made her even, but I've used the mesh at the lower pole of the breast in the internal bra sort of position. And then a long-term follow-up in her will show you, I think, what is achievable when you use mesh in a mastopexy that isn't when you don't. And that's this little bit of upper pole fullness. You know, this is what the women want without being bigger, and I can't create that, at least in my hands, with a mastopexy alone in the long term. And so I found that mesh is very useful when you want that bit of upper pole fullness in the nude as well in a bra. Durasorb, like I said, is very useful. It comes in sheet form, so for me it's more of a cut as you go, and it lasts approximately 6 to 9 months. This is another case example of where I found Durasorb to be very useful. Right-sided breast cancer, underwent a mastectomy and post-mastectomy radiotherapy and a tissue expander here. In my hands, I reconstruct these radiated patients with autologous tissue because I can at least produce a better long-lasting result for them than implants in my experience. And so she underwent a relatively standard 2-perforator deep flap. Reasonable result. She wanted to be smaller and perkier and, of course, reduce the other side of the breast. The challenge in these patients is not the reduction and the lifting. The challenge is the fact that the radiated skin is going to sit exactly where you put it forever, and the other side won't. And then they will come back and say, can you just radiate the other side? Because I really love how perky my radiated side is, right? I think we've all been there. So I've found that actually mesh, and I use Durasorb in this case, is useful to suspend the natural side. And what I did in her was a standard reduction lift on the deep flap side and a reduction and a lift on the contralateral side. And I used Durasorb mesh to give this long-term follow-up where you see in the lateral picture a supported breast, almost as if it's got a bra on it, right? It's not descended like all of our reductions would have descended by this 2-year point. And I find this mesh, and I agree with John Kim's thoughtful comment, if you flatten the mesh and make it too flat and expect it to give, it's not. And that's where you really have to think about how the dynamics of ADM are distinctly different than the dynamics of mesh. And that obviously takes some time. So these are my kids. I have 3 of them. Isabel's the 6-year-old on the right. Warren is the crazy one on the far left. And then Eloise is the 1-year-old in the middle. And when I come home from work, my job is to entertain them and read them books. And so I come home and every time I read Goldilocks, I think of these 3 meshes. And that's, you know, weird, I realize, but it's just how our lives dominated by work. And so, you know, you think about, well, which of these porridges is perfect? I would argue that there really isn't a perfect porridge. There's not a perfect mesh. I think that there's really many times where one mesh is more ideal than another. And I'll use the ADM example. I still believe, at least in my hands, that a two-stage reconstruction is, ADM is beneficial there because I want the stretch. I like the stretch. With mesh, I don't want it to stretch. So it seems almost unnatural to use a mesh alone in a two-stage pre-pectoral reconstruction. With secondary cosmetic breast deformity, I want nothing, I want the opposite of stretch. I want support. When implants are big, I want support. And so that's where I go to meshes like Galaflex and Durasorb. And I would argue that Galaflex is sometimes a little overly engineered for perhaps just a simple cosmetic mastopexy or an initial aug, and Durasorb maybe is a little less engineered for an 800cc implant with very thin skin. So those are ideas as to when and how I choose these meshes. So in summary, I think loss of pocket control and support in both cosmetic and reconstructive breast surgery remains a challenge. Newer technology like Galaflex and Durasorb, in my opinion, has really allowed us to create this internal bra technique that addresses these really remarkably challenging reconstructive and cosmetic patients that we see each and every day. I don't think it replaces ADM. I still find ADM very useful in two-stage reconstruction for a host of reasons that I've outlined. And I've even transitioned to automatically putting synthetic mesh preemptively at a second stage when implants are 600 cc's or more, and especially when I think the soft tissue coverage is compromised. In addition, and this is a whole nother talk, I've given consideration to using synthetic mesh to make these smooth implants a little bit more textured in their ability. And what I mean by that is putting them in, wrapping them in a mesh, and then they stay where you put them. And so I find that also exciting and interesting. John already covered the infection point, so I'll leave it at that, and thank you very much for your time.
I have a couple of questions. Great talk, awesome results, really enjoyed it. You know, with certain implants, especially with the more cohesive, more projecting varieties, we see implant flipping, not infrequently. And I'm wondering, do you have any experience using these longer lasting synthetic meshes to tighten the pocket to help prevent that from happening in a woman that presents to you with that as their complaint?
Yeah, sadly, I have a lot of experience with that because I, like you, have found that implants that are 600 or more cc's in size and projecting full or extra projecting will tend to flip. And it's all about pocket control. You know, obviously I underexpand and then squeeze in the implant, which is one way to prevent that, but no matter what, sometimes they do flip. I go back and I always use a synthetic mesh. And I have found that both are useful. I think it depends a bit on how much coverage you need, honestly. The Durasorb piece is nice and large, and what you can rebuild is the fold in the lateral breast with that. The Galaflex piece is a little bit smaller, the ones that I choose, but stronger, and so I use that in select cases too. But that's really, in my hands, the only way to fix that problem. Yeah, other than downsizing, which nobody wants to do. Yeah.
Sorry, I have another one.
Please.
Have you implanted synthetic mesh secondarily in a woman that has previously had alloderm or some other type of acellular dermal matrix, and how do those two meshes interact with each other?
Yeah, many times, and you saw, I think, at least one example in the talk where alloderm was first used and then synthetic mesh. I have had no real issues other than, I mean, I've seen, like we all do, the alloderm incorporated. If it's not incorporated, I cut it out at the second stage. When I've gone back to put in mesh, or if I'm putting mesh in at that time, I do it just like normal, and I don't use drains, and it simply incorporates with time. I've been very pleasantly surprised, like it's been alluded to in other talks, for the lack of seroma formation with these synthetic meshes, and I put it right on alloderm and don't have an issue.
Thank you, Dr. Ellsworth. For the interest of time, we'll move on to the next session.
Thank you very much.
All right, so I think our next speaker, we have Dr. Trignano. I'm sorry if I botched that. We have porcine ADM in one-step breast reconstruction, his institutional algorithm coming to us from Sardinia.
Yes. I want to say thanks to Professor Santanelli and Professor Clemens to invite me. For me, it's an honor. And today I want to speak about pulsing a cellular dermal matrix in one-step breast reconstruction and institutional algorithm. It's not working?
Click really hard. Just the, yeah. There you go.
Oh, sorry. Okay. Like everybody know, the gold standard for breast reconstruction before pandemic were tissue expander or implant, definitive implant, back prosthesis, free flap, and breast reconstruction with the Braxton or ADM. After 9th March of 2020, the breast reconstruction was stopped for 4 weeks in order to save operative time for breast demolit surgery. We became a COVID center, and we stopped to, we don't have the chance to perform breast reconstruction. We resumed in the late April in 2020, and in this way, it was an unreliable increase the waiting list to the second stage of reconstruction and for replacement to expander to prosthesis. We have a persistent context how to perform breast reconstruction. In general, we think that two-stage breast reconstruction lead to better result, but we perform a new paradigm because we needed the possibility to perform immediate prosthetic breast reconstruction and controlled mammoplasty in one stage. The shortage in the theater time and development of an innovative prepectoral reconstruction technique with ADM led us to modify our algorithm for alloplastic. Our algorithm, it depends because we have increase of number of patients needing breast expander replacement, COVID-19, and OR time reduction. But at the same time, we have innovative surgery technique which allowed one-step reconstruction. Add with the increasing waiting list, we need immediate reconstruction in one stage. We made our algorithm to perform the breast reconstruction. We have absolutely contraindication. We don't usually perform to BMI more than 40, smoke more than 40 cigarettes per day, DM non-control, radiotherapy after surgery, vasculitis or collagen disease. But we decided to make a scale to have a relative contraindication, but we usually give 1 point to age more than 70, 1 point to BMI between 32 to 34, BMI between 35 to 39, 2 points, smoke less than 20 cigarettes for daily. And you can see that for every kind of this defect, we usually give 1 point. Only for BMI between 35 to 39, we give 2 points, and to the jugular nipple distance, more than 30 centimeters. If we have the score more than 4, we don't perform directly prepectoral breast reconstruction, and we send it to delayed reconstruction. At the same time, you can have this kind of algorithm pre-operative room, but in the same time, when you usually do prepectoral prosthesis with Braxton, you need to check in the same time in intraoperative room, because you need to check 2 things. Breast weight, we don't usually perform Braxton and prepectoral breast reconstruction if the weight of the breast is more than 500, and we need to check skin thickness. If it is less than 0.8, maybe 0.6, we don't usually do. In this way, we usually change to Becker's prosthesis if the weight is more than 250 grams, and submuscular prosthesis if the weight is inferior to 250 grams. In our center, now in this time, we usually perform almost all the cases with the breast reconstruction with ADM. Which ADM? We usually pre-shade porcine matrix that we usually fix over the pectoralis major muscle. This is the result of experience matured in tissue bioengineering laboratory and clinical practice with the intention of creating an operative technique as most conservative as possible. This kind of shell is thick like 0.6 millimeter and has a lot of indication. It's good for skin or nipple-sparing mastectomy, in breast size up to 500 grams, in subcutaneous tissue of 1 centimeter, in BMI under 35. You can have very good result in pathologies like poliomyelic or Poland syndrome, but have a contraindication in heavy smoker, in comorbidity like diabetes, hypertension, obesity, in psychiatric disorder, previous radiotherapy or radiotherapy closer to the surgery. But I have a lot of advantage. Reduce operating time. If you are if you can do, if you have a lot of practice, you can do this kind of surgery during the mastectomy. You can have only single hospital stay because you need to change the expander. Reduce recovery time. We usually send them to home the day after. Leaves the pectoralis major muscle intact. You don't have animation. The patient have less pain compared to submuscular implant, and it's economic saving for the company, and you can have more natural breast shape, reduce the incidence of a capsular contracture, possibility of post-surgical radiotherapy, a possibility to use smooth round prosthesis. You don't have this location because it's inside of the shell. It's very difficult to find one disadvantage of this kind of technique, but I really think that the only one is you need to remove the drain before the 12th day because you need aspiration, not because you are scared about bleeding or seroma. I can show you how can I usually fix and I can usually use this kind of shell. Like you can see in the first picture, you can see that even you use a round, smooth implant, you can have anatomical shape, and I really think that there are a lot of technique to fix this kind of ADM. The Braxton always recommended to use pre-tight stitch. Many surgeons usually say that it's good to use pre-tight stitch because maybe if you have a nipple-sparing mastectomy, you need to do pre-stitch. In my practice, I usually just pull with the 2 fingers down the matrix and start to stitch from ADM to the pectoral majors. You don't have one exactly number of points, but I really think that you need to stitch as much as possible because it's very important that Braxton don't move, don't move, really stay fixed to the pectoralis major. I usually fix in the upper pole, I usually fix in the medial pole. Like I said, more is fixed, more there is a possibility that move not make seroma, and for this reason I usually put another stitch to the dentatus fascia, and I usually check if there is any hole with the axilla. If you find a hole, you must close because there is you need that you have no communication between this. I usually do recentation of the wound borders, and you don't need to do like 1, 2, or 3 millimeters. You need to remove until you see bleeding the both flap. And at the end, I usually fix even above the ADM. I usually pinch with the forceps, pass through with the needle, and stitch dermis, Braxton, and dermis until I will close. I don't usually remove the drain until the 12th day because you need aspiration. You usually put 2 drain. We always advise to patient to don't mobility the arm for 30 days, use bra and brand at least 3 days, and absolutely rest for 30 days. In our experience, we did 100 prepectoral. We performed 182 immediate breast reconstruction when staged with the symmetrization. This is the rate of the complication with loss of implant. Unfortunately, most of the loss implant were Braxton because you can think that it's a very easy surgeon, but in the same time, it's very easy to lose the implant. I can show you some cases just to tell you that you can perform in every kind of patient, like in these cases with the contralateral symmetrization is the best result if you can do in bilateral nipple-sparing mastectomy. In these cases, even if you have a medium-sized breast, even you have ptosis, you can perform good symmetry. You can look, this was a kind of cases that was over 35 BMI. For the reason I have a problem to the chance and necrosis, I needed to go back in OR, but after I have a good result the same. This is another cases with the contralateral symmetry. We want to just do the study to understand if alloplastic breast reconstruction was better than two-stage expander implant. For the reason we fill into breast reconstruction module pre and post-operative scale question, just to understand the psychological well-being, the sexual well-being, satisfaction B pre and the post-operative appearance on the breast. And like we show the result, we can see that the result was statistical significant. And according to our data, the analysis of a questionnaire shows statistical better outcome for most domain in patient in one stage group, probably because less time to obtain a final result, no stress related to any further surgical intervention, less centers in the hospital for filling procedure, more natural result, no breast animation deformity, we don't perform, we don't go under the muscle, no problem relating expansion, we have a pain reduction. This kind of a patient has like no patient. I want to conclude, I'm so sorry. We want to just tell you that the pandemic emergency accelerated what can be considered a paradigm shift in alloplastic breast reconstruction. I'm so sorry if it was long.
Thank you. Any questions from the audience? No? Okay. We'll just, for the sake of time, move on. Thank you so much, sir. All right, our last speaker, last but not least.
Sure. This is Dr. Lumenta, who's going to be speaking about reduction, mastopexy techniques, and evaluation of outcomes. Thank you.
So thank you very much. Thank you, Mark and Fabio, for the invitation. I'm quite honored to be in such an established and high audience. So I'm actually the outlaw in this session, I suppose, because I'm talking about taking implants out and not even using meshes. I have no conflicts to disclose. If there are more than some, take any number techniques described, most of them yield comparable results, and depending on their follow-up, they are actually quite good. But there's a trough of unpublished experience somewhere outside the peer-reviewed sector, especially in colleagues which are entirely working in a static sector. So what we know when you talk about evidence-based medicine or versus real-world data is an opinion decision based on the currently available information. And the evidence we have is actually, compared to the real world or the number of operations, which is actually there, is very tiny and very small. So what I call a publication bias is that if it's not novel, it's very unlikely to get published anyway. So I'm talking about such a topic. And I'm just presenting you a personal approach to that. And it's just an invitation to take a different look at different steps. So when you look at the classic reduction mastopexy patient, different demands, then there's the initial assessment, which is really important, planning technique, and then you evaluate, which is the main part of this topic. So demands, I'm not saying anything new. This is augmenting breast hepatophore impetosis is something you have to look at. do you want to use an implant or even take or change implants out? So during the initial assessment, something which is really important is the breast footprint, as Elizabeth Hall-Findlay called that. It's something you can't really change when you perform mastopexy or a breast reduction. So in this type of modification, you always have this breast space which you have to work on. There's a grade of ptosis, and then there's a gland to fat tissue ratio, which is important probably more for reimbursement reasons in our country, because if you've got a resection weight per breast above 500 grams, which applies to most of European countries, you get it reimbursed and is among the public system. So it's possible to get this reimbursed. Then there's a length of plant neck transposition. If you do pedicle or free, I probably do all of them pedicled if I can. And then there's a pre-op diagnostics, family history of breast cancer, which involves MRI and ultrasound or possibly a mammography. Then there's timing, which is important. So patients who are still planning to have kids and so on, I try to consult them not to have that operation before this. So and just wait. And then the other thing which is really important to tell patients that they have a planned or ongoing weight loss to delay that operation until that the weight is quite stable at that time. So the initial assessment when you see a patient is the time for deciding if you want to have a prospective parameter selection. I say this because I'm working with some of the aesthetic colleagues, and some of the data is missing at that time point, and you can't really re-evaluate later on. And so it's really important to have this for follow-up. So if you do not assess this, you don't have any control group. Planning techniques. So I perform my landmarks in a standing position, sternal notch to NAC, new NAC, submammary fold. I prefer an inverted T incision because it's very hard to control redundant skin and the scarring later on. So I get more stable results with an inverted T, even if it's a smaller one. And it's probably not such a big issue with Caucasian patients. It depends on if you've got Asian patients or Fitzpatrick 5 is probably the right description to that. And other patients. So the pedicle for the gland and the NAC, again, is different, and they are all variants from superior medial and take anything in between what you want. So it's possible. Probably what is really important to take the least distance for transposition, which is the important part, which pedicle you choose in the end. So in different types of operations, you just have adjuncts, some type of liposuction, or you address other body region at the same time. Post-op, I prefer to use no drains, and the compression grommet is probably what you call an augmentation bra, is the same. So for the markings, actually this video is 3D, but it takes too long. It takes more 30 seconds to show. I just say, yeah, it's nothing new probably for most of you, but the only important thing is in the upper right part is I mark the height of the patient and the weight at that moment. I do this all the time because it's really important to see later on what's going on with your results. So incision for mastopexy. So I tack this during the operation, and the lower right corner, you can see that if this allows you to see the amount of reduction where you have to perform in the lateral right part, because this helps you planning the reduction a bit better. For a mastopexy, I perform a superior pedicle for the NAC and an inferior bra, inner bra, for let's call the auto-augmentation. And this looks like this. And you can tack it together, but I usually don't do this anymore because the form is more stable if you don't do anything to it. And then you just close and have this as a result during the operation. In some cases, patients do request or have required implant removal, and in this case, I perform it on block resection, which is nothing but a fixed volume reduction in a patient. It's just the same as a breast reduction. And so looking at the evaluation, so it's this NCOF, something I teach to medical students or trainees. So it depends on when you look at studies, for example, what is your case number? Have you got a control group at all? What is your outcome? What are your outcome parameters? And how long was the follow-up, actually? So everyone is the best surgeon if the follow-up is during the operation in the operating theater. And other factors, which include sensibility, form, ptosis over time. So the patient-reported outcome measures, and I call them just the surgeon-reported outcome measures, good or bad. And then there are more objective ways, so weight, height, 2D, 3D imaging before, after, 2-point discrimination, which I haven't done in the end, and complications, which I want to talk about today as well. So the breast Q has been readily covered, and there are readily covered publications about the breast Q and the reduction and the improvement in the physical well-being. 3D allows to assess the volume, and you can actually perform volume calculations using digital segmentations, like filling in the hold-out form. It's a bit like a water displacement method, just in 3D, to assess the volume. It's good for pre- and post-op evaluations, but it probably doesn't help you much for the operation itself. Evaluation pitfalls, I've mentioned some of them, is the weight loss and gain is really important to regard. There's a timing of when you perform these patient-reported outcome measures, when was a follow-up and complications, sorry, I mentioned this. So major and minor is in the eye of the beholder. So a complication is probably better defined not on its definition itself, but its resultant management is key. So the intervention itself required to treat that very complication. My favorite example is a hematoma. So it's bleeding and you take it out, take a stitch out, it's fine, or you need to use full blood in order to replace that patient, or you take him back to theater under local, or you take him back to theater under general anesthesia. Oh, this patient even requires intensive care afterwards for whatever reason. So some of you who know what I'm talking about, I'm referring to the Klavian-Dinder, or the Comprehensive Complication Index, which is something which has been published in 2004, it's already been used and installed for general surgery predominantly, and is something which has been more and more published. So grade 1 is basically any deviation from a normal course, which includes small wound dehiscences, little wound infections. And grade 2 is where you have to use pharmacological assessments. Grade 3 is taking back to theater, either with or without general anesthesia. And grade 4, other life-threatening complications, using even the assessment, the facility of the intensive care unit. So we have analyzes in our divisions and try to standardize the complication rate after breast reduction. And just to make it brief before dinner, just look at the black curve, and this is the probability on the y-axis of being complication-free, and on the x-axis you see the resection weight. So the probability of having less complications, obviously, so this is nothing really new. You would expect this for duration of surgery as well, single-dose antibiotics, or if someone is a smoker. So why include this for evaluation? Because it helps you assess the influence of complications on the patient satisfaction if you use this, for example, together with PROS. So standardizing any undesirable, unintended, and direct result of an operation affecting the patient, that's the proper definition of a complication. So understanding data which was normally not perceived as a complication. So, and this is really useful, and this is what our idea was, to have a future more personalized, informed consent based on the complication rate within your particular division, unit, or your private practice. So this is a grade 1 complication. This patient had a viral allergy, and you had to take out virtually all the subcutaneous tissues over time, which is really painful, as you might know. I have had 2 patients in the years who have done that, but it's really, really something. So from the pictures, you probably wouldn't say there's a complication, but that's something you have to consider. I just give you some cases and see. So this is a patient who had an excellent augmentation mastopexy. There were 250 cc's in per side, and I performed an en-bloc resection, which a bit looked like that, and performed what I showed you before, the inner bra, which is the inferior pedicle, and the superior pedicle for the NAC. And this is the result after the operation. This is an early result. This is about 6 weeks out. And just 2 more cases quickly. And which is really important, is a 6-week result, and this is after 5 years. So it's what I said before, looking at your own follow-up, how long you look at patients, and how stable you think your results can be over time. So take-home messages if the patient, the volume, the expectation of the patient matches the volume of the existing breast, then you perform mastopexy. The implant is, when you remove it, is a fixed volume reduction. I've talked about all the other things before. Preferred incisions. Drains indicate but do not prevent hematoma, so I prefer not to use them if I can. And about the results, so it's probably really important to have a different look at some things. Consider the weight changes when you evaluate patients, especially mastopexy, and think of grading your complications differently. Thank you.
Great talk. Thank you, Dr. Lumenda. For your en-bloc resections, talk us through the pathology evaluation. Do you send it for pathology? What do you send it for evaluation for? If it's a suspicious case or if it's just a general case, is there any difference in your algorithm?
Actually, there's none. So if the patient hasn't presented with anything in particular, I just think if you take out all of the capsules, some patients might have internally ruptured the implant, so it's easier to take that out, and it helps in wound healing because you don't have a wound surface which has been created by the implant, which might trigger seroma, etc. So I take them all out, and they all send to pathology. This is probably a European thing, medical legal reasons. So they all send to pathology.
Any questions from the audience? I think we're going to wrap it up. Just a reminder, we have shuttles picking us up for the faculty dinner, I believe at 6:45 outside for those attending the dinners. Everyone else have a good night. See you tomorrow.
Let me give you an information before you go. First of all, thank you very much staying until late. You are the hero of the day. But I would like to give you some information about this kind of hybrid meeting with online registration and online audience. So can I have the first slide, please? So just to let you know how many people attended together with us. So we had today 920 and half, because it's my son, that one, following the father on the different IP addresses, so almost 1,000. And this is a growing trend compared to last year that we had the meeting in Rome. The next, the transfer to gala dinner, as was said before, it's 6:40 from the lobby, and that's the address of the restaurant, served by Wolfgang Puck. So the last I want to tell you, tomorrow morning we will start 8:45 with the breast augmentation session, Europe versus United States. It's going to be very interesting. And after that session, we will go with the fourth World Consensus Conference on BIA-ALCL. It's going to be a very important conference. I promise we will deliver important answer that we were waiting since a long time. Thank you, and see you later.